Good, good morning, everybody. Welcome to the second day of our 2022 KRSSDI Diabetes Summit. So today we'll start in this Hall B with the oral presentation by the our candidates, and we have a jury to assess them. So I request all the presenters to be around here, and if any of them have presented the same thing as a poster, please just inform us before, so you'll be given the chance last. If you have not presented, your oral presentation will be taken up for consideration. So I think we'll start with Dr. Jaishankar.
Good morning, everybody. I think we are all set to set the dice rolling. So before we start doing that, I think we will just speak about the ground rules with the permission of Sydney sir. Sir, we'll give a time of 6 minutes plus 2 minutes for question answer session, and we will be judging them based on concept and method, timing, impact. Okay, 7 plus 2.
7 plus 2.
7 plus 2, no problem. 7 minutes plus 2 minutes oration, and then we'll have a Q&A session. So you'll be totally marked for 100, out of which the top presenter is going to be awarded. So any changes or anything? Yeah, please, before we start, we should all be on the same page so that there is no confusion later on.
The question and answers will be for 2 minutes. Yeah. At the outset, let me congratulate each one of you for having taken this opportunity to come and present here. A huge round of applause to each one of you for this particular initiative. So as RSSDI, we all know, is more of a research organization. The aim for all of us is to promote the concept of research, get into this the lacunae that we have in our country right now is lack of research and publications. So it's with a huge honor that we have Dr. Sydney coming over, and he has been the backbone of making sure that this research goes on in a big way. And we wanted to also announce about the prize money and the publications that are there. So I would ask Dr. Sydney to talk a few words about why and how.
The very fact, the very name KRSSDI is not conference. Conference is part of it. The R will stand for research, right? So unless there is a basic research, we start from your level. You know, things don't change. We always look at New England Journal of Medicine, Lancet, and all not. Where are our journal studies going on? We don't have that quality. Why? We always call money. Money is the problem. No, money is not the problem. Money is there. But problem is mindset is different. So to change that mindset, I thought we will do something. So our Department of Medicine in Yenapaya Medical College and Yenapaya University, we all pulled in money, our own money, plus university gave 50% of it. So we kept that corpus. So every year 10,000 rupees for the best research paper, which will go on every year. So I want that quality to improve so that people will get benefited out of it. You should spread this message. Thereafter, many people will come forward to give more rewards for that. So your quality of papers should go up. That's the only thing that we wanted to do it. As a past president or chairman, I instituted that prize, which will go on now. Now, regarding this timing, what time is the beep? Where is he? That beep will, what time you want the beep to be there? At the end of 6 minutes, right?
7
Where is he?
7 minutes.
Total 7 minutes. ಆ ಬೀಪ್ 6 minutes ಬರಬೇಕು. ಎಲ್ಲಿದ್ರ? 6 minutes ಗೆ big ಬರ್ಬೇಕು. So they'll have 1 minute. Okay? Yes. Thank you.
Thank you, sir. I think Dr. Jaishankar, we will start. Can you start the clock, please?
Yes. Good morning, everyone. I am Dr. Jaishankar. I am HOD of General Medicine from Vaidhi Medical College, Bangalore. I'll be presenting on prevalence of left ventricular diastolic dysfunction in normotensive type 2 diabetes mellitus patients. Now, introduction. Cardiovascular disease is the leading cause of death among individuals with type 2 diabetes mellitus. It is said that men with type 2 diabetes mellitus has 2 times higher risk of developing cardiovascular mortality compared to men without non-diabetics. In the same way, women with type 2 diabetes mellitus have 4 times higher risk of developing cardiovascular mortality compared to women without diabetes. Diabetic cardiomyopathy is a clinical entity characterized by abnormal ventricular function leading to CCF in the absence of coronary artery disease, systemic hypertension, or any pre-existing structural heart disease. Now, left ventricular diastolic dysfunction is the earliest and commonest hemodynamic derangement of diabetic cardiomyopathy, leading to significant morbidity and mortality in diabetic patients. Diastolic dysfunction refers to impaired left ventricular relaxation with or without increase of filling pressure. Now, these patients can be asymptomatic. This diastolic dysfunction can also occur in patients with preserved ejection fraction and patients with reduced ejection fraction also. I already told that most of the patients are often asymptomatic. That is, the patients with diabetes mellitus, diastolic dysfunction they will have, but they are often asymptomatic, and it's presently associated with a marked increase in all-cause mortality. Materials and method. This was a study done in Vaidhi Medical Research Center, Bengaluru, from January 2018 to 2020 for 1.5 years. It is a prospective observational hospital-based cross-sectional study. Patients with type 2 diabetes mellitus who are already diagnosed with type 2 diabetes mellitus who are aged more than 18 years or normotensive were included in the study. Patients with systemic hypertension, heart disease, history of heart disease in the past, patient who had angina, dyspnea, history, COPD, CKD, anemia, thyroid disorders, coronary artery disease, and type 1 diabetes mellitus, and along with history of smoking or alcoholism were excluded in the study, from the study. The following parameters were used in the study. ECG was done and 2-day echo was done for all the patients. In ECG, we calculated the P-wave duration, QRS duration, QTC interval. In the 2-day echo, we consider the parameters for assessing the left ventricular function. That was, one is deceleration time, then ratio between early mitral inflow velocity and mitral annular early diastolic velocity, E bar, E dash, and pulmonary vein Doppler to see pulmonary vein flow velocity. We also estimated HbA1c for all the patients. The parameters what we used were deceleration time. So what is this deceleration time? It's the time interval from the peak of E wave to its projected baseline. Normally it ranges from 150 to 240 seconds. It indicates the duration for equalizing the pressure difference between the left atrium and left ventricle. Then there is something called as E bar E dash ratio. There is early mitral filling velocity to early diastolic mitral annular velocity. It's a simplified approach to estimate the left ventricular filling pressure. Normally it is less than 8. If it is more than 15 minutes, there is increase in left ventricular filling pressure, which determines the degree of diastolic dysfunction. Then pulmonary vein flow velocity normally it was 80 to 120. It also is strongly related to left ventricular isometric relaxation time. Now results. We included 130 patients of type 2 diabetes mellitus. The mean age of the patients was 51.56 plus or minus 10.50. The overall prevalence of left ventricular diastolic dysfunction in these patients were 54.4%. The 72 patients had it. Out of the 72 patients, 69 of the patients had left ventricular diastolic dysfunction of grade 1, and the remaining 3 patients had grade 2 left ventricular diastolic dysfunction. None of the patients had grade 3 or grade 4. In our study, 95 were males, 35 were females, and there was a male dominance in our study. Out of the 35 females, 17 had left ventricular diastolic dysfunction. Out of 95, 55 had left ventricular diastolic dysfunction. Now this is the table showing the statistical significance. In our study, age, deceleration time, E bar E ratio, and QT's interval was statistically significant. This is the graph showing that deceleration time was more in patients with left ventricular diastolic dysfunction, and E bar E ratio was more in left ventricular diastolic dysfunction, and QT's interval also was prolonged in those patients. Discussion. It is said that worldwide, by 2030, 4.4% of patients will be having the diabetes mellitus, and 80% of mortality in these patients is due to cardiovascular disease. It is estimated in patient with type 2 diabetes mellitus, they have 2.5 times incidence of heart failure, and this independent left ventricular diastolic dysfunction will be early predictor of imminent systolic failure, because the diastolic dysfunction will later do systolic dysfunction, and this is early predictor of imminent systolic failure. Few studies were done. One of the study I'm quoting is from the study done in 2013 by Nigeria, where DOD Manuel ST et al. Recruited 90 patients, and these patients were normotensive diabetic patients, and they also showed that the higher prevalence of left ventricular dysfunction in the absence of cardiac symptoms. It was around 51% in their study. This similar study was done by Patil VC et al. In India in 2011, where 227 patients were recruited, and they also showed higher incidence of left ventricular dysfunction in asymptomatic patients. But they found out that there was positively correlation with the duration of diabetes, HbA1c, obesity indices, and diabetic microangiopathies. Now, our study we included 130 patients, and in our study, the prevalence was 54.4%. Now, as I told you earlier, E bar E dash ratio, the deceleration time in QT's interval was statistically significant, whereas there was no statistical correlation between the LV diastolic dysfunction and HbA1c in our study. Now, the certain limitations were there. The specificity of this, whatever we use, conventional Doppler is 40 to 70%. For tissue, Doppler is more sensitivity and specificity compared to the transthoracic conventional Doppler study. We didn't do a coronary angiogram and threadmill test to rule out coronary artery disease, and we did only HbA1c, and the HbA1c gives the score, gives the average of 3 months blood sugars level. Other studies they consider duration of diabetes, but we didn't consider duration of diabetes for correlation. Then conclusion is, in our study 54.4%, which is similar to the studies done earlier in Nigeria, and all the patient type 2 diabetes should be routinely and repeatedly subjected to 2D Doppler echocardiographic assessment of cardiac function. So LV diastolic dysfunction can be used as an early indicator because it later leads to left ventricular hypertrophy and later clinical left ventricular heart dysfunction. So this has important therapeutic implications and helps physicians to plan early interventional strategies. These were my references, sir. Thank you very much.
So, right on time, sir. If I can ask a question,
yes,
did
sir.
you consider microangiopathies like
No,
the
sir,
other studies?
No, sir.
Any particular reason for that?
The study was, this was a dissertation actually.
Okay.
In this dissertation we only consider prevalence. I understand that the microvascular complications like microalbuminuria has a strong correlation with the
Yes.
prevalence of left ventricular arrest, but we didn't do
Yes.
it, sir.
Okay. Fundoscopy as a dissertation topic, fundoscopy would have been-
Fundoscopy was not considered in this study, sir. We just estimated the prevalence of only this 2D echo and ECG we did, sir.
Okay. Even the TMT also is a non-invasive test. So
Understood,
yes, I mean probably it could have added more value to the study.
Yes, sir.
That is what is my conclusion.
Fantastic presentation, Dr. Jaishankar.
Thank you, sir.
Couple of questions. We very well know that left ventricular diastolic dysfunction is one of the commonest presentations for diabetic patients who are even asymptomatic.
Correct.
We also know that echo is got an inter-observal variations.
Variation, yes, sir.
Now, how much of the interpretation by the performing cardiologist can be offset to take into consideration these vital parameters that we are talking about? So we talked about the deceleration time, we talked about the E/E1 ratio, we talked about these parameters. Now we know that between one cardiologist A and cardiologist B, there will be an interobservational
Absolutely.
variability.
Yes, sir.
Now, how much of that is a confounding factor to estimate your diastolic dysfunction?
So maybe
So as sir said, the variability. How do what have we done to take that into consideration? So I am assuming all were done by the same cardiologist.
no, sir.
Or-
No, sir. In our hospital, actually, sometimes the cardiologist they go for angiogram. So that time the patients, if they come to echocardiographic examination, it will be done by different cardiologists, sir. We didn't consider the same cardiologist, sir. That is, I expect. I understand, sir.
Thank you. The second question was, all these patients who had a diastolic dysfunction, though this was not the objective of the study, did you follow them up with a subsequent coronary angiogram to find out the presence or absence of a coronary artery disease in these individuals? Because we would have estimated the diastolic dysfunction prediction much earlier. So was there any follow-up study of these
No,
patients?
sir. Only few of the patients were followed because see, most of the patients in Vaidya hospital, they come from West Bengal, sir. They come, then they go out. So only few patients came. So around 30 patients came, sir. Remaining patients didn't come. I understand the clinical heart failure and diabetic cardiomyopathy is 12.8%, sir. 8%. But in our study, only 30 patients came, so I didn't consider the following of patients, sir.
The third and last question was, we know that diastolic dysfunction is more commoner in females,
Correct, sir.
but in your study of 130 patients, there was a male preponderance.
Correct.
Was there any selection bias?
No, sir. There was no selection bias in that. I understand the females, females, and the studies show that actually more common in females because the estrogen has an effect over it, sir. And most of these patients were actually, if you look at the mean, it is actually ages between 40 to 50 years, and they are in the menopausal age. So I do understand the patients with females, they should have more of LV dysfunction due to cardiomyopathy. But in our case, it was male patients, sir. I understand the estrogen has a protective effect over the left ventricular diastolic dysfunctions.
Thank you, sir. Thank you, sir.
Thank you.
We go on to the next one, Dr. Arya Satish. So we go on to the next one, Dr. Mahim Sethi. Dr. Mahim Sethi is there. Okay.
Good morning, everyone. Myself, Dr. Mahim from JSS Medical College, a postgraduate. I am going to present my oral presentation on topic pulmonary arterial hypertension as a predictor of severity of chronic kidney disease and correlation with its various stages. As we know, pulmonary hypertension refers to presence of high pulmonary vascular pressures and can be the end result of a variety of different underlying disorders. Under them, it can be cardiovascular, respiratory disorders, chronic thromboembolism, and apart from that, multifactorial causes. And as we know, CKD is a highly inflammatory state and a hyperdynamic state. It increases the risk of cardiovascular mortality and morbidity by 200-fold. And according to the Indian data, the most common causes of CKD in India are diabetic nephropathy, followed by chronic glomerulonephritis and hypertension. In our study, the prevalence of pulmonary arterial hypertension in patients with CKD was evaluated. Along with that, association of PAH with CKD etiology and the prevalence in different stages was also evaluated and correlation with different stages. We included patients, 60 patients who belong to stage 3 and above as per the Kidney Disease Outcome Quality Initiative guidelines and were above 18 years. We had a large exclusion criteria in which we excluded patients who had prior respiratory disorders, cardiovascular disorders, pulmonary thromboembolism, that is CTEPH, and patient who had acute kidney injury, polycystic kidney diseases, burns and sepsis, and pregnant females. Nextly, it was a cross-sectional study done at our hospital from December 2021 to June 2022. And after classifying the patient as per KDOQI guidelines, we grouped them accordingly in the mild, moderate, and severe groups. And after this, the association with the CKD etiologies was also assessed. Next, coming to the demographics and clinical data, we had 60 patients, and apart from that, mean age of the population was 51.6, and out of 60 patients, 52 had pulmonary hypertension, which accounted for approximately 86%. Then, as we can see in the graph, we had major chunk of patients which belong to stage 5D, followed by stage 4, which accounted for approximately 23.3%. This is depicted in the graph showing patient maximum belonging to stage 5D. And this is the distribution of study subjects based on the grading of pulmonary arterial hypertension. Most of them had mild pulmonary hypertension, and the mean pulmonary pressures were 50.83. Next, coming to the relationship between the stages of CKD and pulmonary hypertension, as we can see, in the initial stages, that is stage 3B, only six patients did not have pulmonary hypertension. But as we go on the higher stages, all the patients which belong to stage 5 and 5D had pulmonary hypertension, and we had a significant p-value. This is being depicted in the initial stages. Less number of patients had pulmonary hypertension, but as we go on the higher stages, all the patients had pulmonary hypertension. Next, establishing a relationship between HD and PAH, we had out of 60 patients, 33 patients on hemodialysis, including AV fistula as well as through jugular or jugular catheter, and we had a significant p-value. Nextly, this is depicted in the graph. Now, when we compared to the comorbidities, the major chunk of the patients had hypertension and diabetes, and the patient out of 60 patients, 56 had hypertension and 42 patients had diabetes, and approximately 92% of patients having hypertension had pulmonary hypertension, and 60% had diabetic with pulmonary hypertension. Then if we compare our studies to the different studies, first study was done in Maharashtra in 2013 to 2017, which was done by Kalpana S. Mehta, which also showed serial elevation of pulmonary pressures as we go on the higher stages, which was 9.91%, followed by 21% and 68.5%. And as we can see in our study also, we had 33 patients who were on dialysis, and they had higher pulmonary arterial hypertension, which was similar to the other studies. And the other study, which was conducted by Kalpana S. and Fabian in US, it was also showing that incidence of diabetes and hypertension was more with the CKD etiology. Lastly, coming to the conclusion, our study revealed that approximately 86.7% had pulmonary hypertension and CKD with a mean pulmonary pressure of 50.83, and as the stages advanced, the incidence of pulmonary hypertension increased, maximum seen in stage 5D. And if we compare it to the persons on hemodialysis compared to conservative management, the persons on HD had a higher incidence. Lastly, coming to the limitations of the study, our study population did not include CKD patients who belong to stage 1 or stage 2 and who were on peritoneal dialysis. Lastly, we did an indirect echocardiographic measurement of pulmonary pressures, and it was not done by the right heart catheterization. And the study sample was very small, and being a cross-sectional study, we could not go ahead with the follow-up of the patient. And lastly, the study was done to see whether once the magnitude of pulmonary hypertension in CKD is determined at early stage, we can prevent the cardiovascular mortality and morbidity. These are my references. Thank you. Stage 3, stage 4 and stage 5, sir. Yes, sir. There are not. Yes, sir. Sir, as the stages advance, we need to prove that pulmonary arterial hypertension increases. So that.
What's the title of your study, doctor?
Sir, to assess the severity of pulmonary arterial hypertension, as the first we need to assess the severity of
Put your title slide.
Yes.
Yeah, read your title.
So, pulmonary arterial hypertension is a predictor of severity of chronic kidney disease and correlation with its various stages, sir.
Got it?
Yes.
Now, listen to what's the question that is being asked by Dr. Sidney. What's the question?
Sir, as the predictor of CKD.
Right. So, when do you predict? You need a predictive analysis in the early stages of the disease.
Yes, sir.
So, when you have said that there is stage 3, stage 4, stage 5, as the disease progresses, there is an increase in pulmonary arterial hypertension.
Yes, sir.
Does that have any therapeutic implication at that stage?
Yes, sir. With the initial stages, for example, if we are detecting it in the stage 3 or stage 4, we can, it is mainly associated, depends upon the etiology of the disease, whether it is diabetic kidney disease or hypertensive. And if we start treatment at an early stages, we can prevent LV diastolic dysfunction and cardiovascular mortality and morbidity. We can reduce them.
Perfect. So let's understand this. The objective of any study that we do needs to have either a diagnostic implication or a therapeutic implication.
Yes, sir.
Now, the therapeutic implication is more profound if you are able to do an early predictive analysis.
Yes.
Now, if the same study were to have included your stage 1, stage 2 and stage 3 patients, and if you had done an earlier predictive analysis of these patients, picked up the evidence of pulmonary arterial hypertension, started interventions at that stage, you would have obviously prevented or prolonged the onset of pulmonary hypertension going on and getting on into this. So what you've done is you've mimicked the earlier studies that are there and tried to see what is it that you have as a statistics. Your research as such is good, but what we need trying to see is how could it be improved is to make sure that if it can have an additional therapeutic implications. Right? So that is one of the points that you need to consider whenever we're doing a research. Now, did you have any correlation between the duration of chronic kidney disease in these patients from stage 1 to stage 5? Did you take a correlation of the
Yes, sir.
duration?
Yes, sir. Because of the time constraint, I did not include it. There was, in general, what we see as the duration of chronic kidney disease increases, the pulmonary arterial hypertension will increase as CKD is an inflammatory state and due to the hyperdynamic state and volume overload condition, the prevalence of pulmonary hypertension increases, sir.
So did you see any kind of a negative correlation?
Yes,
where,
sir.
Yeah, what
yes,
is
sir. In our study, there was a negative correlation, sir. We had the number of patients having pulmonary was more than more than 12 months. There was significant number of patients, but it was not statistically significant, sir. So that's why I did not include it, sir.
Okay, doctor.
I just wanted to see your exclusion criteria once.
Yes, sir.
So you did a CTPA for everybody?
No, sir.
No, I just wanted to see that. I wanted to see your exclusion criteria. No, in the exclusion, I think he did mention about that.
So the respiratory disorders were ruled out. Then secondly,
So, probably theoretical, but silent pulmonary thromboembolism, because we know CKP and you have included stage 3 plus, so not stage 1 and stage 2. So silent pulmonary thromboembolism, how have you excluded?
sir, based on the
So basically you need to, all the patients who are
Yes,
included
sir.
should have a CTP. I'm just
Yes, sir.
for discussion's sake,
Yes.
but I am very sure it is not a viable thing,
Yes, sir.
because everybody can't be
Yes.
done that. I just wanted to know about that. Again, correlation with other complications like retinopathy.
Yes, sir, it was there, sir, but mainly because we had included everything, but because of time constraint, I included
No,
the
wha-
major
So,
portion only, sir.
because how many of them had probably moderate or severe PDR?
Yes, sir, they had, sir. Approximately we had a total of 46 patients with diabetes, and in them 30% had diabetic nephropathy, and apart from that, retinopathy was seen in 34%. Sir.
So how many of the people who had diabetes had diabetic retinopathy as well?
Sir, approximately 31%, sir.
No. Of the patients who had diabetes, how many of them had retinopathy as well?
21, sir, total 46 patients of diabetes, out of them 21 had retinopathy as well.
And 34 had CKD.
Nephropathy, 34% of them had nephropathy also.
Okay, the correlation was quite
Significant.
less.
Because our sample size was less, as our study duration was only 6 to 8 months, and it was a cross-sectional study, and we had a lot of exclusion criteria.
So last question, do you think it has therapeutic implications?
Yes, sir. We can predict because if we detect at an early stage, for example, diabetes and hypertension leads to LV diastolic dysfunction. So if we control diabetes and hypertension at an early stage, we can prevent that LV diastolic dysfunction, sir.
Okay, thank you. We go on to the next one, Dr. Srinath KM.
Very good morning to all of you, respected chairpersons. I bring greetings from my institute, JSS Medical College. The topic which I am going to present now is the effect of vitamin D on cytokine profiling in diabetic as well as diabetic nephropathy. My guide is Professor Basavanagadappa, Principal, JSS Medical College. We all know diabetes is a chronic metabolic disorder with an inflammatory component added to it, and its prevalence is increasing day by day and has reached the epidemic proportion right now. And we all know its effects, particularly the complications like diabetic, microvascular complications like diabetic nephropathy is an important cause for end-stage renal disease. So diabetic nephropathy is considered as a non-immune disorder. Of course, increasing evidence suggests that inflammatory mechanisms that may play a major role in the disease pathogenesis as well as the progression. Identification of cytokines not only alters the classical but also gives fresh insight into the pathophysiology of various autoimmune disorders. And monitoring diabetic nephropathy, which is predicted by microalbuminuria as well as vitamin D and cytokine levels, could be a strong early biomarker. So probably early diagnosis can help to prevent this particular kidney disease from getting worse. So in this context, we aim to estimate the levels of interleukins, particularly IL-1, IL-6 as well as IL-2 alpha, and vitamin D levels among diabetics with and without nephropathy. So we did compare the interleukins with vitamin D levels in diabetics with and without nephropathy. Of course, it is a comparative cross-sectional study done among 3 groups. Group 1 is diabetic, number 2 is diabetic nephropathy, third group included healthy subjects which attended master health checkups of JSS Medical College. So we did consider a sample size after consulting a statistician. The mean values of vitamin D among patients with diabetes as well as diabetic nephropathy is considered to be 19.82 plus or minus 5. The sample size was calculated for multiple comparison of biochemical parameters using ANOVA, followed by post-hoc multiple comparison procedure. The sample size required at 5% level of significance with statistical power of 0.8. In addition to that, absolute standardized mean difference of 0.5 is found to be 246 with 82 samples per each group. So thus we included 84 diabetics with nephropathy and 84 age and sex matched controls, which apparent they were the healthy individuals included as a comparison group. Inclusion criteria for diabetics, we applied the standardized WHO criteria of fasting blood sugar more than 126, ppbs of more than 200, and HbA1c of more than 6.5%. For a diabetic nephropathy group, we considered patients who are diabetic for more than 4 years and diabetics with GFR of less than 90 ml per minute per 1.73 meter square with proteinuria. This based on the MDRD formula. The controls were the normal subject without any disorders. The exclusion criteria was patients who had a pre-existing renal, hepatic or cardiovascular dysfunction. Patients with tuberculosis, HIV as well as sarcoidosis, other infections were excluded. Drugs that interfere with vitamin D metabolism, especially antiepileptics, antipsychotics as well as even rifampicin and INH were excluded. The patients who are already on vitamin D supplementation for the last 6 months, they were also excluded. And patients who are on nephrotoxic drugs like ARTs and even anti-malignant drugs, they were excluded from the study. So we did do a biochemical investigations like fasting blood sugar, PPBS, HbA1c levels to determine the diabetic status and also to identify the control. We also did urea, serum creatinine and UACR, urine albumin creatinine ratio, to determine the status of diabetic nephropathy as well as its stages. So we did estimate vitamin D levels, especially by chemiluminescence method, and we also estimated the cytokine levels as IL-1, IL-6 and TNF alpha by ELISA methods, by using special ELISA kits. So each group has 84 number of patients. So look at this is vitamin D deficiency, severe vitamin D deficiency is considered as less than 10 nanogram per deciliter. Vitamin D deficiency is considered as 10 to 20. From 20 to 30 we considered as insufficiency. So more than 30 is considered as a normal. So in the control group, most of the study groups they had vitamin D deficiency. If you just look at the control group, the deficiency was almost 42%, whereas in diabetic it was almost 60%, whereas in nephropathy it is 51%. But if you look at the serum vitamin D deficiency that is very severe, is found in nephropathy group. So we did serum cytokine levels, IL-1, IL-6 and TNF alpha. The IL-1 as well as TNF alpha were more in the diabetic group, whereas IL-6 was more in the nephropathy group. We did a sub-analysis of vitamin D deficiency, optimal, suboptimal, deficient and very severely deficient. So in that, so IL-6 were more in nephropathy group compared to diabetic and control group, whereas TNF alpha was more in the diabetic group compared to diabetic nephropathy group. This is what the blocks plot, which is showing the various especially the vitamin levels. These are the group 1, group 2, group 3, the sub-analysis of based on the vitamin D deficiency.
Sir, time's up. Please summarize.
At the end, I'll conclude that. So majority of the patients in our study had vitamin D deficiency, but severe vitamin D deficiency was observed in diabetic nephropathy subjects. Interleukin 6 were high in diabetics with nephropathy, whereas interleukin 1 and TNF alpha levels were high in diabetic group. Hence, IN6 may be considered as a potential early marker of nephropathy. We thank SERB, the Government of India, for providing fund for this research group. Dr. P.V. Salimat was the PI for the PA project, and myself and Basangoda sir was the co-PIs for this project. Thank you.
Fantastic, Dr. Srinath. It's a very detailed presentation of a research paper. The parameters that you considered were vitamin D. What form of vitamin D was assessed? What form D was assessed?
So actually the vitamin D assessment is only it is not the active form. We cannot assess the active form. Only the vitamin D2 can be assessed by the available this thing. So we could assess only the D2. And this is done across the globe. Whatever the people are assessing, it's only the vitamin D2, not the vitamin D3. Vitamin D3 is the form with the one which acts at the cellular level.
Right. So the second question that we wanted was the correlation between vitamin D and cytokines. What was the net correlation that you found between the diabetic groups and the non-diabetic groups? Was there any assessment that was done?
Yes, that was done. There was a weak negative correlation for IL-6 in nephropathy group, whereas TNF alpha as well as IL-1 has got a weak negative correlation in a diabetic group. Possibly Because in a diabetic group, even TNF alpha and is especially contributed by the intrinsic cells of the kidney, particularly mesangial cells or endothelial cells, other intrinsic cells of the kidney. At the end stage of the kidney, these cells are defunct. They may not be producing these particular proteins. And the limitation of our study is we could not measure the urinary levels of IL-1, IL-6 as well as TNF alpha, which could have given more better results. Because during later stages of the CKD, there will be more proteinuria. These amount of proteins may be lost in the protein. That's why we were not able to dogmatically say this could be an early marker.
And what was the duration of the study and the time? When was the
So
study?
almost 3 years, sir. We did 3 years from 2019. In between, for 1 year, we could not collect cases because of the pandemic.
So that was a question that I wanted to find out. Was there any effect of the pandemic disorder as such as a residual inflammatory marker in these diabetic subset of patients? We all know that.
So, yeah, we could not collect. So majority of the patients, 60% of the patients we collected from 2018 to 19 before the pandemic set in. Okay. After the pandemic, we could collect only the 30% of the patient, even after 1.5 years. Because none of the patients, especially CKD patients, they visited a hospital. That was the reason.
And what is your therapeutic implication for this study that you have?
Yeah, we are considering, actually this is a part of the study. So we did estimate even antioxidants also. Antioxidants like catalase and GPX as well as glutathione peroxidase and reductase. So we just wanted to see, we know CKD is basically an inflammatory disease. Diabetes is also an inflammatory disease. And whether these inflammatory processes are contributing. Suppose if you can pick up these things in an early stage, where can we do any therapeutic target for such markers? Do we have any biologicals? Can we use particular?
Diabetes, it has been well established that it is a inflammatory disease. So
Correct.
we are probably establishing the already established fact by giving evidence.
Correct.
So that is one thing. Second thing I wanted to know, sir, in the diabetic nephropathy group, did you consider doing a PTH? Because vitamin D and PTH are related.
That is a one limitation of our study. We did not do PTH. So
Hyperpara
probably
will
by
be
doing PTH and serum calcium as well as bone marrow density would have given a better added value for this study. That is what I'm saying. Because normal nomogram has not been established for vitamin D. We are searching because that is a paradox in India. See, this sunshine vitamin is deficient in sunny India. Why, being Indians, we have a lot of sunlight, why still we are having a deficiency?
Still do the BMD and PTH in these patients so that we can probably understand the role of IL-1, IL-6 and tumor necrosis factor as a part of probably nephropathy and
correct.
What role it does.
Yes, sir. We are considering that because we have a list of all these patients and we can call them back and and we are getting a BMD instrument in our hospital. So we are planning to do that.
Thank you, sir. We'll go on to the next one. Thanks a lot, sir.
Thank you.
We go on to the next one, Dr. Venkatasai Shashank. We'll skip. Okay. So we'll go on to the next one, Dr. Aishwarya.
Good morning everyone. I'm Aishwarya. I'm from JSS Medical College and I'll be presenting on association of monocyte to HDL cholesterol ratio with vascular complications in patients with type 2 diabetes. My guide is Dr. Ravikumar Vyas. He is Professor and HOD, Department of General Medicine, JSS Medical College. So diabetes mellitus is a chronic metabolic disease commonly associated with both micro and macrovascular complications. The systemic inflammation has a significant role in development of these vascular complications. Several pathophysiological factors such as polyols, hyperglycemic protein glycation, the formation of advanced glycation end products, and ischemia operate together for the development of vascular complications in diabetes. Advanced glycation end products are pro-inflammatory molecules that lead to oxidative stress and induce the production of cytokinins like interleukin 1, interleukin 6, and TNF-alpha by activating cell types like monocytes, which have both pro-inflammatory and pro-oxidant effects, causing the progression of vascular complications. The high-density lipoprotein cholesterol diffuses these pro-inflammatory and pro-oxidant effects of monocytes by counteracting and inhibiting the migration of macrophages and oxidation of LDL cholesterol, as well as promoting the efflux of cholesterol from these cells. A relation between high number of monocyte and low HDL levels have been reported in various inflammatory disorders. And the monocyte to HDL cholesterol ratio is a novel and composite predictor that can reflect the balance between the inflammatory and oxidative stress of both monocytes and HDL cholesterol. It is cheaper compared to other inflammatory markers, and it is easily accessible. We can calculate it from the absolute monocyte count for total counts and HDL cholesterol from lipid profile. In the present study, we aim to investigate the relevance of MHR as a marker to assess the vascular complications in patients with diabetes. Coming to the objectives, the primary objective is to study the association of monocyte to HDL cholesterol ratio with vascular complications in patients with type 2 diabetes mellitus. And secondary objective is to study the role of MHR as a novel and cost-effective inflammatory marker in detecting the vascular complications in diabetics. So materials and methods, it is a hospital-based cross-sectional study, and a total of 100 patients with type 2 diabetes mellitus were included in this study. And based on the inclusion and exclusion criteria, the inclusion criteria being age more than 18 years and patients who are diagnosed as type 2 diabetics for 5 years or more, and exclusion criteria being hematological disorders, malignancies, severe liver and kidney diseases, cerebrovascular diseases, cardiovascular diseases, connective tissue disorders, acute inflammations, and active psychiatric illnesses, and patients who are on lipid-lowering drugs or statins, steroids. The study population was subjected to routine investigations like complete hemogram, LFT, RFT, lipid profile, FBS, PPBS, HbA1c, biothessiometry, Doppler, and echo, and urine albumin creatinine ratio. The patients were divided into patients with complications and without complications, and for all patients, MHR has been calculated from absolute monocyte count from complete hemogram and divided by HDL ratio from lipid profile. The normal MHR in non-diabetic patients was 7.2 with a standard deviation of 0.9. So microvascular complications, we have done spot urine microalbumin creatinine ratio for diabetic nephropathy, and if spot urine microalbumin creatinine ratio of more than 30 mg per gram was considered to have diabetic nephropathy, and for diabetic retinopathy, fundoscopy, direct fundoscopy was done, and for neuropathy, tendon reflexes, 10 gram monofilament, and biothessiometry was done. For microvascular complications, for cardiovascular diseases, clinical symptoms were asked, ECG and echo were done, and peripheral vascular diseases, clinical symptoms, peripheral pulses were felt and looked for, and ankle brachial pressure index with the help of Doppler was calculated. So these are the results. Most of the study population were between the age of 51 to 70 years age, and most of them were males, about 53 are males. And the distribution of different parameters among the study population. So the mean systolic blood pressure was 122, diastolic blood pressure was 78, and monocytes mean was 371.88 with a standard deviation of 171, and HDL was 31 with a standard deviation of 12, and MHR was 15. This is the mean MHR. So out of the all patients, like we had 63 patients showed vascular complications, and 57 had microvascular complications, and 23 had macrovascular complications. The MHR value in vascular complications was 19.68, and those without vascular complications, we got it a value of 8.42, and it is significant. And in microvascular complications, it is at 20.68, and macrovascular complications was 20.41. And for all three, the p-value was significant. And these are the individual complications which we have evaluated. And for out of all the patients, the most common complication we got as diabetic neuropathy. 48 had diabetic neuropathy, followed by diabetic nephropathy and retinopathy. And The MHR was calculated, and for all these patients with complications, it is from 20 to 25, and without complications, it was in around 12. So for all these, it is clinically significant. So results out of 100 sample size, 63 diabetics had vascular complications, and 33 did not have complications. 57 showed microvascular complications, and 23 had macrovascular complications. The mean MHR value was higher for patients, diabetic patients with vascular complications compared to those diabetics without complications. It was around 19.68 versus 8.4, which we got in patients without complications. The mean MHR value was higher for the diabetic patients with micro and macrovascular complication, and it was clinically significant. So conclusion, our study showed that MHR in diabetes with vascular complications was significantly higher than those with diabetics without vascular complications. This MHR ratio is a simple and valuable tool as a predictor for vascular complications in diabetes with micro and macrovascular complications, and it can be carried out even in remote areas where facilities for optimal evaluation of vascular complications do not exist. Thank you.
It deserves a huge round of applause, Dr. Aishwarya, for this fantastic study that you have done, which has got a very, very novel concept and a tool that can be used in the most remotest of places. So congratulations to you on that count. The question that I had for you was, your study population had duration of diabetes more than 5 years,
Yes.
presuming that that's the timeline that is required for everyone to develop a microvascular and macrovascular complications. Point number one. Point number two, all your diabetic patients were in the age of 51 to 70 years. Now, out of all these patients, none of these patients were put on statins, and that's the inclusion criteria, that's one of the exclusion criteria that you've taken off. Now, is that not a disservice to the patients who have been
Yes, sir.
diabetic patients more than 5 years, assuming that they have all these things, and then they have not been on statins?
Yes, sir. Ideally we have to start them on statins, but these are the patients who has come to our hospital setting and they were not on statins, sir, and that's why we had included them in our study.
Okay. Now, the problem for us is to find such kind of a population, right? Now, invariably, as per the standard recommendations, everyone above the age of 40 years, irrespective of their dyslipidemic status, they need to be on statins. Now, do you have a similar implications of this in spite of these patients being put on statins? Do you have a similar kind of a correlation that can be made, or the addition of statins in these patients alter this ratio?
I think addition of statins alter the, not much, sir, because statins usually don't act on HDL that much, but there is a little elevation with statins. Maybe if at all it is included, then there can be a little difference if at all.
So a suggestion here would be to see if you can have a similar kind of an impact on patients on statins. And if you're able to prove that, it would definitely be a very good study that can be taken and used as a standard marker that can be recommended.
Please, can you go back to the slide where you showed the mean blood pressure was 130 and 100 patients of 5 years
And
duration?
they are hypertensive patients, sir, but who are in control, like their BP are in control. Those are the patients which we have included.
Yeah, I think you did not mention that. I was
Yes,
a little surprised that out of 100 patients,
No, they are
none
all,
of them, the mean BP was 130, so that was a little surprising.
They are hypertensive patients, sir, but they are in well controlled.
I mean, as sir said, I'm sorry, but they are so well controlled that they're not on statins, but their blood pressure is well controlled. To get that subset of population wherein BP is so awesomely controlled, but they're not on statins. I mean, that's one probably thing is stinging in the eye. But other than that, yeah, really, if it comes, as sir said, if you can do it with statins and then show that if the numbers come to be pretty significant, then yes, it would be a study worth publishing. but I'm a little concerned with respect to blood pressure being so well controlled and patients are not being on statins.
The other question that I had was there any difference that you found between these ratios between your well-controlled diabetic individuals and poorly controlled diabetic individuals? Was there any sub-analysis that you did?
No, sir. We have not done a sub-analysis on that.
Right. So what we are trying to see is the correlation between this to assess vascular complications, right? So we wanted to also understand, in addition to control, I mean, in addition to the duration of the disease, whether a good control has got any altered ratio versus a poor control having a higher ratio. If that can also be sub-assessed, you can also add that as one of the predictive parameters that you could probably publish.
Yes.
Okay.
Our mean HbA1c in those patients was about 9, sir. So they are
all
not
poorly controlled.
Poorly controlled.
Okay, and if you could do that amongst patients who are well controlled with HbA1c 7, 6.57, and if you're able to see if there is any changes in these ratio, it is worth exploring.
Yes.
Thank you very much. A wonderful study nevertheless.
Thank
You so much, Dr.
Thanks.
Aishwarya. So let's move on to Dr. Tejasvi. Yeah.
So, very good morning to all the dignitaries. I'm Dr. Tejasvi, medicine postgraduate from JSS Medical College. I'm here to talk about the topic, a comparative study of platelet volume indices in type 2 diabetics with and without vascular complications. The study was done under the guidance of Dr. Ravi Kumar sir.
Sorry, just a second. I think now there have been guidelines that we do not use the term type 2 diabetics. We say people with diabetes. So for henceforth, for everybody, I think that should be
Sure.
PWD.
So it was done under the guidance of Ravi Kumar sir, professor and HOD Department of Medicine in JSS College, Mysore. Coming to the background of the study, we all know that diabetes today has assumed epidemic proportions and India has emerged as a diabetic capital of the world. So, and diabetes affects many organ systems over time, leading to serious micro and macrovascular complications. The pathogenesis of diabetes is complex and it has a strong interplay between metabolic, genetic, and environmental factors. Recently, platelet dysfunction in diabetes is being considered as one of the important etiologies in developing these complications. Platelet dysfunction in diabetes is caused by several mechanisms like hypoglycemia, insulin deficiency, obesity, dyslipidemia, dysregulated signaling of metabolic pathways, oxidative stress, and accelerated platelet turnover. As we all know, diabetes is a prothrombotic stage, and a hyperactive platelet is the phenotype, is an important epitope of this prothrombotic state. So young platelets are larger in size and contain denser granules, which release more of serotonin, beta-thromboglobulin, and thromboxane A2. This makes larger platelets enzymatically and metabolically more active than smaller ones, and hence play a critical role in pathophysiology of this thrombotic state. So with larger platelets being hyperactive, evidence from the prospective studies and meta-analysis suggests correlation between the volume indices of platelets, like mean platelet volume, platelet distribution width, and platelet large cell ratio, and increased risk for thrombosis in patients of diabetes mellitus. So our objectives for the study are, the primary objective is to study the correlation of this mean platelet volume, platelet distribution width, and platelet large cell ratio in type 2 diabetic patients with and without complications. And the secondary objective is to correlate between these platelet indices in patients with micro and macrovascular complications. Coming to the methodology of our study, it was a hospital-based comparative cross-sectional study conducted over a duration of 18 months in both outpatients and inpatients of JSS, fulfilling the eligibility criteria. The sample size was 125, and patients who were already known diabetics were taken, and they were divided into two groups with and without complications. Necessary approval was taken from the ethics committee. Informed and written consent of the patients were taken, and all the data collected was kept confidential. All the clinical and lab data was documented in a pre-tested proforma. The parameters assessed in our study are the MPV, PDW, and platelet large cell ratio were obtained through a routine investigation performed, that is a complete hemogram. Patients were also assessed on their age, gender, duration of diabetes, FBS, PPBS, HbA1c, and fasting lipid profile. And also the further assessment was, of the complications was done on coronary artery disease based on the clinical symptoms, ECG and 2D echo, and the peripheral vascular disease by the clinical assessment and ABPI by Doppler method. Diabetic retinopathy assessment was using the fundoscopy. Diabetic neuropathy, the clinical signs and symptoms along with the vibratory sensation test and the monofilament 10-gram test. Diabetic nephropathy patients by the quantitative UACR values in the morning spot urine samples and the serum creatinine levels. Coming to the subject eligibility, the inclusion criteria of a study contains patients above 18 years of age who are already known diabetics for more than 5 years with or without complications. And the exclusion criteria being females with hemoglobin less than 10 grams and males with HB less than 11 grams. Pregnant women, patients on antiplatelet drugs, patients presenting with acute febrile illness who are already known IHD and cerebrovascular accidents were excluded, and with those with diagnosed malignancies, septicemia, thrombocytopenia, thrombocytosis, thyroid disorders, chronic renal failure, and cyanotic heart diseases were excluded. Coming to the results, majority of our patients fall in the age group between 51 and 60 years, and 54% were males and 48% for females. Coming to the glycemic index, 58% of them fall between the 7.1 to 10% of HbA1c, the mean being 9. And out of 125 patients, 60 had complications and 65 patients were without complications. This is the distribution of our diabetic complications. We had 7 patients who had peripheral vascular disease, and there were none with CAD. We have excluded known coronary artery disease and cerebrovascular accidents in our study, and thought to consider only newly detected CAD. So apart from that, none of them were CAD. And coming to diabetic nephropathy, 34 were having diabetic nephropathy, 32 with retinopathy, and 32 with neuropathy. This was the association of mean platelet count with diabetic complications. The overall picture suggests that platelet count was significantly reduced in patients with peripheral vascular disease and diabetic nephropathy, and compared to other complications. This is the mean platelet volume which is studied. It is shown that based on patients without complications and with complications, it was significantly elevated in patients with microvascular complications than the macrovascular. Coming to the platelet distribution width, it was studied in patients without complications, it was low, and with complications it was increased, and significance was showed in only the group of diabetic neuropathy. Coming to the platelet large cell ratio, compared to the without complications, it was elevated in patients with complications and significantly elevated in both micro and macrovascular complications. We also assessed platelet indices in subjects who had hypertension. The most common additional comorbidity we found was in hypertension. So we found MPV was increased in patients with hypertension. And there was a positive correlation between platelet large cell ratio and total cholesterol and also LDL. Coming to conclude my study, it was showed that platelet indices such as MPV, PDW, and platelet large cell ratio are elevated in patients with diabetic complications as compared to those without complications, and they are more significantly elevated in subjects with microvascular than macrovascular complications. Coming to the limitations, the major hindrance of the study is normal healthy population were not recruited, so only correlation was made between diabetics with and without complications. And it could not establish a causal relationship between increased indices and diabetic complications. Also, CVA and IHD were not included. So, majority we studied among the microvascular complications than the macrovascular complications. These were my references, sir. Thank you.
Congratulations, Tejasvi. It's a well laid out study. My observation here was, this was a study done over 18 months.
Yes.
It included outpatients and inpatients from a tertiary patient referral center where you will have nothing less than 25,000 - 30,000 patients per month. And over this study was over almost close to 2 years.
Yes, sir.
And you have selected 125 patients.
Yes, sir.
Any reason?
That is based on the incidence and prevalence of the it was calculated by that data, sir, of diabetic complications.
Do you mean to say that you had only 125 patients who had a combination of these diabetic neuropathy, nephropathy, retinopathy as a subset in your study?
Not that way, sir.
Okay.
Like based on the analysis and the prospective and meta-analysis studies, we have seen 125 subjects would suffice this study.
Okay. That was the way it was. Now, when you found out that this particular indices that are significant in patients who have complications, does this indices change with the presence of 1, 2, 3 and plus coronary artery disease? Did you get my question? If they have only neuropathy,
Okay.
only nephropathy, or a combination of neuro, nephro and retino,
Yes, sir.
in addition to coronary artery disease,
Yes, sir.
does these indices change?
So majority of our patients, those who had nephropathy also had retinopathy, also had neuropathy.
Correct.
So it was not individually, we couldn't individually study the complications in any of the patients, sir.
Correct.
So majority of the patients who had nephropathy had also retinopathy and also neuropathy. So there were only few subset of patients who had individual complications.
No.
So
The question was, does the indices change
Yes.
when the number of complications are more,
Okay.
and is it less when there are less?
Okay.
Is that an observation
yes,
that you
sir.
made?
Yes, sir. But we couldn't observe that individually, sir, because majority had complications, like 2 or 3 complications there.
Okay. I know that you're trying to say something which you've not looked into. That's what
Yes.
it appears
Yes,
to
sir.
be. But what I also want to understand was, is there any method where you have added them on antiplatelets? Using antiplatelet, 1 or 2 antiplatelets, does this study give us any indication towards a recommendation to start antiplatelets as putting them on 1 or 2 antiplatelets based on this study? Does that help?
Sir, I feel that in this study we couldn't establish the duration and the indices per se. So I feel that there are many other factors which are contributing to this complications apart from the platelet volume indices. So definitely we can start the patient based on antiplatelets, but that how does it differ the progress of the patient is not established, sir. Like the cause and effect is not established. The direct causal relationship with the platelet and the complications is not established.
The same thing what sir wanted to ask, I wanted to ask, sir has asked, what happens if there is only neuropathy? Because nephropathy and retinopathy go hand in hand
Yes,
most of the
sir.
times,
Yes,
90% of the times. But only neuropathy, if it was there, and combination of others, can we have a comparison and say, yes, it is more here, it is less here?
Yes, sir. I
Because
think
neuropathy, 60% of the patients of diabetes will have neuropathy.
yes.
5 years is pretty good time.
Yes, sir. I think we should have studied individual groups would have helped us. Individual complications would have helped us better. So,
Okay, thank you.
yes.
Next we go on to Dr. Sara Shaukat.
Good morning, everyone. My name is Dr. Sara Shaukat Ali, and I'll be presenting on extracellular fluid to total body water ratio and pulse pressure in patients with varying degrees of proteinuria and normal creatinine in type 2 diabetes mellitus. My guide is Dr. Sydney D'Souza. So coming to the introduction, as we all know, type 2 diabetes mellitus is one of the leading cause of end-stage renal disease. And proteinuria, especially microalbuminuria, is an early sign of renal injury. In this...
Could you go back to your title?
Yes. Extracellular fluid to total body water ratio and pulse pressure in patients with varying degrees of proteinuria and normal creatinine in type 2 diabetes mellitus patients. So, proteinuria is one of the early signs of microvascular injury, early signs of renal injury, and decrease in albumin usually leads to extravascular shift of the fluid, and there will be an extracellular fluid overload. So, there have been studies showing that pulse pressure and mean arterial pressure has been assessed for the risk of proteinuria or nephropathy, and it has been proven that mean arterial pressure increases with proteinuria. So coming to my research objective, it is basically to assess the relationship between extracellular fluid volume to total body water ratio and pulse pressure in these patients with urine protein creatinine ratio, those who have been diagnosed as type 2 diabetes mellitus, whereas the patient has not progressed to renal failure. That means renal functions are normal. So the methodology was a cross-sectional study. Study site is Yanakoya Medical College Hospital and study duration is 1 year. The current status of the study is ongoing. So coming to the inclusion criteria, according to ADA criteria, we have included patients with type 2 diabetes mellitus, and they should be having proteinuria measured as per urine protein creatinine ratio, and they should have normal renal parameters according to the lab value. Exclusion criteria were deranged renal function, volume overload assessed by clinical examination, use of diuretics, and urinary tract infections. Statistical analysis, a preliminary analysis of 18 available samples was done. Association between the parameters were assessed using Pearson correlation coefficient, and grouped analysis based on extracellular water to total body water ratio was analyzed using Mann-Whitney U test. So coming to the results in this preliminary study, according to Pearson correlation, there is no specific correlation, whereas in pulse pressure we can see and visually the trend increases as extracellular fluid to total body water ratio increases. Whereas even in urine protein creatinine ratio, there is no specific correlation. And R square is 0 for negative association and 1 for positive association. Here, however, it's more than 0 in all the samples. So in box and scattered plot, we can see that even though it's not statistically significant, the median values were taken in extracellular to total body water ratio, keeping a cutoff of 0.4. So we can see the median value is more in all the patients who had ECF to total body water ratio more, even though it was not statistically significant, probably due to the low sample size. This is the correlation of mean arterial pressure and pulse pressure. Even urine protein creatinine ratio was more, the median was more in the sample size of extracellular water to total body water ratio, even though it was not statistically significant. P-OA value was 0.4. So coming to the conclusion, we can find that mean arterial pressure, pulse pressure, and urine protein creatinine ratio tends to be more in patients with extracellular fluid to total body water ratio more than 0.4. Whereas we need to recruit more samples in order to analyze the most sensitive and specific biomarker to raise the to indicate the raise in ECF to TBW ratio to improve the significance. Coming to the discussion, we know that body fluid balance is tightly regulated in our body, whereas in end-stage nephropathy, the body fluid balance is severely altered. We can see it as edema because there is an extracellular fluid overload. So in this study, we want to prove that body fluid balance is altered initially, even when there is renal failure has not set in. So we have used here bioelectrical impedance because traditional methods require use of tritium oxide and Evans blue, etc. And it's a time-consuming and cumbersome method to estimate. So this bioelectrical impedance just takes 2 to 3 minutes to assess the fluid volumes. So early changes in volume is one of the factors that can lead to progress of end-stage renal disease and reduced kidney functions. So there is a clinical value for intervention, and we can prevent progression to end-stage renal disease by controlling the ECF to TBW ratio. These are my references. Thank you.
So it is definitely a novel concept that you have tried to look into.
Yes.
Even the title is beyond our comprehension for most of us who are actually, so you've gone into a research in this topic. Hats off to you. Okay.
Thank you, sir.
So now I wanted to understand, you assessed total body weight and extracellular fluid by a impedance,
Yes, sir. Bioelectrical
bioelectrical
analysis.
impedance. Can you please elaborate on this for the knowledge of all of us on why, how and how it is done?
So bioelectrical impedance, basically the electrodes are placed in the palm of our hands and the feet, and an electric current is passed, and in that we can analyze the skeletal lean muscle mass, body fat, the total body water, extracellular fluid, and intracellular fluid volumes as per the difference of the electrical values.
Okay. How accurate is this?
Sir, it's around 70% sensitive and 90% specific.
Okay.
Sir, in body 520 is the model that we have used in our college.
Is this accepted internationally, or do we have similar standards of these machines?
Yes, sir, there is.
It is?
Yes.
Okay, good. Now, the patients who are included in the study, you said was how many patients?
Sir, 18 as of now.
18
Preliminary
patients.
study. Yes, sir.
It's an ongoing study.
Yes, sir.
What was the cutoff for your proteinuria?
Proteinuria, urine protein create ratio was the one that was taken. So according to our lab, 0.2, more than 0.2. Urine protein create ratio.
So 0.3, no? 300 micrograms.
Yes, sir. According to the our lab calibration, it was 0.2. The calculation came up to.
The accepted standards that
Yes,
are
sir.
there. 300.
More than 300, yes.
30 to 300 micrograms is
Yes,
what
sir.
is the criteria, right?
Yes, sir.
Now, the other point that you wanted to measure in this was, how does this have an impact on progression of renal disease? How it can have a predictor for renal disease?
Sir, there have been studies showing that the more extracellular fluid overload is there will be decreased perfusion to the organs. So that can be told as an independent risk factor for progression of renal disease. So if we can alter reduce the ECF before it is clinically seen,
So
whether it is possible to prevent the progression.
Is this a one-point study that you do? Is that measurement taken as one single point parameter?
Sir, which one, sir?
The body, total
Yes,
body
sir. Yes, sir. 1 point.
Wouldn't you think that there are so many other parameters that would alter this total body weight and ECF in a given individual at given different points of the day based on the fluid intake of an individual, whether the person has had an exercise, not an exercise? So do you think that all these parameters are all
Sir, according
confounding?
to the criteria for measurement for the body composition, we have to take the patient early morning on empty stomach after urinating to prevent any changes throughout the day.
Was this the criteria that you had used?
Yes, sir. It's there as per the body composition, this thing to measure that this is what to be done for the accurate bioelectrical impedance.
Were other causes of hypoalbuminemia excluded, like cirrhosis and things like that?
Yes, sir.
Nutrition and all that?
So nutrition we hadn't looked into, but we have avoided all cirrhosis and this thing. Clinical examination and basic history was taken, and all those were
But
avoided.
clinical examination is not a criteria for cirrhosis.
No, sir.
You,
Cirrhosis patients we
you
have
must
not
have a
taken, sir.
fibroscan and albumin.
Yes, sir.
Okay, okay. So, what was the objective when you set out to do this? What is your end goal in this?
Sir, that using that if we can decrease the extracellular fluid load before the creatinine worsens, like whether we can prevent the patients to going into the end stage, that is progression of renal disease, and we can prevent hemodialysis and other complications in them. And no, sir. Yes, sir. And sir, even this early atherosclerosis and increased cardiovascular mortality is also mentioned in one other study which was done. So even that we can bring down or not is another one of the factor.
I think Sydney sir's students, sir, can you put a little bit more information into the people here to how and what it is?
This is a pretty novel. I was a reviewer from journals. Some idea I got from that. So I thought this is a novel idea, which probably is the early predictor of any vascular changes. That's why I said, why don't you look at this? And with this difference in this ratio, we see this patient having pulse pressure which is going up. So this must be having an impact on the pulse pressure, which ultimately could be a cardiovascular risk factor for all the patients with type 2 diabetes. That was the reason. True. This study needs to be really looked into more carefully, and we just started it. See, it should be, this is exactly what research is all about. Can we do it in our setup? One thing, we can't, look for a sky for our thing. And secondly, is it something novel which we can apply to our population? I think these are the two things. If we look into, I think good research will come out. And it's the last moment I told her, why don't you present this also? So that she's still ongoing, and that COVID had really created a lot of problems. So a lot of things. I appreciate her because this is a difficult topic, but she still did that. I didn't want to. There's absolutely no influence to your marking, absolutely no. Because you asked me to do it, I am telling you.
What is this? Sydney, what is this instrument?
That's the instrument. She will be able to tell better.
Sir, it is basically we have to stand on the instrument. Sir, around this. No, you should like little bit. Photograph. Yes.
No.
Yes, sir.
Yeah, that is there. That is body composition analysis.
Yes.
Just to add on, sir, this instrument is called a body composition analyzer. The nutrition departments usually have this. So what all they look into that analysis, the principle what she told is right. It's based on the bioelectrical impedance it measures. In that report, what they give is along with the weight, calculation of BMI, waist hip ratio, segmental muscle mass distribution, segmental fat mass, extracellular fluid volume. So all that analysis is a comprehensive. It's a body composition analyzer that she has used. In that, one of the indices that she has used is the extracellular fluid to the total body weight.
So this is a routine machine that every one of us use in the clinic, which is a body
Yeah.
But when she talked about using electrodes and other things, so that is not there part of your regular machine. Does not have any of those things.
It's a handheld.
Okay, so the last paper, Dr. Siddharth Sadnani. Could you come over, please? Yeah.
Good morning, everybody. So I'm Dr. Siddharth from KMC Manipal. I'm a final year resident in internal medicine. So this study I'll be presenting is to look at the prevalence of metabolic syndrome in heart failure preserved ejection fraction patient using an H2FF score in a tertiary care hospital in South India. My guide was Dr. Raviraj Acharya, the HOD there, and Prabhu sir also had inputs on this. So coming to the introduction, background about heart failure. The prevalence is around, some studies say up to 5%, 1 to 5%. Subclassification is based on EF with HFpEF being when it's more than equal to 50%. And they have different pathogenic mechanisms, and the treatment varies quite a bit. So it's important to know which subclassification a patient falls under. So the major differences are, and HFpEF patients have older age, and they have the therapeutic, there's no very good treatment available even today, even after the Emperor Preserved trial. So some background. So HFpEF is a complex heterogeneous syndrome. It accounts for up to 50% of all heart failure, which is sizable. And the ERIC study showed that it is up to 70% in elderly people, even up to 77. The three words I'll mention here: a multimorbid patient having a lot of inflammation, causing coronary microvascular dysfunction. So those are the three main things, and then the patient has HFpEF. So in India, the Trivandrum Heart Failure Registry, which is the biggest authority on heart failure in India, they had like 57 patients who had HFpEF in one of their studies in 2020. But they had major drawbacks in their study, that they included valvular heart disease and also infiltrative disorders, which is not true HFpEF. A new National Heart Failure Registry has been established in India, with Trivandrum leading the way, and all AIMS and all premier institutions are part of it. Data is still to come out from there. So gaps in knowledge, I'll just highlight the major points. There's no good prevalence data in relation to metabolic syndrome and HFpEF, not just in the Indian context, also in the world context. There's no effective evidence-based treatment due to the aforementioned factors. And it's a complex syndrome, not easy to diagnose it. We overdiagnose it or underdiagnose it. So no study in India has looked at this H2FF score, which I'll be elaborating on quickly. My primary objective was to assess the prevalence in METES in HFpEF patients using this H2FF score. Secondary objectives were epidemiology, risk factor prevalence of HFpEF, correlation between H2FF and NT-proBNP, and using a modified H2FF score with a BMI cutoff of more than equal to 25 in the Indian context, of course, and to analyze data accordingly. So one major thing, all diastolic dysfunction is not heart failure preserved ejection fraction. A major point to be made here. Methodology, the study design was, it was a prospective observational cross-sectional study, single center based, from Jan 2022 till November 2022. The sample size was 128 using this statistical formula. I can elaborate on it later if need be. Inclusion criteria was adults more than 18 years of age with a clinical syndrome of heart failure with an EF more than equal to 50%. And this clinical syndrome was defined by Framingham criteria. Exclusion criteria, like all infiltrative disorders, were excluded. Restrictive hypertrophic cardiomyopathy was excluded. Valvular heart diseases were excluded, as were primary pericardial diseases and primary pulmonary vascular diseases. This is a modified Framingham criteria where 2 major or 1 major plus 2 minor is diagnostic. Coming to the H2FF score, this is a score which came out from the Mayo Clinic in end of 2018-2019. So this is to help us diagnose HFpEF a little better. It's a very simple score based on 3 clinical parameters and 2 echo parameters. The clinical parameters are, heavy, being BMI more than 30, carrying 2 points, AF, which can be clinically or ECG-wise diagnosed, like a combination of both actually. So 3, that's the highest points that any variable carries. And pH is like 35, PSP more than 35, and filling pressure of the E by E prime, which Sir had earlier, the first study mentioned. I'll be elaborating on that very quickly, more than 9. And elderly, more than 60 years of age, hypertensive on 2 or more antihypertensive drugs. We use the modified H2FF score also to analyze and compare the data with. So based on this, you get a score from 0 to 9. 0 and 1 HFpEF is ruled out. 6 to 9 HFpEF is ruled in. 2 to 5 is where a lot of population lies, and for that we used NT-proBNP to further subclassify them as having HFpEF or not having HFpEF. So exposure assessment was the metabolic syndrome. We use the IDF criteria, which central obesity is the core of it. If you have that, then you look at 2 more, so 3 out of 5 is diagnostic of METES. And 90 and 80 are the cutoffs in males and females in South Asians. Waist circumference was measured standardized weight, top of the right iliac crest in a horizontal plane. Echo, this is like the pulse wave echo which is used, which is majorly even followed today. But it misses out on a subset of HFpEF patients, early HFpEF patients and the moderate dysfunction pseudo-normal phase, where the E by A is more than 1, which is similar to a normal patient. So the E by E prime picks up that also, and the E prime is actually a very sensitive measure. So this is a tissue Doppler imaging, which quickly. So we actually measure it, you gate it around in the interventricular septum, where the mitral valve anterior annulus is there, anterior leaflet, and you calculate the negative wave, which is the relaxation of the septal annulus. So this was the study flow. 128 patients were there, and then using the metabolic syndrome, this was how the statistical analysis was done. So 71 patients had METES, and 57 patients did not have METES in the HFpEF population. Statistical analysis was used, standard methods were used. I can elaborate if time permits later. The results of the study. So demographics, more than 60%, we can see like 61 to 70 and more than 70. More than 60% of patients were elderly. The gender of the patients, 59% were males and 41 were females, which is different from a lot of studies. Clinical features, breathlessness was very common, as was bilateral Krebs. NYHA 4 was the most common NYHA class seen in our patients, and we see filling pressure was seen in more than 120 patients. Almost all the patients had it. Comorbidities, 77% had hypertension, and IHD was sizable in our population, 70%, around close to 70, and type 2 diabetes, 51%. Using the HFpEF score, we had like 101 patients with the classical HFpEF score who had this, had HFpEF, and 105 using the modified HFpEF score. The mean of these variables was like age was 62, BMI was 29, other variables like NT-proBNP was around 3,900. So did we get where we wanted to get? A small step, giant leap, didn't happen. So 55% of patients had metabolic syndrome in our population. Female sex was more prevalent in HFpEF patients, and it was statistically significant. Hypertensive, diabetes, BMI were also statistically significant, more in the metabolic syndrome
Make
group
it faster.
in HFpEF patients. So the distribution of weak positive correlation was there with NT-proBNP level and HFpEF scores also. And HFpEF high probability score meant that you have more probability of getting metabolic syndrome. So to conclude our study, metabolic syndrome was more prevalent in patients with HFpEF. Female gender, higher BMI, hypertension, and type 2 diabetes was significant. H2FF score and modified H2FF scores positively correlated with NT-proBNP levels. High probability of H2FF score was associated with presence of metabolic syndrome. The discussion of my study, we looked at, like, this was a study Ganpati et al., which from Trivandrum.
I think we'll summarize.
Yes, sir. So IHDs, there were some differences. There's no direct correlative comparative study presently there, even abroad, which has looked at these parameters together. So that was one thing. Strength and limitation of the study I will just highlight on. So the limitation was small sample size, so generalizability, external validity would not be there. Cross-sectional study, causation not possible. Observer bias, echo measurements cannot be ruled out. Selection bias may be present as less females with HFpEF in our study. Tertiary care center and more CAD patients may explain this in our study. Missing some data on NT-proBNP and lipid profile, but we did data imputation, and there was no problem with that. So first study to our knowledge in India to use H2FF scores as a means to diagnose HFpEF, proven to be sensitive, specific, as well as predictive of prognosis. Exclusion criteria were designed to select actual HFpEF patients, not all diastolic dysfunction. There was no loss to follow-up. Data, majority of it correlates with other studies. No random misclassification of outcome or exposure, and a modified H2FF score is put forth. These were my references. Thank you.
Your criteria for the heart failure with preserve H2FF.
Yes, sir.
You said it is more than 30.
My criteria, sir?
Yeah. the H2FF
H2FF score, sir.
was more than 30 for heavy.
Uh,
In the criteria,
yes, sir. More than 30, yeah. The BMI more than 30.
But that is not acceptable in India.
Yeah, so I used a modified H2FF score. I calculated that all data was computed based on the actual H2FF score and the modified H2FF score, where the BMI cutoff was used was 25, sir.
Oh.
So we analyzed data, and all the data, all tables that were produced were both the H2FF as well as the modified H2FF scores.
So you said this is the first study that is being conducted in India using
the H2FF score, even right now, presently, sir. Yes.
Okay.
It just concluded study, sir.
And what was the correlation between the NT-proBNP and the score?
It was a weak positive correlation of 0.24, sir.
Okay.
Yes, sir. Yes.
Okay. And you also mentioned that in the METs
yes,
components, which was the one that was the highest contributor to this? Was there any sub-analysis?
Yes, sir. There were like hypertension and waist circumference were the highest predictors in the METs components, sir. These two were more predictive than diabetes and other parameters.
Waist circumference and?
Waist circumference and hypertension, sir. The presence of hypertension.
Yeah, so the various criteria, can you just run through that slide, that modified FF score?
Yes, sir.
Go back.
The score, do you want to look at
Yeah,
the score,
yeah.
sir? Okay, sorry. This is the score.
Okay. It is a good study, Dr. Siddharth. Nevertheless, you lost out on time. It was probably a lot of data that was there in it. Your presentation was also good. What's your take? What's your recommendation going forward?
My recommendations are metabolic syndrome. Like, I think one of the main things that people don't do studies with metabolic syndrome is, like yesterday somebody was mentioning, no one wants to carry a measuring tape. I needed to do that for all my patients. So there's less data on it. So I think metabolic syndrome is a risk factor for heart failure, preserved ejection fraction. We need to acknowledge that, and further better studies need to be done looking at that, because at core of HFpEF and metabolic syndrome is inflammation, and that leading to coronary microvascular dysfunction leading to this. So if you understand it better, we can look at better therapeutic targets, as we have no proven treatment for HFpEF even today. Even empagliflozin is, if you do look at the composite endpoint, it was mainly to do with hospitalization than with mortality. So we don't have definitive good treatment. So we need better treatment for HFpEF patients who are actually 50% of heart failure and are actually, mortality is also comparable to HFrEF. So we need better therapeutic targets. So metabolic syndrome can be looked at it also, and a good score to diagnose HFpEF better, sir. Two important takeaways for my thing, and later on therapeutic step. So a very, very small step maybe in the right direction.
And on a lighter note,
yes, sir.
What you are saying is quite frightening.
Yes.
In this room, except for Srinath and Sydney, I don't think anybody else fulfill this criteria.
Yes, sir.
My question would be, if the cardiologist is sitting and doing an echo, either we have referred them or the patient has themselves gone.
Yes, sir.
So, do they mention this score anywhere?
They are also presently, after I did the study, one of the cardio registrars in my college, my institution, is looking at doing a study using this, and there is another score which the ESC has come out with, which is called the heart failure HFA PAF score. So they also, one of these scores is actually recommended by presently in all diagnostic algorithms by even JACC, ACC-AHA, as well as ESC.
Okay. So the next time, I think my takeaway from this would be that we should suggest cardiologists to do this score.
Yes, sir. And
all the
should
patients.
More importantly, sir, you need to suggest them to actually, first of all, start doing E by E.
They are cardiologists. They'll not listen to anybody. It's very difficult to convince them. It's not that easy, as you say, in a research
But
thing.
E by E
Either
prime
ways.
is, the most difficult thing that I found. A lot of people are not calculating that also.
Okay, thank you.
Thank you.
I think we'll wind up.
Another small comment, lighter note.
Yes.
Whenever you say HFPF, I feel huff puff. Huff puff while walking. So that correlates with your study, I think.
There was one joke which was going around that nowadays there's a lot of talk about mental health. So just try walking 4 stairs. You'll forget your mental health because you'll be so much breathless.
Yes.
So that is very important.
Thanks a lot, sir. Thank you.
Congratulations, Doc. Let's have a huge round of applause for all the members who have presented today's presentation today, and also for all the members who are there in the audience today, which shows a humongous interest in the clinical research aspect that we have. So as Dr. Sidney has been pointing out, one of the core objectives of a conference of this nature, and especially the RSSDI, is to promote this concept of research amongst young scientists like you all. And if this is taken on a day-to-day basis, I mean, we do not have to, as Dr. Sidney said, it's not the absence of grant or the resources that are available. The amount of patients that each one of us see in our chambers is humongous clinical material. And if we are able to harness our resources properly, and they are able to curate the right kind of a research material, we will do yeoman service to our public and have immense amount of recommendations. We will stop quoting ADA references, EASD references, criterias, and those kind of stuff. Those guidelines are not meant for us. Our patients are different, we are made differently, and we need to have our own criterias, and we need to have our own guidelines to make sure that we are able to promote this. And how do we get out of this? It's with such clinical research like this. So a huge round of applause to each one of you. Please carry on this momentum. We encourage more and more people to take up this in a very passionate manner, and we will always be there to support you all in all your initiatives. And RSSDI has taken it in its major mandate that it will support all the required grants right from the state to the national chapter. So huge applause to each one of you, and closing remarks from our senior consultant, Dr. Sidney.
Thank you, and one or two reflections. Before I do any of those things, I want all of you to give a loud applause to our judges. They were so critical, very, very focused, and the comments were very much required. And this is exactly what they have done. They have done the job so beautifully well. I was very much, if I were a student there wanting to present that, I would have refused to go to the dais and presented it. Because that criticism was very, very much, very critical. And this is exactly what you require to. Don't get worried about the criticism, that is required. Number 2, you don't need big things to do research. All that you require to ask a simple question, what is it, something different? Has it been done in the past? If it is done in the past, what is the gaps that you are going to look at it? If you do that, I think any research paper will come. And there are enough and more people who will be prepared to help you out. And today's presentation, each one of you have done so well. I am really proud of all of you. It doesn't matter whether you get a prize or not. It is simple. See, I had a student of mine who was a little eccentric fellow. He wouldn't come to the class, he wouldn't do nothing. If you ask him after the class, did you understand anything? He said no. In front of you, he will say no. And the worst part is, just before examination comes, so I don't want to appear for examination. I say, why? Whatever you people teach is all wrong. I said, see, we have a human brain. Your brain is a little beyond us. It's an Einstein brain. So you are not fit for this. You should be a researcher. Because he refuted the Newton's law also. In physics, I said, heart and Newton's law doesn't go together. This is what he told me. I thought this fellow is nut. So I said, see, even if you want to become a researcher, if you don't have a basic degree, nobody will accept you. So finish. He said, yes, I will do it. He passed also. Thereafter, he never did his internship. He was in the IIT, sitting with them. After 1 year, he comes back. So I want to do a project with you. I said, do it. He did. Why people with diabetes don't get gangrene? They stand. All of us stand. Do we get gangrene? We don't get. He said, why only diabetics get gangrene? So he said, I'm proposing a different theory. So he started with his own theory. And he said, because this is known as chaos theory. This chaos theory, he says, when we stand, we go on shaking. So the foot pressures keep changing because of our nervous system, the autonomic nervous system. But in a diabetic, because it fails, the pressure becomes static. And that is why you get so much of pressure. And we will try to prove this. I said, I'll give you my patients. I got enough and more of them, I'll give you. Those are the 1990s, not now. Even mobiles were not available. So he had to make a stand of glass. And who would stand on a stand of glass? The patient would never stand. But he saw to that it was very sturdy, and he bought a video camera and put it under and shows how the whole thing changes in a normal person and patient with diabetic neuropathy. So beautiful, and it got published in a best of journal, the Science, and also he got the first prize by DST. What do you know what DST is? Department of Science and Technology, gold medal. He came and showed me. I said, this is for you. I said, no, this is for you. This is technology. This is the brain. Now I don't find him. I don't know where he is. I must go in search of this boy. But that is exactly what research is all about. Just things, a simple thing. Thereafter he goes after it and gets it done. And this is exactly what I want these young people. We couldn't do it, so that's why I want to promote this to you people. You start doing it. Thank you very much.
Thanks for the encouraging words, sir. And I should say, sir has convinced his institution to give a cash prize of 10,000 rupees for the best paper of this conference. So that will be announced a little later. So another 3 people have requested for presentation. For the interest of time, we couldn't accommodate them. So anyway, they have been given a chance to present it as a poster. And with this, we'll wind up this presentation session. There is a presidential oration going on in the main hall. That we will do it after the oration. Yes, yeah. Okay, so we should be there for the presidential oration. Please, kindly. So there is a talk about the biostatistics, yeah. So we'll come back, and so that would be a very interesting and important session too. The statistics is very important. So after the presidential oration, please, most of the researchers, scientists, students, please come back. Once again, welcome back to Hall B, and without much wasting time, I slide again. I welcome Dr. Madhu, who is a professor, Department of Community Medicine, JSS Medical College, and Deputy Dean for Research for JSS, and please welcome. This is a talk about basic statistics. So it's a very important thing for the young researchers to be aware of the statistics and how we can. Most of the research is based on statistics only. If the statistics is robust and we understand how to bend it to our use, not convenience, so it will be much more, we can generate much more data and much more research papers. Thank you, ma'am. Please come.
A warm good morning, and I bring greetings from JSS Medical College and JSS Academy of Higher Education and Research, Mysore. I thank the organizers for giving me this opportunity to share about my few thoughts on the basic biostatistics for clinicians. This is a 2-year course which we offer at JSS Academy of Higher Education for in the name of MSc Medical Statistics with 20 minutes that you are time given. I will try to do justice, giving a bird's eye view of the topic. At the end of this session, I hope all the delegates will be able to identify various data and the statistical variables, differentiate between descriptive statistics and inferential statistics, try to understand the different types of graphical presentation of the data, and understand the availability of various statistical software for data utilization. And most important, clinicians develop statistical thinking in their clinical practice. To begin with, I would like to ask these questions. As a clinician or as a practitioner, what questions do you encounter in your day-to-day clinical care? Suppose if you're seeing a case of fever, which disease will be your first clinical diagnosis? Would you think of malaria or dengue? Okay, if it's somebody from the coastal Karnataka, they would think malaria. But if I'm seeing the same patient in Mysore, my first will be dengue, because as per my knowledge, I use the knowledge of prevalence that over the past 3-4 years, I have not heard of any malaria cases in Mysore. So that would be. So here I start using the proportion or prevalence, the simple statistics in my clinical care. Next, every year I encounter episodes of asthmatic attacks in my allergic bronchitis patients. So I want to know, did this episode increase this year, or was it the same, or did it improvise, or it increased? So I would like to know what was the incidence of these episodes of asthmatic attacks in my patients. So again, these are numbers. How many of my diabetic patients have complications? So maybe I'm treating around 100 patients per month. In that, how many of them are having complications? How many of them are not having complications? How is my care being delivered to them? Again, it's proportion and percentages. Or you have tried a new combination of therapy for 2 groups of your patients. For one, you would have asked them to take only medications. For another group, you would have asked them to take oral medications. Along with them, ask them to do yoga. After some time, you see there is a difference in the blood glucose in these patients. Now you want to interpret that. How do I interpret my observation? So the answer would be compare the mean glucose between 2 groups and apply a simple statistic test. So wherever our clinical care and observations are coming, the use of these numbers in the form of percentages or means is a way to give scientific value to it, or what we call as giving evidence-based clinical medicine. So this is our day-to-day life, and with simple proportion or percentages and simple mean calculation, we start our statistical analysis. This was one study sponsored by ICMR for one of my students. So first step, what she did was she just took out the percentages of the 970 students whom she had done the study on. Simple basic statistics, calculation of percentage. With this, it was only describing the study population. Further, what she did was she looked into what was the gender-wise, male and female-wise exercise pattern that was happening in these 970 students. So here, male, female, she has observed some percentages. So similarly, she looked into the course-wise, MBBS, BDS, pharmacy, engineering, and commerce, and took out the physical activity parameters, like sedentary to 5 times a week. Now she had to derive some value from this percentages. So what was done? A chi-square test was applied. She found out the p-value, and with evidence now she can say that the proportion of females led a sedentary lifestyle. That was almost about 58%, whereas the proportion of males, that 12.9%, or more than say around 50%, at least do 3 times a week of physical activity. So this becomes an evidence with scientific content being justified. So similarly, here the next way, in another study where around 8,000
school-going children were analyzed and looked into, what is the proportion of malnutrition, overweight, and normal BMI they have. Somebody told me, one picture speaks 1,000 words. In the previous two, it was tables, figures, and only numbers. It could not attract the attention of my audience. So in this, if you see in one picture, locality-wise, male, female, numbers, percentage, everything is depicted. It's easy for me to convey the kind of study subject that was there in this study. Similarly, in one figure of this, we have compared the WHO and IAP criteria for BMI. In BMI, they use this percentiles, 3rd percentile, 5th percentile, 50th, 97th, 95th, like that. Anybody less than 3rd percentile is considered undernourished or underweight. More than 90th is considered as overweight. Between this is considered as normal. So we also compared between males and the boys and the girls, and also using the two criteria. So graphical presentation is another way of presenting it to the audience or whatever data or research that you have done in a simple way. So all this is nothing but statistics. We just get the fear that I chose medicine because I didn't want maths. But if you see in reality, every day we do apply knowingly or unknowingly the knowledge of mathematics. So statistics starts right from the collection, classification, presentation, analysis, and interpretation of our numerical data into something which we want to infer from. We want to give out a clinical relevance to whatever we have observed. So when you apply these principles into the biology or more so the medical related data, it becomes biostatistics or medical statistics. So to say that it's the key to conduct new clinical research, and it's one of the foundations for evidence-based clinical practice. So how did all this start is, if you see the 18th century and the early 19th century, that was where the germ theory was getting into, evidence was being generated. People did not believe just by whatever somebody said. They wanted something logical to be understood. So he was the person, Pierre Charles Alexander, who introduced this numerical method in medicines. Whatever he did, he gives certain numbers. Simple they started was with proportions, and then simple analysis of calculation of means. So all those things, where to do percentages, where to apply means, is first you have to know what is your type of data, how you want to present it. So broadly we can classify these variables as categorical or numerical. So when I say these were the number of males, these are the number of females, I only name it. Or these are the number of diabetic patients, these are the number of patients who don't have diabetes, who have hypertension, who don't have hypertension. I name them under a group, so it's a nominal data. If I'm able to categorize my patients, those data into like stage 1 hypertension, stage 2, stage 3, and cancer stage 1, stage 2, stage 3, or if there is an order, so I call it as an ordinal data. There will be certain data which I will only be taking it as discrete numbers. For example, how many episodes of hypoglycemic attack my patients had. So it's a discrete count. In 1 year he would have had 3, or he would have had 5 or 7 or no. So it's a number. So 0, 1, 2, 3, 4, it's discrete. When I want to measure and I want to analyze the fasting blood glucose level, postprandial blood glucose level, HbA1c values, which are like you can get it as 120 fasting, 121, 122, 123, these are continuous. So I categorize them as continuous. If there are an interval which is very much defined between one to the next, we call it as interval. If there is a ratio between the one value to the next value, we call it as ratio. But for all statistical analysis purpose, just remember these two, categorical and numerical, and these nominal, ordinal, discrete, and continuous. For analysis purpose, for simple basic analysis purpose, these data can be categorized into quantitative and qualitative. Quantitative, what I told is the continuous, and qualitative is what you can count. So those are discrete and countable. So these were the examples I gave. So what do we first calculate is mean, the basic statistic. Here, if it's qualitative, it is proportion or percentages. If we ourselves collect the data from the patients directly, one-on-one basis, we call it as primary data. But if it is obtained from medical records or already published data from the journals or from other databases, we call it as secondary data. So this entire picture is what is the real statistics. We all are here as researchers because we are interested in this big diabetic population and the various research questions we ask. But it's not practical or possible for anybody to do the study on all the diabetic patients that are there in the world. So we are capable of doing our study on a small sample, could be of 100,000, 10,000, lakh, based on our capacities and the funding we get. So we start everything or whatever we observe is in this small sample. So I told we have only two types of statistics, descriptive and inferential. So descriptive is to simply calculate percentages and means of what research question we have asked. So either you summarize, if you have done your study on 100 patients, you summarize it either into a numerical, percentages or mean, or give a graphical summary of the sample. So most widely used sample descriptive statistic is sample mean and sample proportions. From this, using our inferential statistics, the so-called chi-square test, t-test, many tests are there. So we would be estimating our parameters, which are nothing but what is in reality of the world. So here we will get the population mean and population proportion. So this inferential statistics is like what you have done on a sample. Based on your inferential statistics, it's generalizable to the whole diabetic population. Descriptive statistics starts with only two things, measures of central tendency and measures of dispersions. For ease and simple of understanding, measure of central tendencies, remember that it has got to do something which is at the center. Or if we have done it on 100 subjects, we want to know what is the average. So for calculation of average, these are three ways in which you can calculate the average: mean, median and mode. Mean is nothing but it is one single figure where you take all the 100 values and divide it by 100. So you get that mean. Whereas median, what it does is, median will distribute this entire observations into two equal parts, 50 that side and 50 this. Whatever value comes in that central will be taken as the median value. So similarly, the mode is out of your 100 patients, how many of them have the most common value? That will be taken as mode. So it depends on the type of data and in what situation you have to use. Commonly in statistics, we use mean 80% of the times. Sometimes in 20% of the situations, we will use median. So I just gave an example here. You would be interested to know what is the mean HbA1c value of my 100 patients who are on a particular anti-diabetic combination. Somewhere if it comes 6.8, probably you have calculated a mean. So I told descriptive statistics, the other part is the measures of dispersion. So what does that dispersion mean? So we have calculated one central value. But what about the other 99 people's values? How is it varying from that central is what dispersion says. So three common measures of dispersions widely used in applications are range, interquartile range and standard deviation. To understand the range, it is nothing but what is the maximum value and what is the minimum value for those 100 patients that we have looked into. If you take the interquartile range for the same 100 observations, if I divide it into 4 equal parts, it will become a quartile. The Q2 is the median one. So 50% are this side, 50% are that side. So I can call it as median, Q2 as median. Yeah, okay. So whatever is at this Q1, we call it as first quartile, and what Q3 and above is called as third quartile. So if you see, majority of our observations, nearly 50% of our observations will be around this median and between these interquartile range. Now if you take the standard deviation, always they'll say mean plus or minus standard deviation. What is that? So you have calculated a mean. When you say one step plus or minus some value of one standard deviation, it means that 34.1% of the observations or values are on the right side, 34.1% of the values are on this side. So within 68% of the values will be around that particular mean. So this is the descriptive statistics. What is the message that you have to remember here is, when you are applying statistics for any of your analysis, if you use mean, use the dispersion plus or minus standard deviation and represent it like this. If you are using median, use interquartile range and represent it like this. Always biostatistics goes with epidemiology, or epidemiology and biostatistics are linked together. So if you have understood the epidemiological study designs, there are certain basic questions, and you would have seen this right from undergraduate level. So what is that you have to get inference from this and link it to biostatistics is it I am describing one study group, or am I analyzing and comparing two groups? If you are using only one group, like for example a case report or a series of patients of a particular type you are just describing, or you are describing a particular disease condition with respect to time, place and person. So it's usually a one group, and most of the time it's one group where percentages are more commonly used. If you are comparing, so it's an analytical type of study design. Either you are observing something or you are intervening something. If you are observing, in a cross-sectional study, you have one time you go, you observe them, and you make them into two groups, those who have complications and those who don't have complications. Whereas in a case control, you have again two groups. First, you will identify a particular group of patients who have a certain condition. Similarly, you will take an age and sex matched control. Whereas in a cohort, you have two groups of people who are exposed to a certain risk factor, who are not exposed, where you will follow them up over a time period. So these are two groups again. Obviously, in experimental study, we have one which is a control and another an intervention. So all analysis with these type of studies will have two groups majoritarily. Here it will be single group unless specified. So after knowing that, this is where our inferential statistics starts. So tests of significance, what we call, either it should be a parametric or a non-parametric. How do we determine if it's parametric or not? That is determined by the normal distribution of the data that you have calculated. It's not rocket science to know, okay, whether it's normally distributed or not. I told only two things that we have to remember is mean, percentages. So for normal distribution, look at the mean and standard deviation. If your standard deviation is higher than the mean value, then it's a non-normal or it's not normally distribution. Your standard deviation should always be less than the mean value. So make a choice whether it's parametric or non-parametric based on the normal distribution. Then remember this simple slide. Okay, now I have my samples. Maybe I've collected 50-50, 80-80, 100-100, 90-90. Ask the question whether it's normal or not normal. Look into the mean and standard deviation. If your standard deviation is very much less than the mean value, yes, it's normal. If it's not normal. Then what is this paired, unpaired is another question. Paired means if you repeat it in the same group. Like for example, before giving a new treatment and after giving the treatment, what happens to the blood glucose value? On the same group of people, you are measuring the blood glucose before and after. So we call those groups as paired. If it is different, like I have one group who is on one type of medication, another group who are on another type of medication. There are two different medications I am looking for. So then it is unpaired. If it is two group, it is t-test. If it is more than two groups or three and above, it is ANOVA. Similarly, here also t-test and ANOVA. Whereas if it's not normally distributed, there are names for it. The name is not important. What is the science behind using that particular test is important. So if it's two groups and if it's paired, Wilcoxon sign rank test. Can it take some more time, 5 minutes? Okay. If it's more than that, it is Friedman test, and unpaired Kruskal-Wallis test. Just to remember, it's not going to make huge difference if this is changed, this is changed. Only the p-value and the kind of interpretation that you get or the background in which this analysis has been developed will be varying. Another common thing which we do in our research studies is finding the relationship between variables. So in that, when we are doing the relationship between variables, first we have to know what is an dependent or an independent variable. So I've taken an example here is, I want to know what is the effect of X on Y. So X is the lipid lowering drug and Y is the individual cholesterol level. So Y is equal to x1 plus x2 plus x3 plus x4. It's a regression analysis equation. For simple understanding, the cholesterol level depends one on the lipid lowering drug the patient is put on. It also depends on many other factors. The duration of diabetes, whether it's a male or a female, the age of the patient, other coexisting morbidities, and so on and so forth. So understand that when we are looking into relationship like that, the same data has to be looked in the form of dependent variable and independent variable. So anything you start when you have to look into a relationship, first look, are they correlating? So what is this correlating? One example you would like to give here is, so you want to look into the dose of the drug and the cholesterol level. I take the dose of the drug on the x-axis and the cholesterol level on the y-axis. As the dose increases, does the cholesterol level increase or decrease? What is that I want to see? If it increases and the cholesterol level comes down, it's a strong negative correlation. And another way, the number of hours of walking. I'm walking every day 3 to 1 hour, 2 hour, 3 hour, like that I'm increasing. My cholesterol level is getting reduced. So it's a inverse. So that is what will be told by the correlations. So after this correlation, you can have various types, like if your value of correlation coefficient that is calculated is 0.7 and above, we call it a strong positive. If it is less than 0.2, it is called weak positive correlation. How do we determine if it's positive or negative is the sign. If it is value is plus and above, it is positive. If it is minus, it is negative correlation. Then if it is perfectly zero, somewhere or nearing to zero, that is no correlation. A perfect positive correlation is +1. A perfect negative correlation is -1. After looking into the correlation, we go into this regression analysis. I told you the cholesterol level is not mattering only on the drug he takes. It depends on the various other factors, because human beings are not only one parameter. They are a combination of various other variables and parameters. So we calculate this regression line or an equation which comes, which says that if, for example, in this they are looking into the percentage fat based on the BMI. But you can add other components also, like the type of drug they are taking, the dosage, the duration, all those will matter in analyzing the regression. So regression analysis, I can say it's a multivariate, more advanced, and you can get better interpretation of the relationship between the variables. After analyzing the relationship between variables, the next common where you would like to look into is with respect to time. This survival analysis started with what is the average time a person lives from birth. But now with the application to the patient care, it can be used like widely used in cancer treatment. Like after treatment of cancer is started till the time of death, what is the time? But we can use it to other conditions. Like for example, time of detection of diabetes to development of complications, if you are following your patients over a period of time. Or time of HIV diagnosis to developments of the full-blown AIDS condition. Or from the time of admission to hospital for a particular condition and how much time they take to discharge. So these are all under survival analysis, though the name is survival because it started with looking into how long people will live. But it can be applied to this based on the principle. The analysis that goes in the survival analysis is the Kaplan-Meier analysis. It's simple to understand that what's the probability of these number of patients over a time period of follow-up, how many will stay along and how many will drop out from that follow-up period. To summarize, we saw descriptive statistics, inferential statistics. Descriptive statistics, measures of central tendency, mean, median. Measures of dispersion or how our data is spread, range, standard deviation, interquartile range. You also saw inferential statistics if it's 2 groups or 3 groups, simple, Z-test, ANOVA, T-test, chi-square, Mann-Whitney U test on the non-parametric side. In multivariate, correlation, regression and survival analysis. But most important question all the PGs or anybody would look is what is the p-value, what is the p-value, right? But how much importance should we give for that? Look at this example. A postgraduate was very much enthusiastic because they were looking on a new drug. They tried it on 500 patients. It was a new antipyretic. What they observed is, okay, this is the mean, this is the standard deviation. I've got the p-value. P-value is less than 0.05, very excited. The guide asked, okay, yes, there is a reduction in temperature, but is it really making clinical relevance? The decrease was only 0.63 degrees centigrade. So always, even though you get a p-value, look into the clinical implications of that interpretation. These are only numbers. Statistics, softwares, or statisticians will be only looking into the numbers and analyzing your data. It is who you have to give that meaning for that clinical relevance that is having from your data. Another common thing which we encounter in our practice is we are dependent on certain screening tests. We are dependent on point of care tests. But every time there's a question, what is the quality of these tests? How valid are they? Based on those, can we make a clinical decisions? Every time you bring in something new, that's the question. How do we answer for this? So widely used analysis is sensitivity and specificity. So to just why the sensitivity and specificity, or what is the background in which how it is calculated is, we have 2 groups of people who have a disease or a condition, who don't have a disease or who don't have that condition. When we do this test in them, out of those who are deceased, whoever comes the positive, we call them as true positive, and if we calculate that percentage, it becomes sensitive. And similarly, among those who don't have the disease, and when we apply this new test or a point of care test, how many of them are truly showing that they don't have the disease becomes the true negative, and that's the specificity. But more important, what we also have to look is this predictive value of a positive test. What do I mean by that? If I am doing a point of care test, if I am doing a screening test, what is the probability that it is going to say how many of them are truly having the disease? So if you see that, out of my total test positives, that is A and B, how many of them are truly having the disease? So along with that sensitivity, specificity, calculation of predictive value of a positive test is very important when you want to clinically say that yes, this test can be used as a screening test or as a point of care test before they come to the hospital. The next question, we are always encountering with biochemical cutoffs. How did they derive this? Is this okay for our population? Is it right or is it wrong? So this is based on, again, of the same principle. True positives, true negatives. This graph I've just tried to explain. Our lab values, if you just put it on this range, we can categorize them into normal range, abnormal range, and this is one small area where you have to draw the cutoff. How is that based? This is the healthy population or people who don't have that particular condition, who are true negatives, means they don't have that condition. These are a group of values of diseased patients. For that particular biochemical value, they are known as true positive. Identifying this point, where you have minimal false negatives, minimal false positive, is where the cutoff value is developed. So there, for that lab value, you start looking into the clinical relevance or the measures, how it's being, or the clinical presentations are happening. So for this, they do this ROC curve analysis, like for various cutoffs, how are we getting the true positives and the true negatives.
Sorry, ma'am. With the interest of time,
Yes,
can
sir.
we wind up? I feel like my dad is taking me away from my ice cream shop. Your presentation was so good, but with the interest
Just
of
few,
time, yeah.
the last part, sir. 2 minutes. Yeah. So the last part is the graphical representation of data. Picture speaks more than the words. So these are what you all have been known about: bar diagram, histogram, pie chart, comparative. But what I want to show is there are softwares available like Tableau, JMP software, Python, where you can customize your own data sets and you can give visual analytics like this. Very easily in one slide you can give the entire type of descriptive analysis you want to picturize. Similarly, which has been done for patient satisfaction dashboard, you can develop it for the patient care, the department-wise, specialty-wise, occupancy-wise. The Python, where you write simple codes, you can look into the data visualization. And if you look at this, it's so robust. Different kinds of analysis and interpretation to make even the simplest, smallest data very meaningful and visually appealing for the audience. So there are softwares which are available which will help you to do that. JMP is one such software which gives you the entire spectrum. We are proud to have that JSS has this facility. All kind of advanced analysis for every patient data will be utilized, and it will also analyze the text also and the huge time series data over months or years that of a particular patient also. So lastly, yes, evidence-based practice is important. It emphasizes on the systematic collection of data and the generating of evidence. It is important for the critique of scientific literature. It helps in comprehensive care of any disease. It helps in identifying risk factors of disease and health events. So it will help you to identify the efficacy of a drug or combination of treatment, interpreting your screening test, identifying new clinical syndromes. Last I want to say is, whatever I've presented is just a tip of the iceberg. Statistics is huge. It's only that you have to develop an interest and you can start analyzing looking into all the angles how the data or the clinical evidence can be generated. I thank the organizers for giving me this.
Thank you, ma'am. Thank you. Any comments from Sydney, sir? Anything, sir?
She put the whole thing in perspective, I think simplified very nicely. But one thing, some brains don't accept mathematics. That's exactly what statistics is all about. For some people it looks very simple, for others it just doesn't go in. So, I know. I think after my 10th standard I threw all my mathematics books out.
So that's why I told the graphical representation. You just don't want to do anything. If you are able to apply, it will really give a beautiful.
Yeah. End of it, everything looks beautiful. I know. To go till there is a problem. But it did very well. Thank you.
Thank you, ma'am. Thanks for the excellent presentation. I think for the past 2 days, with the name of Research Society, I think your presentation is a excellent, conclusion of this conference. And with this, could you please, the quiz participants stay back in this hall. Others can please go down to the main hall, the hall A. So there is a presentation here about the nutrition and the lifestyle modification. After that, maybe 15 minutes later. So quiz participants, please stay back here.
Well, it's very, very heartening to see almost the last bit of session in this hall. And it is full, and we ordered some more chairs there. Lifestyle. So this is one of the things which is close to the heart of mine and which I really wanted to do it. And mind and body happened in the morning, and it was really a good session, which a good feedback. And it's not just a, it was not just an exercise or an yoga session. we evaluate and get back to you. So in continuation with that, we are talking about lifestyle disease. I spoke on diabesity, and just now Dr. Sattur's oration, he told the only options other than lifestyle, there is an option, that is hospitalization. So in continuation with that, I invite everyone for this lifestyle symposium. And since I need to be shuttling, my friends will moderate. We have Pariksha Rao. Must have seen her in the social media quite a lot. She's a nutritionist. I welcome her. And Mala Gurappa, she is there. She's there, okay. And Dr. Samir. Can we play the slides? No, introductory slides. Dr. Samir is a very interesting character. MBBS and then into physical medicines, more into it. Lifestyle is his fore. Dr. S.R. Arvind sir has spoken very high about him, and he said he should be there, and I said, fine, that is one of the things which interests me and definitely interests every one of us. So he is with us and is associated with St. John's. And my good old friend, not old by age, but by our association, maybe from class 5, Dr. Prem Kumar is a professor in Kempegowda Institute of Medical Science. and my running partner, and sometimes partners in other crimes too. So I will hand over the session to the team. We will keep it very interactive. We will not run 15 slides into 4 and bore you. A lot of practical aspects will be discussed. It will be a definite eye-opener for even ourselves, even though we think we know everything about diabetes or nutrition. Over to Pariksha. Thank you.
Good afternoon, everyone. Like Dr. Manohar mentioned, we have a wonderful case that we can brainstorm with and understand the role of lifestyle modification. I invite Ms. Vimla to moderate this session.
Thank you, Pariksha. I would like to call upon Shyam Narayan, who's been our patient. He's been newly detected for diabetes, and he started his lifestyle modification and the entire treatment last month in the last week of November.
Mr. Ram Narayan is a very enthusiastic person. We spoke about lifestyle to him. He not only accepted and got his family involved, and he said, I want to spread this awareness. We are very, very thankful to him and his better half. Both can join us, and we can have an interactive session, what went through their mind, and many other questions. I see a lot of senior colleagues of mine being attentive, so I think it will be very exciting.
So we have a 40-year-old male. I'm sorry to put it this way, but he's an engineer. Had a sedentary lifestyle like we all do, given a job profile or a day-to-day work routine. Self-perceived stress levels were at a level of 4 when we asked him that, on a level of 1 to 5, how do you perceive your stress levels? Mother is a diabetic, so there is some predisposition. Stress of diagnosis was definitely there. He sleeps well. Definitely he's observed over a period of time that fluctuating blood sugars leads to a poor sleeping pattern. Medication, he was only on blood pressure medication, and once Dr. Manohar started meeting with our patient here, understood that he's at a borderline of starting with all the complications, and that's where the lifestyle modification was prescribed. Understanding that he's an amazing individual who's taking wonderful control of his health, I just have one question to Dr. Manohar, that what made him motivated enough to put him on a lifestyle medicine?
Lifestyle is coming back as a big thing in our practice. I must say that. We usually write diet, exercise, I always write, but do we really detail on it? Do we have the time? Or do you think the person sitting on the other side of the chair has the interest? Or does he think it is important? So what I do in my practice is, we are associated with a lot of lifestyle coaches, and I keep running, and many people would like to, interested to be joined, we can do it. So first is in our initial conversation, look at the pulse of the individual, how much really is interested in listening to you. Otherwise, say I'm being practical. If someone you talk to him and he is not interested, I don't want you to waste your 5 minutes on him, honestly. It's important. See, this is what I have done, this is what some people have done, and reverse the diabetes. If not reverse, they've gone into remission for some time, or they've reduced the medications. If nothing else, their risk of getting into complications, definitely, we have seen in the yesterday's talk also, even you may not get to the goal in every aspect, but your morbidity, mortality comes down. So once you talk to that, and you see the response, what I do is, I always guide them to our nutritionist and tell, please meet them. There is no additional cost, because some people they spend everywhere else, but for a dietitian, they say, I know everything, I'm 20 years diabetic, you only tell me or give me the paper, I'll read it. They won't even look at it. Maybe they go back, taking a snack and folding that diet chart onto that. So when I met him, he was, see, if you look at him, he is not obese, but he is interested. Because in our short conversation, we made it clear that it will be beneficial not only for people, we were talking about vaccination. There are vaccination at individual diseases, but there is a vaccination for non-communicable disease. That is lifestyle changes. It will not only help your diabetes, but many other things. So he was so inclined, willing, and he has encouraged everyone around him. And thanks to him, he said, I would volunteer and come over here, and he is there since morning, 7:30, attending our sessions, mind-body workshop. Thanks a ton. Over to you. So what did you feel, and what made the difference?
Yeah, basically, a number of times I have gone to Dr. Manohar himself, and number of times he's told me, you're in the borderline, I have to get you into medication next. Your HbA1c levels are high, you have to get into medication unless you make lifestyle changes. He's told this to me about 4 years back as well. But, I personally, like he mentioned it, I would take that saying that, he's telling that, but I think I'm following a good lifestyle, so let me just follow it. I don't think there's a problem in it. But, over a period of time, I observed that HbA1c levels are just going up. And this last time that I met Dr. Manohar, that was about a couple of months back, he told me, I think, why don't you get into a lifestyle change? Why don't you look at putting up a continuous glucose monitoring system and then make changes to your lifestyle to see what effect it has and, what happens to you. It looked interesting. It made a lot of sense from what he told. So I said, let me jump into it and let me see what's happening with that. And, it made a lot of, when I started ultimately, they've mentioned that I'm an engineer. So engineers tend to respond to a lot of data. You must have seen that. And it's not only engineers, a lot of people who work around, they respond to data better. We want to see data. So when we take our readings of sugar, say once in a week, or sometimes a couple of times in a day, where you take the morning reading and then the post prenadial, it's only telling you something, and it's really not motivating you to make many changes. But when I put this CGM on and the data came out, there's a lot of realization which came out from that. My HbA1c levels were high, but I was seeing that my morning levels, that is morning sugar levels were it's okay, it's about 90, 100, and after meals it was 110, 120. But I observed my evening, that is the night, after dinner, the readings were 200, 220. So I myself understood that, this is what is happening. I think there is I'm doing things wrong. I'm probably not doing it right. Though traditionally I've been taught that this is the way to do it. I have to get up in the morning, do a lot of exercise, and eat well in the morning, reduce the food in the lunch a little bit, and don't eat that much in the night. So I followed that, and I assumed that that was the correct thing which I was doing. But this was an eye-opener. A lot of changes came about in my thinking on, how, things would change. So, based on the health coach advice, I started reducing some amount of the exercise which I did in the morning, introduced that to the night, and the results were, really very nice to see. Those levels of 200, 220, which I was talking about, is now come down to 120. That is in the night, whatever levels were there. So, that's in short, how I got interested in this, and I see a lot of benefits personally on how things are changing for me in terms of diet, in terms of physical exercises, etc.
Thank you so much. So, understanding from a scientific perspective, you mentioned that you split your morning exercise. You were doing 45 minutes of yoga and aerobics, and now you do 30 minutes in the morning and 20 minutes in the evening, and that's making an impact. So, Dr. Prem, my question, or what we can understand here, how basically splitting of that exercise helped, and how post-dinner walk or little bit of exercise helped him achieve a better postprandial sugar response post-dinner?
Well, I can add this way, since as Dr. Mano rightly put, he isn't obese. If you see his physical stature, he seems to be fit enough, and definitely it is never named that he is diabetic. So it is like it follows among everyone. A splitting of exercise, splitting up of a physical activity. Most of the usual diabetics, what they think is, I do so much of physical activity, isn't that an exercise? So when it comes that way, I run up, I go up and down the stairs. See, that is just a physical activity. But what is that you're doing as a part of exercise? And he, as a regular thing, as he addressed, he does yoga, he does aerobics, and it is session to 45 minutes, etc. Now, how much is he comfortable to do that? Like, is it kind of a stress what he has to do? Like, I have to get up in the morning to do this as an exercise. Now, when you see that way, the comfortability helps in giving you results. And I'm sure that he's comfortable in doing certain set of exercises. Now, can he extend more of it? Is it that only the part of exercises limit him to the yoga and aerobics, or can he add up anything? Or that is what is something what we need to know just about the lifestyle changes. See, as he is following a good diet control and diet practice, now about the exercise and its result basically adds too much to the lifestyle changes. Now, if I have to say about the splitting up into the pattern how he can do in the morning and postprandial, and he's one of the result what he said that it is come down a lot after he does a postprandial walk. That is one of the change what he has split himself, especially saving his time, not just fixing it up for once only in the morning, it is also in the evening. So that definitely gives a result. I think that is one of the reason.
Sure. So I remember you mentioning that now your blood sugars post-dinner have come down to 120. So I think that's a simple modification, Doc, of splitting the exercise without any drug intervention or medication intervention. He was able to get to the level of ideal blood sugar target. Any particular exercise or walk do you recommend?
Yeah, see, now, again, since he was introduced to lifestyle modification, most of the diabetologists, they suggest, okay, other than medications, what can I do? Now, just now Dr. Satur mentioned in his talk, in the end thing, he mentioned, what is an alternative exercise? And he rightly put it as hospitalization. So that is one thought everybody has to get. Exercise has no alternative. It is exercise. Likewise, diet. Now, when I say that, when it relates to the type of exercise he does, it is comfortable for him to do as walking, and most of the time that is what the diabetologist suggests. Do some exercise. What? Walk. Now that is not the end of it. The endurance exercise definitely it helps. It improves not just for the sugar levels, of course it helps for other cardiovascular issues and also about related to lipid issues, etc. Now one thing what we also note here along with diabetes is stress. Now what are the other ways he can enjoy the exercise? Endurance exercise, definitely strengthening is one. Now most of them think strengthening is not just within the gym what you do. There are so many variations of strengthening exercise programs which has come. There are home-based exercises what you don't have to always use a dumbbell. There are so many things which has come as therabands, there are tubes. So you can go about with that. Swimming is a good form of it. Of course, cycling and outdoor activity, you get relaxed doing that because you have got a different environment altogether. So there are different forms like this. Only thing what you need to know or keep in mind is how much is the extent. Now that is what is to be prescribed to him, like how the drugs are prescribed, likewise diet is prescribed. Now what should be the limit or extent of the exercise he is supposed to do? I think Dr. Samir would be able to add a bit more on that.
Absolutely. So we were reading that you mentioned that your stress levels were around 4, and especially there was a stress of diagnosis as well. So Dr. Samir, can you help understand what's the role of stress?
Hi everybody. First, I'd like to thank Mr. Shyam and his wife, as well as the audience for gracing us with your presence. I'd also like to make a special note with regards to Dr. Manohar and Dr. S.R. Arvind, without whom I wouldn't be here. Coming to the question, first I would like to define stress, and my definition of stress is any unaccustomed stimulus. Now what that means is that we have negative stress and we have positive stress. Now positive stress by the word itself is beneficial for us, and negative stress by the word itself is going to be not very beneficial for us. Now when we talk about diabetes and when we consider stress, and over here we're talking about negative stress, what we need to realize is its effect on the neuroendocrine system, its effect on the sympathetic nervous system, as well as maybe its effect from an immune system. So now when we think about it and we think about how it affects the sympathetic nervous system, we all know the sympathetic nervous system is divided into 2 branches, parasympathetic and the sympathetic part. So an increase in stress is then going to activate the sympathetic system. This activation is then going to cause a downflow and a cascade of cortisol rising, and we know what cortisol can do in the long run, especially when it is chronically raised, right? Now coming to the neuroendocrine system, we consider stress, negative stress, to affect us right from the brain with the release of corticotrophin releasing factors, which then go down and affect adrenocorticotrophin, which then in a sense again instigate cortisol to rise, and this sets this cascade rolling. So in a sense what we're trying to say is that stress, negative stress, can affect us at an organ level, and these organs all combine to create a negative end product. Now what we also need to consider is that somebody who's been told that they have diabetes, somebody who's been told that along with diabetes they probably are hypertensive, are also suffering with dyslipidemia, might be also prone to brain health conditions such as anxiety and depression. And research has told us time and again that in diabetes there is a propensity for one to be depressed. Now if we consider somebody who is first having diabetes, second suffering with a lot of stress, and is now not very comfortable from a brain health perspective, and therefore might be either depressed or very anxious, what will happen is that his compliance with regards to self-care activities, like taking care of himself, being compliant with medications, following lifestyle suggestions, might also plummet. And this will ultimately result in an outcome which is only going to be negative. So I think it's very important for us as doctors to consider that when a patient walks into our chamber, they are already very stressed, and utilize this space to understand what contribution to the disease is via stress, and how we can have a positive discussion to then try and mitigate it.
Thank you. Talking about stress, I'm sure with the word diabetes, first stress comes as what's going to happen to my food, isn't it? that now I'll have all the limitations. I can't eat this and I can't eat that. So this question is for your wife. So how did you manage that when people said that you'll have to change eating patterns or you'll have to cook separately for him? Are you cooking separately for him, or is it a healthy way of eating?
No, because his mom is also basically diabetic, so we three follow the same diet. And it's only for the kids, so that's a little bit different, that's it. So we more or less follow the same diet. So it was not so difficult, but maybe, yeah, of course, introducing salad before every meal, that's an effort because you can't keep repeating the same thing. So there needs to be some different menu. So otherwise, it's all okay. I mean, we are able to take it. So.
Okay. So I think you made quite a bit of changes. You started adding salad before your meal. You started adding some protein like a sambar or something like that. So the moment they moved to a healthy, balanced plate where they reduced carbohydrate by 10%, little bit of rice was reduced and one chapati was reduced, and then protein and fiber was added. One simple change. Whenever I'm asked a question whether there is a diabetic diet, I say no. It's a healthy way of eating, because the word diabetes itself is so negative in its connotation that we think we are not well. Though it is a lifestyle disorder, we can definitely change our lifestyle and modify. And I think it's a very good way that you're looking at it as a very healthy way of eating, rather than saying, I am a diabetic and I'm not going to eat in a certain way. And I think he has a sweet tooth, if I am correct. Yeah. So what all do you enjoy, and how are you managing with your CGM data when you enjoy your sweets?
I mean, previous to this, I have a sweet tooth. I want to eat a sweet every day. And, you know, when I met the doctor and when he told me that you're probably getting diabetic or are diabetic, you know, that was very depressing, like he was saying. I said, the first thought which came to me is, you know, am I going to start losing my sweets? And second, of course, stress levels increases in terms of other thoughts, etc. So now after seeing the CGM data, I realized that there are times at which my levels are low. Now I'm not sure whether, I mean, I'm allowed to do that or no. Maybe I have to check with the doctor. But at those times, I secretly get into the kitchen and have a bite of the sweet, whatever is there available over there. I have it. And I mean, after doing that, I again looked at the CGM readings, the next set of CGM readings to see whether it had any effect. And I found that everything was okay. You know, it was not bad. It was, you know, it was on level. And, you know, it kind of got me excited, saying that, okay, I mean, I don't have a big disorder now. I can manage this disorder and still get away with whatever I was doing.
Interesting, because that's, I think we all are. It's very difficult to change a habit or a behavior in a day one. And I think the technology today is supporting quite a bit. You could understand how your body is responding to a certain amount of sweet at what time. And what we observed is that why post-dinner his blood sugars probably are not able to go well with the same amount of food. Probably the insulin sensitivity is coming down by evening hours, and most of us have that. Insulin sensitivity is highest in the morning hour, slows down by lunch, and delayed by dinner. So mostly we say try and finish your carbohydrates early in the morning. Keep dinner high on fiber and protein, so you have a sustained release of sugar throughout the night. Wonderful. I also see you have tried to manage quite a bit of routine to your exercise now. You manage about 26 days of good routine exercise. So I'm going to take this question to Dr. Prem. How do you see with your clients and patients how challenging it is for them to get into this routine of everyday good exercise which is not stressful for them?
As I previously said, once when the doctors suggest the patient do some exercise and the form of exercise. Now, when it comes to form of exercise, there are 3 stages in exercise. That is one thing I should always say, the importance of giving the contemplation, planning an action. What is the type of exercise I'm supposed to do it? Now, once you think, okay, the exercise behavior, now this is what I'm supposed to do. I can't do excess of exercises which can even harm my other systems. It might be the joints, it might be the muscle. The type of exercises could be very less or very more compared to the state I can do. So there is something called exercise behavior, planning how to do it and sticking on to that, the action stage. Now whenever we say sticking on, New Year is coming very soon, and most of us make a New Year resolution. I will hit to the gym. Now whether the gym hits you or you hit the gym, definitely you're going to buy a new pair of shoes, new dress, everything, and day one you're there. And maybe the trainer there also so very enthusiastic because he can see a customer walking in. So definitely he will teach you certain stretching and he'll put you on a machine where you have to pump your muscles, so you lift some dumbbells. The third day or the second day itself you develop soreness. So once the soreness develops, you start thinking, okay, now I can't do that much of it. So you limit your participation in the gym. Then other things add up, which we call it as stress. No, it is not stress, it is your planning. Your behavior, what has changed, is not the stress. So once you do not have a proper plan, you're not putting it into action. So once your action is planned or you have a behavior which is set, then maintenance of it. How many times I'm supposed to do? How many days I can do? See, as it is in diet, there are some cheat days. No, in a week, definitely one day is a cheat day where you're allowed to eat anything of your likes. Likewise, exercise also need to rest at least one day so that your muscles can recoup. If there's an injury or if there's something what can reform, there is one cheat day should be allowed to the muscles to do. So likewise, when 26 days is an excellent duration what is kept, or a practice of exercise. Now, form of exercises, it can be the way how the yoga or aerobics or cycling which can be done. Change a form into it. Bring about something new, add stretching to that, add some flexibility exercises to it. Try something which is new, like Tai Chi. You get so many online tutorials, try something new. And also, see, it's not always limited only the endurance exercise. Strengthening also definitely helps. Focus on which group of muscles you need to build. So that, I think, helps more of us to plan and then succeed in attempting to it. That's it.
Thank you, thank you. And good part is that you don't experience any pains or aches. Touch wood, you're healthy that ways. Again, coming back to you, Dr. Prem, that if somebody, like most of the clients that we see, somebody has knee pain, back pain, what would be the best way to get started? Somebody who's just trying to control blood sugar, never exercised before. Yeah. What would be the step-up plan, first plan for them to just get started?
See here, just not for the injuries. Even if you have any kind of a problems like a common cold or a cough, immediately next day you're not willing to do an exercise. So that will put you one step back. It's like sticking on to the behavior. That's the very first thing, and how you kind of execute it. Now, whenever there are certain injuries, attend to the injuries. See what has caused injury to you. For example, I just mentioned the gym and the soreness related to the gym. There are two things which can always relate to the pain which can cause. Either the form of exercise what you're doing is wrong, or your muscles or joints are not up to it to take the amount of exercise you're doing. So always plan it in such a way that injury has to be first given a first concern, so that you always can continue doing the regular, easy, comfortable pattern of exercise. So it is like guidance is very important. A trainer or if you are self-learned exercise, then you should know how to do it. Then accordingly you should also have a self-check. We always keep certain goals. Okay, I have to be slim after this many number of days, or I have to reduce weight. So all these things are goals what we keep, and especially when it comes to diabetes, I should say, maintaining the blood glucose levels. Now, as he suggested that he goes with the CGM, and it guides him to have a extra sweet in the night. So likewise, I think it can also help and guide you to do a different form of exercise which can still maintain or balance your blood glucose level. So that's how it can be. And injury wise, address it in a way, in a form where it should not exceed. If you are feeling it as a discomfort, it need not be the exercise induced injuries alone. You might have something related to the pattern of your ergonomic changes, which how you sit in an office, or maybe you attempted to lift something which was heavy. So these all can cause some or the other type of musculoskeletal injuries. Now, attentive to it is always with a consultation. Do not self-medicate or do not try something new online. So because there are so many exercises which can relax, which can build up your strength, at the same time maintain your muscle power and muscle strength. So that has to be definitely focused upon.
Thank you so much, Doc. I remember Dr. Manohar when we were talking about how he became an ideal candidate for starting with lifestyle medicine or a lifestyle choice. I understand your role is equally important because it's your body. You have to take care of your health. So what was the initial discussion when Dr. Manohar asked you and you showed your inclination towards it, and how you got started? So he was asking you for 4 years. What was the tipping point that you said, okay, let me do it now?
I think it's clearly, he has been telling this before, and to be frank, whenever he's told that, and he was mentioning it now, like a New Year resolution, after you meet the doctor also, you make a resolution. And for about 10, 15 days, you do everything that is possible and, try and, make sure that, you're following it. After that, you lose the spirit of it because you start tending to feel, is there any benefit out of this? Is this happening? Am I okay with just taking a pill? I mean, why am I having to do this? So that thought process is coming. But this time it was different because this time Dr. Manohar told the same thing. But then when the CGM patch was put, it was an eye-opener for me to see what is happening within my body. And the moment that came about, I think, everything else fell in place. The motivation came in automatically to me, saying that, I have to change my food habits, I have to change my timings, and I have to probably distribute my exercise from what I was doing before. That motivation came automatically. And if I may, I have to add in over here, I'm at least only at that border level, but my mother her HbA1c levels are at 13.9, which is pretty high. She's still not on insulin because she refuses to take that. But along with me, she's also followed this. She's about 70 years old, but she's also followed this entire thing. And her average blood sugar levels have been dropping drastically. With the same medication which was there, it has been dropping drastically, and I think that's a bigger eye-opener rather than me. And she's following the same thing that I've been doing. She obviously cannot do all the exercises that I'm able to do, but like how he suggested that, whatever they can, she's been doing whatever she can. And, her sugar levels, in the morning, you can imagine, about a month and a half back, her HbA1c levels were 13.9. And now, in the last 1-2 weeks that, we've been measuring her sugar. Now the CGM patch is not there, but the, her fasting sugar is at about 97, 100, post is about 140, 150. So we can ourselves see the change, what is happening. She's not done anything except shift her timings of food. We made it earlier. Otherwise, we used to have our dinner at 9:15 in the night. Now we are having it at 7:30. It's making such a huge difference, and we can feel it as well. Right?
Wonderful. Thank you. Talking about the role that you have to play in making the decisions or taking the right choices at home, my question to Dr. Sameer is, how do you think the mutual goal setting plays such an important role to see more compliance in day-to-day setting?
Yeah, where we think that the customer should be king. Now, in our hospitals, when we have patients coming in, I think this is a philosophy that we should keep in the back of our mind, where our patient is the king. And they bring to us, yes, health-related issues. They bring to us professional issues which come in the way of their health goals and so many other things. If we were to just look at it from a purely health perspective, and if we were to tell Mr. Shyam that, you know what, you cannot do X, Y, Z, or you need to do X, Y, Z, and that is the way we need to move ahead, then what's probably going to happen is that he is not going to be able to comply with it, and he's going to seek help in other areas, and he then might get it or he may not get it. But if we can sit down with him and if we can consider what can be done, let's talk about it from an exercise perspective. So he has said that he happens to have time in the morning, he happens to have some time in the evening to do a couple of exercises, be it yoga, be it running, be it some other form of body weight related exercises. Then we need to consider how much can he do this and at what intensity can he do this. And then this is a dance where we have to suggest something, he has to agree, and then we have to keep moving ahead. And in a sense, create this feedback loop where we're constantly in touch with each other, so that tomorrow, if I have suggested that he needs to engage in, let's say, 15 push-ups, and he can't because physically he's not able to, or because professionally he doesn't have the time, then is there an alternative? That has to be put out onto the table so that the patient, as well as us, can come to a consensus with what is possible and what isn't. And then maybe we can think about bringing positive health changes into their lives.
Makes sense. So I think we all human beings, we have to be first convinced. And that's the point that I like, that as soon as we understand that a patient is convinced, we should be able to put lifestyle medicine more often. We see it every day on our setup, patients walking, and today I think you all or patients have started demanding. I think lifestyle modification has been the first line therapy for ages, since at least I started studying. I've studied that, all non-communicable diseases, 6 months is a lifestyle modification. I think now the awareness is so beautiful that even our patients are coming back and asking us that, why can't I control with lifestyle? And that's where I think the motivation for all of us has set in, that yes, let's first try with lifestyle modification and make sure that the person is motivated enough to take control of their own health. And maybe that's why we are seeing amazing technology coming and supporting us. I also observed that you mentioned that you stopped taking milk, right? Were you correlating milk and the food sugar elevating your blood sugar post-dinner? Or what was your observation?
Yes, I mean, for the first week of having that CGM patch, I observed that, taking the milk was raising the sugar levels up. So when the health coach told me that maybe you can make a change, and she told me to get rid of milk completely in my coffee. Now that's difficult to do, so I bargained with her and made it a 40-60 kind of ratio. But that was for morning coffee. And then night, before going to bed, I used to always have a glass of milk. Today I've had it since probably when I've started having milk. I've always had that. I stopped that. And I always thought that milk is what is keeping me healthy and doing everything for me, etc. But now it's a realization that probably that was the possible culprit. I don't know. They will know better, but possibly that was the culprit, and it's got about changes. I can see from data that it's got about changes. So hopefully that's the answer.
Okay. How many of us think here milk leads to diabetes, milk consumption? Please raise your hands. Anything is fine. Okay, so how many of us would want to go dairy-free to reverse diabetes or control diabetes? Thank you so much. I'm so happy that we don't believe that is true. So when we looked into the data, we did more of food recall. We understood that he's finishing dinner by 9:30 earlier, and bedtime milk is at 10 o'clock. So the glucose load of the dinner was complemented or increased with the lactose load that came with the milk, and that's where the blood sugars rose, right? So sometimes what happens, we just tend to understand that probably there is a culprit, whereas the timing is problem for me. I agree that there is a lot of research today that says that dairy could be one of the possible reasons which is leading to leaky gut and things like that. I am not going to deny that. But when I sit with our patients and I understand whose gut is responsible for triggering diabetes, that lies in gut microbiome. Or when we start understanding a person's response to blood sugar. So when he's wearing a CGMS, I would definitely want to see only milk consumption along with, only protein sources, no carb coming in, and what is his blood sugar response to milk. If I see a dramatic increase in your postprandial sugar, then I'll say, yes, your body is not metabolizing milk. Or on the other side, as a clinical nutrition, when I understand somebody already has an autoimmune disease, maybe gluten sensitivity also, lactose sensitivity, definitely it can trigger. But if these conditions are not there, I do not tell my patients to stop milk. They need to make sure it's antibiotic free, it's coming from an organic farm as much as possible, and it can be only in the form of curd and paneer. You don't like milk, that's absolutely fine, even I hate it. But probiotic form, like a buttermilk or something which is doing good to you, because we Indians, any which way, don't have any probiotic going. And gut health is very, very important for blood sugar regulation. So my observation there will be to split milk and your food, which you already did, and buttermilk at bedtime is a wonderful thing. So now you are having dinner 7:30, and your buttermilk at bedtime, right?
Exactly.
So you're seeing good results with
absolutely, that. Absolutely. The data shows that it's, it's working. So.
Right, right. So I think we all agree here that the way precision nutrition or precision medicine is going, it's going towards personalization, and there is no one rule that's going to fit everybody. Just coming back quickly to Dr. Prem, that if you have to just give 5 tips, Dr. Prem, that what would be a good exercise regimen for anybody who's trying to control their blood sugar and staying healthy.
Now, when we kind of matter is about the control of blood sugar and the type of exercises, always better is with an endurance type. It's like simple yoga and be cycling. It can also be aerobics, and more importantly, again, sticking out is very important. Now, there are results which has lot of research which say that the high intensity training in a particular form or with a moderate intensity definitely will help. Now, always we consider as low impact exercises are good to maintain the blood sugar levels. Also, now there is a study which says high intensity training and also strengthening exercise can be added, where the patient has to get conditioned to that form of exercise. Now, age matters, the physical stature matters definitely, because these two things. Old patients, yes, we have a different set of exercises with the repetitions or with the practice. At the same time, young patients with their physical stature, if they can do or attain more, why not participate in some more impact type of exercises where they can go for competitions? Definitely there is a chance. Only thing, the form of exercise has to be decided, like how medications are prescribed, likewise exercise also are prescribed. So follow with a better physicians and also with a good consultation with the physiotherapist or a physiatrist who can help with this.
Many thanks. So I think we are closing to the time, and understanding that a holistic approach to managing a person's health is very, very important. Thank you so much. If there are any questions, yes.
Very nice program. Very, very helpful. Just wanted to comment. If we understand that diabetes, hypertension, ischemic heart disease, these are lifestyle diseases, we should understand that we need to address lifestyle, period. That is the most important thing. And the present strategy for management of lifestyle disease is like mopping the floor without addressing the leaking tap. We are developing better and better technologies to mop the floor without addressing the leaking tap. That leaking tap is your lifestyle.
Yes.
And I fully agree with you. There are no separate diets. Sugar is bad for a diabetic, sugar is bad for a non-diabetic. Salt is bad for a hypertensive, salt is bad for a non-hypertensive. It might be worse for them. What is good for me cannot be bad for you, and what is bad for you cannot be good for me. That is not how nature works.
True.
And exercise, he mentioned about stress. Stress, I define it a little differently. Stress is something which you are not able to deal with. If you are able to deal with, there is no stress at all. If you are not able to deal with a situation, with a person, or with your own emotions, that leads to stress. And exercise, yeah, we have created a narrative in our life where it has, we need activities. Actually, exercise should be a natural part of our daily routine. We do not walk, we do not climb steps. Wherever we go, we use motorized vehicles. But if that becomes a part of our daily routine, but we have made it into an activity. And this activity, if we keep using walking, climbing stairs, wherever we are working, the work gets distributed during the day. Many people do 1 hour, 1.5 hours exercise in the morning, and then they sit for 11 hours in front of the computer, which doesn't help. It has to, so people who are working in offices should be told to walk, climb stairs, not to use the lift, and it should be a part of our daily routine.
True,
Thank
sir.
you.
According to your continuous glucose monitoring, when did you measure the sugars? After having your milk or your breakfast? What time after your breakfast?
No, I had the CGM patch on.
Yes, CGM, yes.
Yes. So, I looked at the readings, 2.5 hours. I looked at the readings
readings about 2.5 hours after I finished the meal. So I finished the meal at 7:30. I think I was looking at my readings at about 9:30, 10 o'clock. And that was when what was about 200 had dropped to about 120. This is, the changes was I was having my meal at, about 9 o'clock, and I was checking at 11 o'clock. And at that time it was 200. Now when I shifted to 7:30, plus, after 7:30 to 8 o'clock, I was taking a 20 to 5 minutes walk. And after that, when I checked at 9:30, 9:45, the reading was 120. This is like consistently over 3-4 days that I saw the change.
Why I'm saying this, I had a similar patient with a similar profile. He too was an engineer by the name Mr. Shrikant. His mother was a diabetic, and he used to have this glucometer and was checking his blood sugars. Suddenly one day he decided to have this patch and measure his continuous glucose levels. And one fine day he called me and said, I ate jamun and I had tea, my sugar is 180. He has measured after half an hour after having his jamun and tea. I said, no, that's not the correct way. You should wait for 2 hours to complete the process of insulin secretion and the levels coming to normal, and then you must decide whether to take or not to take. I have a question for you. Does plain milk raise sugar levels?
Sorry?
Plain milk without any additives or nutrients, does it raise sugar levels?
Like any other food, because lactose, galactose both are there as milk sugars. So definitely it has a decent amount of response, in fact. So that's
Does it
why
have a high glycemic index?
No, it has a moderate one, but that's why we just recommend that it is not combined with main meals as well as with fruits. Because the fruit sugar fructose, when combined with lactose, again, we have a very peak response in blood sugar. So we say milk should be as a snack or at bedtime. So we generally try and avoid it. Otherwise, breakfast milk and a complex carbohydrate is a good combination. So quantity of both will matter. But otherwise, it is a moderate one. Milk sugar also increase blood sugar quite a bit.
I have a question. I think probably Samir or Prem can answer this. One of the challenge what we face in the treating the elderly diabetic patients is like most of them complain that they have this osteoarthritis or they are obese, they'll not be able to walk. So, though we have heard and have been telling them to do some non-ambulatory exercise, right? So, any take on that, like, what you would like to tell for the elderly patients?
So to address your question, what I'd like to do is actually cement what Sir had mentioned with regards to us taking care of the tap at first. And if we consider lifestyle as a means to take care of most non-communicable diseases, then we should also consider this, which is my parting thought and a message that I would like you to consider as you leave this place, which is, as children we were told that we should always ask the following questions: why, where, what, when, who. And I think when we come to lifestyle, and if you consider, let's say, exercise, nutrition, stress management, or sleep, similarly, what exercise, where, when, how needs to be considered, because these are prescription strength equivalent. Because today a medicine is known to reduce, let's say, blood sugar by 20%, and so is exercise, so is eating well. So these are prescription strength modifications which we are suggesting. But unfortunately, the broader audience doesn't have that scientific nuance to then state exactly what needs to be done, where it needs to be done. So coming to your question in particular, where you might come across an elderly patient who has, let's say, physical difficulties in engaging in an exercise, primarily bilateral knee osteoarthritis, which is very common. What can be done? The suggestion could be a cycle ergometer, where they utilize their hands. Now, yes, we know that it isn't as good as them walking, because we have larger muscles in the lower body in comparison to the upper body. But we also know that something is always better than nothing.
Yes.
So this is the train of thought that we need to start inculcating in this patient population. And probably if they were to start with, let's say, a cycle ergometer, and then maybe standing for 15 minutes post their meals, or maybe a very relaxed walk while having a conversation with whoever's next to them, we might see their weight then reducing. We might see their pain then reducing. And in essence, we might then modify their so-called osteoarthritis, and then we might be able to enhance the intensity of the exercise.
I would like to add a few more about it. Since your question was related to the age-related problems as well as chiefly the osteoarthritis and non-ambulatory exercises, definitely see, when we were in school, definitely we all have attended a compulsory class on physical training, the PT exercises. Why don't we do that? It was not, we were not made to run all around. We had to stand according to the beats of the drum or the whistle. We were doing it. That's a good form of exercises too. And that anybody can do even in sitting or in standing. And more importantly, as we had a beautiful session on yoga in the morning, and yesterday Dr. Hemant also was defining how yoga can manage or help controlling diabetes. So there are so many types of pranayamas, which again has a major role in reducing the visceral fat. So there are the different forms of practice where even a non-ambulatory person or a obese person or something related to musculoskeletal and age-related problems can do practice. I suggest that.
This for dietitian. So whenever diabetic come to our clinic, we say them avoid glucose-rich food and eat chapatis and eat biscuits. Okay, how healthy are they? And eat rava foods. So I want to know how healthy are they, whether they lead to leaky gut.
Okay, so if I understand the question, we are saying whether wheat is healthier than rice or biscuits, the healthy claimed biscuits. So I'll take one by one. If somebody is a rice eater, their gut manages rice better. If somebody has been born and brought up eating wheat, they will handle chapatis better. And their body is prepared to handle that glucose response much better. So I have displayed couple of food models when you go and have your lunch. Take a look at the portion sizes there, right? So the chapati size and the rice bowl size, that's where we need to put our attention to rather than just the ingredient. If I have to break down the glycemic index of rice and wheat, definitely wheat is a little lower. But if you're eating 2 big chapati and 1 small bowl of rice, the glycemic index is now same. The amount of carbohydrate that is going in the body is the same, right? Only the gut microbiome or how the blood glucose response will be higher will be different in 2 different individuals, right? So it completely depends on the person's eating pattern. I generally go with what they've been born and brought up eating, their grandma's way of eating, locally procured millets, pulses and everything. That will be the best way. Coming to the healthy labeled biscuits, I don't believe anything is healthy on a processed food. We did want to discuss about that as well, but when you look at the food label, right, I know it has ragi for that matter, but ragi is also processed fine like maida, right? Then how is it ragi? That itself has highest GI, and then we tell our patients that ragi biscuit is healthy. So it's a completely misleading information. We should not fall for these marketing gimmicks, and we should definitely sit down and read the food label. For me, a khakra or a methi, ragi chapati is much better as a snack rather than a biscuit. So just read the food labels. It has high fructose corn syrup, invert sugar. They will hide word sugar, but they will have everything there. So it's our job to inform our patients to make the right choices.
What about rava?
Rava, same thing goes. So it increases your blood sugar the way it will increase, the way poha will increase your sugar. Poha and rava, again, the intestinal transient time is a little different, right? That's where you'll see some difference. Add equal amount of vegetables to either poha or upma, and that is good to go with some protein.
So I just read an article in nutrition. So they've labeled all this gluten-rich foods as inflammatory diet.
Okay.
And when they have avoided these foods in diabetics, so the weight loss was more.
Okay.
So when they avoided 2 to 3 kg weight loss that happened.
Okay.
Instead of, they have not modified anything else.
Okay.
So
like I said,
had a doubt.
No, so it's a completely personalized response, right? Today, definitely I am seeing modified gluten that is there on the market. The way we ate wheat and the wheat that we are eating today is completely different. So that modified gluten or gliadin, whatever, is the problem. So we need to understand where our atta or wheat is coming from. If you know the source, it's gone to a fresh chucky and from there you procured it, I don't see an issue. And there are individuals who are sensitive to thyroid hormone response when they eat gluten. So that could be a response that you are seeing for an individual responding better on weight loss when you cut down on gluten. But it's not a blanket statement. Work closely, understand how an individual is responding. Thank you. My pleasure. Sorry, sir? You had something to add on?
Just to add to ma'am what you said is that Mr. Shyam here told us that if the accuracy of the CGM is right, that when he ate sweet, it so seems that his response is not as bad as we'd expect it to be. But maybe that he's not able to metabolize milk as well. So there you have this peak in blood sugar. So as Dr. Sudarshan yesterday mentioned, that today we are reaching a form of medicine which will be personalized. And over here, maybe we need to consider each individual as being different and see what works for them.
So you had a question. Fruits. Okay, so for somebody who's trying to control their blood sugar, we recommend 1 to 2 fruits per day. Healthy individuals must have at least 2 to 3 fruits per day. And this recommendation comes from their phytonutrient intake, sir. We see a lot of antioxidant properties that we consume with the fruits, which is very important for their blood sugar regulation. But fruit has to be consumed as a snack, should not be as a part of breakfast, lunch and dinner. Like here we have a habit that meal will finish, we'll end up with finishing with a small banana, which is good, which actually calms down stomach acid wonderfully, but not for a person who's trying to regulate blood sugar. So for them, fruit has to be a snack, 2 hours after food. That's what I see successful. Anything is fine. 2 hours gap has to be there between fructose and your glucose coming from your meals. For a diabetic, I don't recommend that. I do not recommend that, but if the goal is for weight loss and a way to control or give some rest to their gut, maybe yes. Again, very, very individualized. Somebody who's dealing with thyroid issues or some kind of inflammatory process that's going in the body, I don't recommend. And it is never one fruit. So we never feel satisfied with one apple, right? It'll be a bowl of fruit where 5 fruits have gone in. That fructose load is so bad for our liver that the whole purpose is denied.
It was very contrasting that we prescribe exercises for all our patients, but also look at these things. Every day when he goes to the gym and come back, his blood sugar used to shoot up. And Sunday, when he doesn't go to the gym, blood sugars are normal. The point I would like to make here is, some of the exercises are not suitable for everyone. When we are prescribing exercises, we need to be very, very careful, because any exercise which is not suitable will add to stress, and stress will increase the blood sugars. I hope
that's a nice point what you mentioned. I just mentioned that planning of an exercise itself is a stress.
Yeah.
So pushing yourself to do something more, definitely the double stress. So I think that would be the thing what you notice in the patient.
Always please consult the sports medicine specialist when you are putting a patient on special activities. Yeah, thank you.
Thank you.
Here I'll just like to add to what you've said, and over here what we need to realize is that when we exercise, we are actually creating stress which is negative to the body, because that is not our body isn't very happy when we exercise. Muscle grows courtesy the micro tears that we see, and similar. But what we are looking for is the following adaptation that exercise will bring in. And over the course of time, if one were to stick to exercise, agreed, a routine which is within their limits, the adaptations far outweigh the negatives that come with that momentary rise in blood sugar or the momentary rise in, let's say, a pain that one might have to tolerate after doing exercise. But as you mentioned, I think it's very important that when a diabetic comes into our clinic, we need to consider that they may have other comorbidities, and a one-size-fits-all prescription may not work for them. So you have to be careful with what you suggest, why you suggest it, and maybe request them to undergo certain investigations so that they are safe to engage in these exercises.
I see many clients like that, many patients, and when we sit down and do a food recall with them, they are going on an empty stomach to the gym, right? Their glucose levels are completely empty, their tank is empty, and that's where the muscle glycogen or gluconeogenesis sets in place. Only thing that we observe does wonder is that giving them a protein breakfast or protein snack before they hit the gym. And that's where the glyconeogenesis part comes down. Your alpha cell dysfunction, which is producing so much sugar as a response to exercise, reduces, and they enjoy a wonderful exercise session. So pre-workout snacking and post-workout snacking shows me some wonderful results, especially with people who are not able to handle the stress of exercise in the gym for their blood sugar control. That's nice. Absolutely.
Yes.
Yeah, I think it was a wonderful session. Yeah.
So definitely I agree with it, but how much, right? So handful is what we need because they are high in saturated fat as well. MUFA as well, PUFA as well, they're good, but the quantity has to be controlled. And somebody who's dealing with IBS, IBD or gut issues should go very easy on dry fruits and seeds and oil seeds as well. So one handful generally are good. Somebody should keep an eye on their bowel movement. If that is getting disrupted, that means body is not handling it well. My pleasure.
One last question. Yeah.
So, sorry, sir? Soya bean. Yes, definitely it's good, but the real soya bean, the extruded products that we get in the market, it is processed so many times, the ultra processing leaves protein quality to be zero. So the bioavailability of that protein in our body is 50% only. Where I say soya has a PDCAS of 1, that means it's as good as egg. Processed soya, the chunks or the extruded products that you see today in the market, that will hardly have 50% of the protein left in it. So absolutely, it's a good choice. Pleasure.
I just wanted to ask you, what's your take on intermittent fasting as far as diabetes is concerned? Or
No, I think we'll take this question and we can end the session of this.
If the person has controlled blood sugar or it's not a brittle diabetes, I definitely go for it. But I start very slow. So I start with 12-10, 14-10, and then move it to 16-8. So once your client's body has adapted to understanding when the food is coming in the body and when not, and when your liver is working and when your pancreas are working, once that balance is settled, I see wonders, frankly, but not with a brittle diabetes. Because we are born and brought up in such a way that our ancestors or grandparents started eating at 5 in the morning, stopped eating at 5. So we have a cycle to get into intermittent fasting, but again, very, very individualized. Some people have a hangry response. They don't handle the fasting period very well. If cortisol is coming into picture and increasing blood sugar, I do not recommend it. So personalize it, but I see good results on intermittent fasting.
Okay, I think so I'd like to thank, first of all, both of you for volunteering. So as I see, the success of any talk depends on how many questions that comes out. So I think if I allow, I think it can go for another few more minutes or even an hour probably. So it was a well covered topics basically on the diet, exercise, stress, every aspect of the diabetes lifestyle modifications, everything was covered. So as we all as a practitioners of diabetes, like we always say to the patients that you have to follow diet and you have to exercise. And as Dr. Pariksha, Dr. Samir, Dr. Prem has told that this particular topics which we are able to tell to our patients in a structured way, I think definitely it's going to have a long-term effect in terms of keeping their blood glucose levels. If a person is in a pre-diabetic stage, there is definitely a possibility of reversing it to the euglycemic stage as well. So I think it was really a wonderful session. I would like to thank Dr. Pariksha, Dr. Samir and Dr. Prem for their talk. So I'd like to have a group photo.
I still feel diet takes over exercise.
I request everyone to stay back. There is after this there will be a Nadagoda lecture. It's going to last for just 2 minutes. My request to please have your seats. We are coming to the end of the session, so I'd like to have a symposium slide of Vinaya Nadagowda honor lecture. Dr. Nadagowda is a famous leading physician, diabetologist and an entrepreneur and a philanthropist from Hubli and North Karnataka. To encourage young diabetologists and researchers, Dr. Nadagowda has contributed generously to KRSSDI and many other organizations to institute orations. To salute and evaluate the virtues of this family, Mrs. Vinaya and Dr. Nadagowda honor lecture has been instituted. Thank you. I think we have come to the end of this session. So thanks everyone.
And there comes the research. Given that the trials are very mandatory, but 80% of the trials are being conducted in only 20% of the research institutes. Nevertheless, many investigators who have that enthusiasm or time are left behind. So we have developed a platform called as Ignition, which is going to help you there to ease your time, and whatever time that you have, the smallest time that you can spend for research can be used judiciously. So in a conventional method of doing a trial, a lot of activities, it's a huge sequence of activities where it starts from the protocol designing, site selection, the laboratory selections, finalizations, regulatory approvals, including the DCGIs, as well as the institutional ethics committees. Then the actual patient enrollments also happens. So that's where your important piece of contribution comes into picture. So based on the protocol, the inclusion and exclusion criteria of the trial, you are going to select the patients who are eligible for the trial, and then the actual problem of the documentation happens, which is a huge, which most of you are aware that a clinical research has a lot of documentation. That's where you cannot spend much time. The TriMix platform is going to help you a lot by easing those documentation procedures, digitalizing the entire process. The next steps of that is data cleaning and data validation of the entire patient enrollments or whatever happened till then, the data log, and then the analysis, the statistical analysis. Important part of this is the research publications. So once there are many pros to do these clinical research, just not for, because I know most of you are not looking at the financial aspects, but the paper publications post the completion of the research or the trial. So there comes again the TriMix part, where we are going to publish the papers of the trials conducted and also help you to have a better visibility in most of the journals that are of high repute. That also helps you for the global networking and also associations like American Diabetes Association and others, because you're already visible across through the trials that you have conducted and also through the research publications. Now, the problems with the clinical research and the essential steps that are involved there have a lot of duplication of the work, where the research coordinators, who are your team members or yourself, is doing that activity. You may feel that why am I entering this data again and again? So at the same, because as you know, the research has a lot of documentation and endless paperwork. Important thing is about your participation or your contribution in the patient enrollment. The gaps there are so critical that it will hamper, and that's where the TriMix platform is going to help you to identify the patients through the electronic health records that a platform that we are going to provide you, so that there is an easy flow of all the patient database, and you can filter those patients who are actually eligible into the trial. So that is going to help you, which is not happening in the conventional clinical trials. That is one of the plugs or one of the bottlenecks that we have identified, and we are trying to fix that. And we have successfully done that through 3 clinical trials so far. And also, there are a few other items. For example, the investigators being burdened with like 80% of the trials in India are being conducted only in around 20% of the institutes. So that is like same investigators are doing the trials again and again, but there are a lot of enthusiasts like you who are interested but not sure what are the next steps to do that. So we are here to help you hand in hand, help you with the next steps of the first steps of doing a trial, because we have a few sponsors who are ready to do the trials in India. Our sponsors are US based, globally from Australia as well. And so far we have recently concluded a trial, which I'm going to explain what about this trial in the next slide. So that's where TriMix has identified those problems, and we are a startup company started off in 2020 by a couple of IIT Roorkee graduates and also a medical oncologist, backed by US-based investors. We have around 20 to 25 of software engineers coming from IITs who have developed a software platform that would definitely help you to shorten the time, or whatever time that you could spend can be judiciously used for the clinical research purpose. And also we have the platform which is also interfacing with the ethics committees, the patient pools, the central labs, wherein you need not as such, or your team need not transcribe each and every value of the lab parameters manually. The software is so integrated that the lab values will automatically flow into the database, so that there are no transcriptional errors, no manual entry errors. The quality of the data is very high, and the sponsor is very happy to see such kind of a good clinical research being conducted that will help their product to be marketed or launched without any hurdles from the regulatory inspectors, who are going to ultimately the decision makers to allow that particular drug into the market. And I'm going to give the next slide to my colleague, Mr. Vikram Bhatt, who is going to explain how we are going to bring that value addition or make that change and fix those bottlenecks that we have identified earlier. Over to you, Mr. Vikram.
Thank you, Dr. Suresh. I'm Vikram. Thank you for elucidating all the facts about what are the issues that are faced in clinical trials. So right now, I'm going to tell you how Triomix technology is going to help in making sure that these issues are not there. So initially, I would like to start with what a super site is. A super site is a clinical research ready site. A super site can be a clinic, a multi-speciality hospital, it can be a medical college hospital as well. So at these super sites, we've made a bunch of tech interventions and eased the flow for quick conduct of trials. Super sites also network with one another to deliver synergies. Like-minded investigators can collaborate with their peers, both nationally and internationally. Investigators conduct similar type of research in the same therapeutic area and share their know-how and brainstorm effectively. Due to this, the investigators receive new info related to the field of their expertise, newest developments in the upcoming therapies, gain access to new drugs and therapies, and become part of associations like the American Diabetes Association, the Indian Diabetes Association, etc. By becoming a super site, PIs are able to leverage the power of these associations. Overall access to these networks helps the investigator build a very robust clinical research profile and gain visibility amongst industry sponsors. PIs can gain access to company-sponsored studies and also be published in national and international journals like Nature, Science Direct, etc. One such advancement is the extensive use of CGM and wearables to effectively monitor glucose levels and metabolic health in treatment of diabetes. Dr. Suresh will explain further with regards to that. Now, I'm going to explain how super sites, or rather how Triomix helps its own super sites. We have a three-pronged approach. One is the network, the other is the infrastructure that we create, and third is the support system that we provide. I'm going to talk about the network. So initially, we spoke about a different type of network. Now we're going to talk about the peer-to-peer network. We have pre-built a network of independent consultants, SMEs, key opinion leaders, peer network, and regulatory experts. These networks help investigators to get the necessary approvals in an instance. Our platform has made research proposal possible in one click. Hence, there is no harsh task of printing, signing, sending the dossier here and there. It can all happen in one click. We've tied up with multiple independent ethics committees as well. Now, a lot of investigators here would not have clinics, and the question is, if I do not have an ethics committee in my clinic or my hospital, what do I do? We help you tie up with independent ethics committees, and we can conduct clinical research there as well. A bunch of hospitals which already have an institutional ethics committee. Our platform can coordinate with those guys as well. Query resolution can also be done on one single click. Now, one more issue that happens is with respect to patient identification. Now, considering the inclusion and exclusion criteria is very robust, it is very difficult for investigators to find the right kind of patients who fit into the inclusion-exclusion criteria. So Triomix has a one-click query search. So you just need to search there, and you would be able to get a list of your patients through your EMR. And these patients are pre-qualified to be able to be recruited into the trial. Triomix, we've digitized the inclusion-exclusion criteria, making it easy for you to recruit patients as well. Then comes the patient management. Once these patients are recruited and they sign their ICF and they're a part of the trial, managing these patients is also a tedious task, considering you're also doing your clinical practice. Patient journey during the trial can be easily managed. Complete overview is available to the investigator, including visits, scheduled visits, tests, and investigations too. The third thing, what we've done, is we've digitized the CRF. Most of you would have, whoever has done trials, has used a paper form of CRF where the investigator writes something into the paper CRF, after which it is a third-party person, will have to key in whatever these details are into the computer, followed by which a monitor comes and says whether whatever has been keyed in is correct or not. This we call as monitoring. This is time-taking, very tedious, and if there is any issue with the monitor, the investigator has to be there to understand what it is and what it is not. So what happens with Triomics is we have done source data verification. Since we've digitized the CRF, source data verification has already happened, because in the CRF, the investigator itself enters whatever details are there. We also have tied up with regional and local labs. So if in case there is some lab tests or some diagnostic tests that need to be ordered, this can be done on one click through the tab. So there is information which is sent to the local lab saying that this test needs to be done, and the person from the local lab comes and performs the diagnostic test wherever it is, and the details are auto-populated into the CRF. We also have a very good support system as well to conduct the trial. We have experienced project management team which will handhold you through the whole duration of the trial. We have a quality assurance team which does the monitoring and the audits after the trial is done. If in case you are interested in investigator-initiated trials or IITs or academic trials, we can customize the CRF for you. That also is done. We can provide you 24/7 support in terms of any questions that are there. We'd be more than happy to answer. And we also have one coordinator who is trained with Triomics technology at your site. We also have a statistician which will be provided. So these are a bunch of benefits to becoming a super site. You gain access to global clinical studies. You would become a prime choice for industry-sponsored trials. You would earn honorarium in conducting these trials. We help you with our EDC, which is our software for conducting these trials. And we also help you with patient identification and patient management. Over to you, Suresh.
Thanks, Pat. Thanks so much for giving a big insights about the super site. We have next few testimonials, a few investigators who have actually done trials for us across India, and a couple of their experiences doing trials or research with the Triomics is for you here. Meanwhile, we have some technical, but meanwhile, I'll call upon one of the investigators we have here, Dr. Srihari Kulkarni. He has participated in a couple of trials for us. Both of them, one is sponsored by an Australian sponsor and another one by an Indian sponsor. And he has used our platform and he will share his experiences.
Thank you, Suresh. Good afternoon, everyone. I'm Dr. Srihari. I'm a practicing diabetologist in Bangalore. Clinical trials we've been doing since ages, and we know how cumbersome clinical trial was earlier. 5 years back when I started my clinical trial journey, the main area of problem was the storing of the CRF so that it does not get wet or all other issues. But now with the new onset of Triomix, the complete investigation is digitalized. I have done 2 studies with them. One is Reasarch study where it's done for the COVID, and another is a ultra-human study. With both of them, it is very easy. You don't have to do anything, and all data is stored in a digital way. And one good thing, one more additional is they provide a on-site CRC. If you don't have a full-time CRC or you don't have CRC, that is one advantage. Triomix gives the CRC, she is there full-time, and I have interacted with 3 or 4 CRCs. I can bet you they are good. All CRCs, they work very well, and one of the CRC is very advantageous what Triomix has done. In one Reasarch study, I conducted in 1 month, had 200 patients. We could finish it. I still remember when Dr. Suresh called me one night and said, "Sir, we need to do this study." And I said, "Okay, when I'll start." But he said, "Sir, we need to finish it in 1 month." And first we had to have 100 patients, but we could go on up to 200. So easy it is. And the CRC were very cooperative. I can say that they were there from morning 7 o'clock till night 11 o'clock also till we completed the study. Last but not the least, remuneration part, I don't want to reveal, but it's very good, and it's on time or even before. So with this, I think Triomix, wish you all the luck for your future endeavor. Thank you very much.
Thank you, Dr. Srihari. Thank you so much for those words. We have few other investigators who couldn't make it today. Yes, please. Please stop.
Like NHS, NHS has, I don't need a speaker. NHS has a uniform EMR record. In India, we don't have. Every hospital has a different EMR record system.
Correct.
And to collect data and process where you have a 69% of correct data into your system, will need a lot of setup
Correct.
data mining and putting to be done.
Correct.
So how do you take care of those parts?
Definitely.
And secondly, when you say that you do software verification from the records of the hospital, OPD records or the lab records, how do you take care of the identification of the patient in terms of the patient's identity not revealed to the sponsors or the CRCs or the monitors of the site?
Got. That's a very, very good and valid questions, definitely. We are going to address that. We have a couple of slides left over. We'll finish that and I'm going to answer those questions. Thank you. So there are other 2 investigators from Chennai who couldn't make it today here, but they have participated in our trials and they have something to say for you.
Hi, this is Dr. R.P. Rajesh, consultant diabetologist from Ardhavan Diabetes and Research Center, Chennai. As of now, I have conducted 2 clinical trials with Triomix. Initially, I was very much inclined to do a clinical trial, but unfortunately, because of lack of time, I had a very hectic clinical practice, and because of that, I was not able to find good time to do clinical trials. That was the time Triomix actually contacted me, and after that, I started doing clinical trials with the Triomix. Then everything became very, very simple. They saved a lot of time for me. Triomix saved a lot of time for me, and now I am able to efficiently conduct a clinical trial along with my clinical practice. And one more thing is that they have an excellent coordination with the central laboratory. So each and every time we need not call the central lab to collect the samples as well as to receive the reports. Everything was easily done just with a single click. And another important highlight is that most of these works are paperless. So we don't actually have to find a storage space to keep all the files in the clinic. So most of these things are paperless. And another thing is that whenever we do a clinical trial, the monitoring takes a lot of time. It consumes a lot of time. So what happened with the Triamix is that most of the monitoring was actually done remotely, which saved a lot of time for us. So considering all these advantages, I am eagerly looking forward to do more and more clinical trials with Triamix in future. Thank you.
I'm Dr. K. Bharanidharan, Senior Consultant Diabetologist, Supra Diabetes Care and Research Center, Chennai, and also I am consultant in Kaveri Hospital, Chennai. I have conducted one clinical trial in Triamix. The concept of super site from Triamix is a plug and play concept, which is quite interesting. Everything happened digitally. All the reports has been sent digitally, which I can just view it in my tab, and it's hassle-free. And I can also access all the records, which really helped me in doing a research in the clinic, which I just appreciate from Triamix.
To answer, the session is open for the question and answers, and to start with the question raised by Mr. From the WOCAT, I will invite my colleague Aniket Jaiswal, who is going to answer your question, sir.
Thanks, Suresh. Good evening, afternoon. So basically, you have two questions. One was on the data transformation, which is basically, I can say standardization of the data across different hospitals, and one was like the identification of the patient and their mining operations. So basically, as part of our super site process, we do two level of transformation. So when we convert any hospital into super site, we do a mapping of whatever standards they are using into our standard coding. So let's say one hospital is using a Dolo for paracetamol, one hospital is using Crocin for paracetamol, or one hospital is using C as a paracetamol. So we map all the 2, 3 or whatever different terminologies they are using into a standard coding, which we have mapped as part of our process. So these standard codings are Loing, ICD, SNOMED, CT, or other standards which are used as a global scale. So whatever hospital are using, irrespective of what, when we have the mapping at the central level, so let's say Dr. Srihari or Dr. Barney or Dr. Rajesh, for a same parameter, they are using different terminologies. So they will interact with their own terminology, but at our end, we will receive in the standard format, which we have defined. So this level of mapping we do at the time of the onboarding of the super site. That is the process of the transformation. So it takes generally 15 to 20 days because we have developed our own interface engine, which makes the entire process of transformation from one terminology to another terminology very efficiently. So hope this answers your first question. In terms of the second question you have asked, like how we are handling the identifiers, because patient safety and patient confidentiality is the paramount process in any clinical trial, and that is something which is a challenge across all the clinical trial practices, and due to which majority of the sponsor or majority of the pharma company don't want to digitize the processes. So what we have done is, like as Suresh has mentioned, we have a very great engineering team. People are from IITs and BICS who have a very great engineering mind. So we have devised the platform in a way. We do segregation of the identifier and non-identifier data, and we only receive the data which is non-identifier from the hospital. So as part of removing the PIIs from all the databases, we do that level of segregation whenever we are having any query. So we are using AWS technology for those fronts. So it's a very standard process which happens in US market and a UK market. So same level of standardization and transformation we are implementing into Indian market. Happy to answer any other questions. there's some questions.
I think more of a comment. Thanks for being a part of KRSSDI. I think we always have inertia. We always believe in just practice, practice, and practice. And we, as one of the other doctors who was testimonial, he was telling that we are a very busy practitioner. I think by doing that, we are losing sight of many, many things in medicine itself. Forget about in life, we have lost a lot of things anyway, thinking of practice. So I think that is where we need to be careful and start having inclination towards practice. I was fortunate to work my initial, just after passing out, with good clinical practitioners and clinical researchers like Dr. Arpandev. And so I've been there in touch with clinical research from almost 20 years since the time I graduated. So, and then initially then a lot of DCGI rules and regulations made it almost impossible to conduct clinical research. And now I actually conduct research only in Manipal Hospital.
Okay.
So there are, these are the one things which we need to first open ourselves before we embark into the details of clinical research. That's one thing. And in the coming days, we will do one platform to run, that's in my mind when we through KRSSDI, that how do we include many other things in clinical practice. Clinical research, it has to be managed. Even we were not digitized. I and Arvind are working. So initially we thought it's a waste of time. I also used to think digitization is a waste of time. But when we start doing it more often, it actually saves time. And of course our handwriting is not the best in the world. And so even on that legally, and when you have the data only you can act on it further. So I think digitalization should be the forefront of all our practices first. I don't, many times we struggle to read what we have written sometime back also. So then comes the clinical research, CRCs, and then it was so much of a mandate few years back, especially. It became too bad that now I do clinical trials just to keep afloated, be in touch with clinical trials than for the monetary gains. Even that way, it is not so attractive for us to get into that. And I have had some interactions with him, and I think it's a very good platform. A lot of people are here whom we can share the data, and then we'll see how we can take it forward. Thank you.
Thanks a lot. Thanks a lot, Doctor, for kind words.
So doing clinical trials is one aspect. Like what about the publications?
So, yeah, so that's a very interesting question. So basically, as part of our session also, what Vikram has explained that as part of our ecosystem, we have a network of medical experts and regulatory experts who help you to transform your SDKM datasets or clinical datasets into standard formats, which we can use to publish as part of standard journals or international journals. So our medical and regulatory teams help you to basically find out which journals will be the suitable for your specific research and which type of publication we can target in terms of the novelty of the research or in terms of the novelty of the clinical practices. So that is something which our medical and scientific team are helping you on day and night.
And also the topics, in the sense we as a doctor, we tell you these are the burning issues and all those things. Do you have supports, like do you go through the journals, which is the topic which can be done, the particular study, this is attractive, this can be publishable, this is replicable. Main thing is, publishing is not a big thing nowadays.
Mm-hmm.
The publishing data has helped anybody in clinical practice, that is
Exactly. So basically finding out the novelty in the process, like whether this particular same research has been exactly done or not. So as part of our protocol development process, our medical team do a very robust research in terms of whatever existing research has been already done similar to that process. One of the study which Suresh will explain, where we have done study with CGM on healthy and pre-diabetic population. We have faced the similar type of issue because a lot of research has been already done in US and European market. But we have found out some novelties like what additional biomarkers like cortisol, HOMA-IR, lipid profile, we can make a correlation with the CGM data so that we can create an entire metabolic profile of a patient, which help you to identify whether what is the percentage of chances of you being from diabetic, pre-diabetic to diabetic and healthy to pre-diabetic. So that level of novelty we have gained through that extensive research. And now we are in process of to publish that similar research into AT and Nature also. Abstract submission has been done, so we are just waiting for the final confirmation.
Yeah, because that is the future, because publication is one thing. Future people are asking like, okay, you have published this particular data. How this published data has helped the clinician or they help the patient in their day-to-day thing. Good concept.
Exact. And also one thing is around the data quality also, because a lot of time the international journal don't have the trust on the data which has generated at clinics or local labs. So what we have done is, as part of our network, we have integrated with CAP aggregated labs. So you need not to perform clinical trial specific or clinical research specific test at local labs or just NABL labs. Using our platform, you can create orders and you can, so they will come and they will receive the sample and they will perform the analysis, and all the reports will be automatically populated into the platform itself. So you need not to get the report manually, enter all the parameter into the system. And the other advantage which we are leveraging using this type of infrastructure is like very robust mechanism of screening, because a lot of time if we miss one parameter, let's say if inclusion exclusion criteria is on the fasting blood sugar, HbA1c, OGTT or hemoglobin, so if there is a disparity in the data that the lower limit was 12 but you have mentioned 12.1 but in the actual report it was 11.9, so the patient is eligible, but actually the patient is not eligible. You perform the study with the patient, but when the sponsor re-verify the data, the patient is not actually eligible. So using this type of infrastructure, we are making the entire process 100% leakage proof, because all the data is directly coming from the verified system. And the tunnel which we are using to transfer data from central labs or regional labs to our system, it is validated and verified by 21 CFR Part 11 systems and FDA guidelines. So this makes the entire process at a global standard, like we can use that data for FDA submission or global submissions.
At the outset, I'd like to thank Dr. Manohar sir for including such a novel approach towards research. Hats off, sir. Thank you. Thank you for that. My question is, I am from Gulbarga, which is around 600 kilometers from here, and how do we, because I don't think so anybody being physically present at the site is needed. You can coordinate online.
Sure.
So how do we go ahead with that one? First thing. Second is, I think a speaker earlier to you, or probably you, spoke about IITs, investigator-initiated trials. So what are the criteria for that we should be looking, or you will be the one who will decide X, Y, Z topic to be taken up? So is it totally investigator-initiated, or your medical team will have a say on that?
So, so basically, as part of your first question, you being part as a Gulbarga, so how we can collaborate? So our team works with hospitals and sites pan India. We have sites in Delhi also. We have sites in Ahmedabad. We have sites in Chennai and Vizag also. So distance is not an issue. Our teams can work with you and transform your site also into super site.
In fact, we have one of the sites in Belgaum. So, but still the connectivity I'm saying. They are also approachable, and we have Dr. Neeta Deshpande. She is our investigator for one of the trials. Yeah, please.
Yeah, and answering to your second question, as part of IITs, so basically using our platform, all the investigator can do all their own IITs using our team in terms of converting the CRF into digital CRF and then mapping the CRF field with EHR databases, with lab databases. And when if you need any help in terms of regulatory guidelines, if you need any help in terms of medical guidelines, whether the idea is novel or whether I need some funding related to some sponsor or BIREC or other departments, so our medical and scientific team can help you on that front. It depends what exactly the investigator needs and what exactly the investigator wants. Yeah. I think any more question? Any of the
Anything
doctors?
else? We have a stall number is 23. Just for time, I think we are running out of time. Any questions, please do visit us at stall number 23, because our idea is to convert your clinical practice into your clinical super site, where you will be updated with the latest investigational new drugs before they get into market. You will have an access to the INDs, and we always feel that if we are updated, if we are not updated, we will be outdated. Thank you all. Bye-bye.
Thank you. Thanks a lot.
You can have it, please get it. So good clinical practice is the topic next, and I think one of the most important integral part of clinical practice related to research, clinical research, is the having a GCP certification. Not just in paper, but in practice. And few months back I had got mine. So if you're in active research, you got to change my brother.
Thank you. So good afternoon all. We had a very interesting session where we discussed about how data is being transferred from the source data into ECRF form. EDC has been functioning for quite a while now, and the challenges what we had in India is about the same, about transferring the data from source data into a format which is being data mined and being transferred into a system, and we have a proper flow of the data, because setting up the entire system takes time and there's a cost as well. But I'm sure that we are all moving towards digitalization of data, and that's how we're going to move in as well. So I will not go into my CV. So I have done more than 110 studies. I've got 16 years of experience in clinical operations. I head the clinical operations, regulatory, PV, and QA of OCAD. I'm also MBA graduate. I've also completed my master's in artificial intelligence. Currently, I'm pursuing my certificate from strategic management, and I'm also doing a PhD in management as well. So that's my background. So GCP is actually takes about a couple of days workshop, but we are trying to finish in the next 20 minutes. So I'll take you to the definition of GCP. So what I've done is I've broken just GCP definition into parts, where I say it's a standard. It's a standard for designing the protocol, for conducting the study, for performing the study, for monitoring of the study, and auditing and recording and analysis of the data. So these are very, very important part when we say what is GCP. Anybody can tell me any idea what is the difference between audit and inspection? Anybody? So audit is or monitoring is a part which is done by the sponsors. A sponsor CRA, when they come to your site, they do monitoring. When the QA person comes to the site, your site, to do the data verification, they are called as auditing. Whenever a FDA official comes, whenever from a state FDA or from a regulatory authority or from US FDA will come to your doorstep for looking to your data, that is inspection. So as an investigator, it is your responsibility to allow all the monitors or auditors or inspectors to come to your site and evaluate the data. So we have to report clinical trial that provides assurance that the data are credible, accurate, and the rights, integrity, and confidentiality of trial subjects are always protected. So this is a definition of GCP. We follow ICH GCP E6 R2 guidelines. It is based on Declaration of Helsinki and assures protection of human subjects. So we also have international harmonization aimed at ensuring good quality, development of safe and effective medicines, registration in most efficient and cost-effective manner. We all went through COVID a couple of years back, and we also had a vaccine which came up. But do we know that the Oxford vaccine, the study was done in UK. But because India follows International Conference on Harmonization, ICH GCP, even they did a phase 3 study, we did not have to do a study from phase 1 to phase 2, phase 3, or a preclinical. We directly did a bridging study in India, and the vaccine was approved in India as well. Because of the racial system, we at least had to do a bridging study. We did not have to do an entire gamut of clinical trial from preclinical to phase 1, phase 2, phase 3, and the product was marketed because India is part of the ICH GCP guidelines. So what is GCP? it protects trial subjects or patients, credibility and reliability of studied data. So when I'm saying subjects or patients, subjects as in when we are doing a phase 1 study on human volunteer, we call them as subjects. Whenever we are doing post-marketing studies or observation studies, we call them as patients. So there's a difference between subjects and patients when we are reading a protocol. So as an investigator, we should understand that what is a term being used by a sponsor or a medical monitor when he comes to your site saying that, doctor, I want to do a study with healthy subjects or patients. So we need to understand that whether he wants to do a phase 1 or a phase 2, phase 3 study, or he wants to do a phase 4 or PMS kind of study. Okay. What also is important is that whenever you follow ICH GCP, it ensures that the data is credible, reliable, and the study data can be published. So when we had this question in the last session as well, that how do we have a good publication? So whenever we want to do a good publication, first is that we should have a good protocol in hand, a good properly scientific designed protocol. Always if it's an interventional study, a randomized study, the chances are good that your study will be published in a good journal. But if you follow ICH GCP guidelines, you have all the regulatory approvals, you have all the ethical committee approvals, then of course your study will be published in a very good journal. Okay. So why GCP? It protects the right and safety of subjects. Trials are based in good science and well designed and properly analyzed. Trial procedures are properly undertaken and documented. Assures integrity of data submitted to regulatory authorities. Presents a record of the trial, that is source document. What if GCP is not followed? Subjects who can take part may be at risk. You may have a wrong study which is approved or wrong medication which is approved. Failure to obtain approval of useful drugs. Suppose you are not doing ICH GCP properly. There could be a chance that the drug is very good, but you did not get approval because you do not follow ICH GCP guidelines. Costly litigation if patients are harmed, especially in US, if you do not follow ICH GCP guidelines, doctors are also barred from doing clinical trials and also clinical practice as well. So who are the stakeholders? The stakeholders are the investigators, investigator team, the regulatory authorities, CRO, the IRB or IAC, and the pharmacist as well. You would imagine why a pharmacist, because a pharmacist is a person who stores the drug at your site. Suppose it's a blinded study, it's a randomized study, even the pharmacist has to follow the ICH GCP guidelines and ensure that he follows the protocol and there is no deviation in terms of storage of drug, in terms of dispensing of drug to the patient as well. So even the pharmacist also is a part of ICH GCP to be followed. Principles of ICH GCP. Clinical trials should be conducted in accordance with ethical principles of Declaration of Helsinki. Before a trial is initiated, foreseeable risk and inconvenience should be weighed against the anticipated benefit. You may have a very nice protocol, but you have to ensure that the benefit is more than the risk involved. So all those has to be taken care whenever a protocol comes to you. So whenever a CRO or a sponsor comes to you with a protocol saying that, doctor, I have a protocol to undergo, you as an investigator best judge tell him that, no, this protocol has this lacunae, or you have to maybe change few inclusion criteria or few exclusion criteria or few study design so that the risks are less. I'll give you an example. Suppose a patient who is undergoing chemotherapy and you say that my drug wants the patient to come to the hospital on a weekly basis. Is it really justified? Because chemotherapies are given on maybe after 3 or 4 weeks when the patient comes to the hospital. If you call a patient who is undergoing chemotherapy, who's undergoing oncology treatment on a weekly basis to a hospital, that's a wrong protocol which we have designed. So we have to, as an investigator, you have to tell the sponsors that, sorry, the protocol is not right, you may have to change this part of the protocol. So always the investigator or the medical monitor, it is responsible for the design of the protocol which is being undertaken. The most important part whenever a clinical trial is done, rights, safety and well-being of the trial subjects. Whatever trial you do, you may be spending billions of rupees in doing a clinical trial, but if the drug is not safe, you cannot go ahead with the study. I was doing a study when I was in Merck with a phase 3 study on multiple sclerosis. It was a very good drug. But it had certain safety issues. We from the company as a sponsor had to stop the study after phase 3. We had spent hundreds of billions of rupees on this drug because it was an international trial globally conducted, but we had to stop the study as well. We also should always have the available non-clinical and clinical data. Suppose some sponsor comes to you or CR comes to you, sir, saying that we have a phase 3 study to be done.
the investigator is always liable to ask the sponsor or a CRO that please provide me the phase 2 data, please provide me the phase 1 data, please provide me the preclinical data. After going through all the data, then only you should be able to start the next phase of study as well. Clinical trial should be scientifically sound and described in a clear, detailed protocol. So always you should say that the protocol what you have is a detailed protocol which tells you the entire aspect of the protocol, the medicines, the IPs, the storage conditions, the visit schedules, etc., etc. A trial should be conducted in compliance with the protocol that has received IRB or IAC approval. So no trial, be it IA study or intervention study or a phase study, we cannot start a study without a IRB or IAC approval, right? Regulatory approval at times is not required. As I said earlier, for IA studies, regulatory approvals are not required, but for any study you do, you have to take an IRB or IAC approval. Anybody, what is the difference between IRB and IAC? So IRB is the ethics committee which is associated with the hospital. Ethics committee is not associated with any hospital. Independent working is IEC, Independent Ethics Committee. The medical care or a medical decision made on behalf of subject should always be responsibility of a qualified physician. The protocol may say that this is a rescue medication, but as an investigator, it's you who will judge and decide what is the rescue medication given to the patient, what is the care which has to be given to the patient. Each individual involved in conducting a trial should be qualified by education, training, and experience to perform his or her respective task. So every investigator who is doing a study has to be GCP trained before he initiates a study. Freely given informed consent form. We always have to seek an informed consent from the patient, and it will be a freely given consent. We cannot coerce or push the patient to give us an informed consent. We have to always explain the nitty-gritties of the protocol and take the consent from the patient. All clinical trial information should be recorded, handled in a store that allows it accurate reporting, interpretation, and verification. Verification is very, very important. As I said earlier, inspections, monitoring, and audits can happen outside. So you should allow verification of the data as well. Confidentiality of records should be always maintained, and the privacy and confidentiality of rules of patient should be always taken care of. IP, the investigation product should be always manufactured under GMP guidelines. As I said, GCP guidelines for clinical trials, all the IPs which we are undertaking a clinical trial has to have a GMP guideline certificate as well. We can only do a preclinical study with the R&D batch data. But as soon as we move to a phase 1 clinical trial, we have to ensure that the product or IP has to have a GMP certification. Only preclinical can be done by R&D batches. We have to have systems that produce quality of every aspect of the clinical trial. So these are the 13 principles of GCP which we have to adhere to while doing clinical trial. Now there are a lot of chapters in clinical trial, from sponsors' responsibilities to investigator responsibilities to IP dispensing, making, producing, and also the records as well. I will just touch upon the investigator responsibilities. So the investigator should have a qualification, you should have an up-to-date CV, compliance with GCP, permission of monitoring by sponsors and regulatory authorities, maintenance of list of qualified personnel who are delegated for each responsibility. Suppose you have a CRC at a site, you have to have a delegation log which says that XYZ is a CRC, ABC is a pharmacist, OPQ is a nurse. So you should have a duty delegation log which says that each responsibility is being done by a specified person at a site. The investigator should have adequate resources, it should have enough patients to recruit, it should have enough time to conduct a study, they should have a qualified staff, they should have enough facilities, and also they should be trained to do a clinical trial. A qualified physician is responsible for the trial-related medical decisions, provide adequate medical care for AEs or other significant medical conditions, inform PCPs about participation in a trial, make a reasonable effort to ascertain why participants withdraw from the study. Suppose a patient withdraws from a study, an investigator should try and find out that why did he really withdraw from the study. Was it an adverse event? Was it that the visit schedule was very difficult for the patient to come? Was it that there is lack of efficacy? So we as investigators should find out why the patient dropped out from the study and also document that as well. Everything. So whenever a patient goes out of the study or removes his participation, we have to find out that why did he really get out of from the study. Communication with IRB, this is very, very important. We always feel that the communication with IRB has to be done by the sponsors. No. All the communications with the IRB or the ethics committee has to be done by the investigator. What does the sponsor do is, a sponsor supports you in terms of getting the documents ready for the submission to the ethics committee, but all the documents, if you see, goes from your letterhead. Your letterhead goes asking him to do a clinical trial and approval. Your CV goes, your undertaking goes, your MRC detail goes. All these details from your side goes to a ethics committee for approval. Sponsors can only support you in terms of the ethics committee fees as well as the dossier submission to the ethics committee as per the requirement. So if you all know this, every ethics committee has a different set of requirements for their EC approval. Some say that they require 5 copies, some say that they require 10 copies, some say that they require the financial agreement as well, some say they don't require. So every SOP is EC is different, and every SOP requirement is different for EC approval as well. So the communication between the IRB, the ethics committee, is to be done only by the sponsor. Suppose there is a AE or adverse event or adverse drug reaction at your site, you as an investigator will have to inform your ethics committee that such an adverse event has occurred at your site, nor the sponsors. It is very important that the investigator complies with the protocol. There could be protocol deviations or violations which is okay in doing a clinical study, but you have to see that you adhere to the protocol and its requirements. So a proper training of the protocol is very, very important when you undertake a clinical study. IP accountability, also important. I was doing a drug on oncology where the IP, each tablet cost about 20,000 rupees. You know, for a 6-week therapy and all, the entire therapy was for 36 lakh rupees. So IP accountability and storage is also a very, very important factor for an investigator when he undertakes a clinical trial at a site. How many medicines were being used, how many were destroyed, how many were unused, how many were returned back. So all these are also a responsibility of an investigator when he undertakes a clinical trial at his site. Again, as I mentioned, all the records have to be stored, all the source data has to be stored. You have to store your data for, especially your intervention study, for 15 years after the product is being launched in the market as well. So ensure that whenever you undertake a clinical trial, what happens to not only the CRF form, but also to your source data, your X-ray frames, your MRI records, your lab reports, all those have to be stored for a period of 15 years, especially for interventional trials. And hence, whenever you conduct a clinical trial, you have to first discuss with your sponsors that what happens to my source data, where does it get stored, do I store it, do you have a third party where it can be stored. So all this has to be discussed before a clinical trial is being undertaken. As I said, again, the progress report has to be informed to the ethics committee on a regular basis, maybe 6 months or yearly. It all depends upon the EC SOP. Suppose there is an adverse event happening at the site, the sponsor has to inform the ethics committee about the adverse event and what treatment was being done. And maybe if it is SAE or something, the EC may communicate what insurance has to be paid or what compensation has to be paid to the patient. Again, if you want to terminate the study at your site, as an investigator, you have the rights to stop the study at your site and premature terminate as well. Again, as final reporting, so whenever the study gets over, you as an investigator will have to inform the ethics committee that the trial has got over. So these are, in short, the responsibility of an investigator while doing a clinical trial. We have many other responsibilities of sponsors, etc., which we can discuss later as well. Thank you. Any questions?
Good afternoon, everyone. Any questions regarding the ICH-GCP talk that you just had? I know it's a difficult talk to have post-lunch, but then yes, this is one part which is very, very important if you want to become an active clinical researcher. So yes, we would like to thank him. Thank you, sir, once again for taking the trouble. And yes, it was an excellent talk. But yes, believe me, all of would have had multiple questions if we were getting a certificate out of this for the GCP. Okay, so thank. Yes, I think. I'm sure we can talk to Dr. Manohar and see that people who want to get GCP certified can be done by a simple training session on ICH GCP. Thank you so much, sir. Thank you so much. Moving on, thank you once again. We will be moving on to the next workshop. First of all, I would like to thank KRSSDI for giving us an opportunity to, first of all, come in a room which has been named after our guru, Dr. K.R. Narasimha Shetty, whom we lost recently. And second, the person who is responsible for giving a push to many of these institutions, organizations, Dr. C.D. Srinivasmurthy. So I'm sure Dr. C.D. Srinivasmurthy, is he here? Okay, I think he's downstairs. But yes, a few lines of for Dr. C.D. Srinivasmurthy. He is one of the most loved teachers who was associated with DNB teaching programs across Karnataka. He has published several hallmark papers, both in national and international journals. He was associated with IMA, API, Holdsworth Memorial Mission Hospital, and was instrumental in building the MRCI hospital. So a big round of applause for Dr. C.D. Srinivasmurthy for his kind-heartedness. Starting with the diabetic foot workshop, yes, I know many of you have come here for the practical tips from the boss who is standing there, Dr. Sunil Khari. Many of you will be knowing him. My name is Dr. Pavan. I'm also a diabetic foot surgeon. I'm basically an orthopedic surgeon. I take care of the Department of Podiatry at Karnataka Institute of Endocrinology and Research. So when we were initially thinking of doing a diabetic foot workshop, and I was talking to Dr. Sunil sir, the whole idea was we did not want to talk about dressings. We did not want to talk about WAC, because knowing that you are all physicians, I mean at least 90% of you are physicians here, we wanted to make sure that we went back to basics. So that was the whole idea which originated, and that's how we started thinking of, okay, let's try to get all the physicians back to basics to see how well can a physician identify a diabetic foot, identify a pre-ulcerative lesion, and what can he do best with the setting that he is in. So that was the whole idea of this diabetic foot workshop. Yes, I know Dr. Shekhar sir was supposed to be chairing this workshop. I think he's just finishing one of his talks in the hall below. So what we would do is we'll be going ahead. I have already given you the introduction of Dr. Sunil. Dr. Sunil, if you can please come. We will be starting off by giving small talks, and then we have a patient with us who is come from very far away. A big round of applause for her, because getting doctors to such programs itself is difficult. You can imagine getting a patient here. So we would really like to thank you, ma'am, that you took time off and have agreed for us to demonstrate certain things on her. Thank you once again. Dr. Sunil, all yours.
Thank you, Pavan. At the outset, let me thank the entire team of KRSSDI. They just gave me this opportunity to share my experience and the company, what I have built up, Mandakini Medi Inch Health Private Limited, where we have taken up this first initiation, wherein my concern will be how best, as a surgeon, I have seen in last 25 plus years, varieties of cases. Now the issue is, it's only going to be a high risk, and high risk. So it's becoming a puzzle to most of the physicians. So I thought that let us solve this puzzle. You all are quite capable of handling it. I don't want any surgeon to work on this area. Let us work on basics. We are not interested in dressing. We are interested in preventing first ulcer. All physicians are interested in preventing first ulcer. So I have created a kit with this background, where it will be given by my executives are there. Devraj and Dominic, please give a kit to everyone who is there in this hall. And the kit contains the most important 2023 calendar. The first January, February, March will boost you that I am going to do this. I have given you a forefoot ulcer heals in 100 days, a midfoot ulcer heals in 100 days, a hindfoot ulcer, which is very difficult to heal, heals in 100 days. After that, after April onwards till December 2023, I have given you, please go through what you should start working in your clinic tomorrow, that is on Monday morning onwards. All protocols, guidelines, info cards are there in that calendar, and I have made particularly that April onwards, you will not appreciate any dates or anything, but you will appreciate only what you should do with the foot. I have given some pamphlets which should be circulated to all your patients, what education they require, 30 mantras, how I can prevent foot problems. Then the most important thing I have given you is a nail filer. Please make it a point that every patient should have a nail filer. He should never cut his nail. The moment he takes a bath, it is wet, ask him to file the nail, and everything ends there. Never allow any patient to cut the nails. So these are basics what I thought that I should reach to every physician and convey this, and let me work. The goal, what I started with, as Pawan told, this was my concept, that our goal is, first to Karnataka, rural diabetic foot should be forward to prevent world's cheapest artificial limb, that is Jaipur limb. I don't want anybody to have a Jaipur limb. That is how one has to work on. Every physician can do this. This is our goal, and we can achieve this provided the major role is from the physicians. Number two, the theme is what best 360-degree care can be given to prevent the first ulcer. And this can be achieved by preventing, by assessing every aspect of the foot, and how one has to deal with it, I will be dealing with in a short while. Everyone is looking at amputation. Everyone looks at the data. By the time I finish this 1 hour lecture, I think it is 60 minutes. And as you know, every 20 seconds, one limb is amputated across globe. So around 180 limbs will be amputated, or 180 amputations will be performed by the time we finish this workshop. So what is required? We need to address whether I'm going to cure this condition, whether diabetic foot is curable, number one. Number two, what is the number? Why you are so worried about it? Is it a big number, what we are seeing it? What is functional limb and what is non-functional limb? What is footwear science? Why we have not been taught in our curriculum in medical college that footwear science is very important now. Number four, what exercise advice I am supposed to give as a physician to the diabetic foot person? All of you are so much curious. I think morning they had a discussion on yoga and exercise. So what exactly we are supposed to advise to the patient who has a foot issues? Now we need to make connections to sort out the puzzle. What is that connection? We are unable to pick up at risk foot, we are unable to detect high risk foot, and we are unable to detect very high risk foot. So we need to have understanding regarding foot behaviors in diabetes, number one. And number two, plan to salvage. How you can salvage it? If you understand the behavior of a foot for a trivial injury, yes, you can salvage that limb. The next point was, we need to visualize the differences when I should refer it early to the next level of a higher center. As you know, metabolic, you are the leaders. Vascular, there is a person who deals with it. Microbiology, very important. Wound care is very important. Education to the patient is important. But the most important is offloading, offloading, and offloading. If you don't understand this new science of offloading, how you should offload the body weight when patient starts walking, I don't think any wound will heal. In spite you have an excellent coverage of all these. So we need to fix all these in the right way, then only the puzzle can be solved. What is our plan? Today's plan is, we have our strategy, and definitely we want to know what are the new challenges diabetic foot is going to come up with, what will be the new clinical presentation in next coming years, and what is going to be your new prescription, what you are going to give to the patient in coming years. It's very important now. And this is what all of us are trying to do to keep the foot in remission. Stay connected. How can doctors and patients reach us? It's an emergency. It isn't a foot attack. All of you are aware of heart attack, but nobody is aware of foot attack. Let it be acute, subacute, let it be chronic, let it be active or inactive. You need to get connected. And that is how we have created a DF helpline. Just connected on WhatsApp. Keep this number always with you. You have any issue anytime, just share the details to me. We are there to help you out. And this is how we are planning that we best reach across rural Karnataka to prevent amputations and to prevent Jaipur limb. Thank you so much. I think I am supposed to request Professor M.A. Shekhar sir to talk on a very, very important topic, how a glycemic control can prevent an amputation. I think sir will join us later. Meanwhile, I'll ask Pawan to deal on nail care and skin care for just 5 to 6 minutes. Thank you.
Thank you, sir. As usual, a small talk, but he conveyed a lot in that. So before we begin, I think Dr. Sri Srinivasmurthy sir is here. Thank you once again, sir, for your big-heartedness. A big round of applause for having supported KRSSDI through difficult times. And yes, we will be trying to make sure that your name lives on in the form of all these programs that KRSSDI does regularly to make sure that our staff, our medical staff, paramedical staff are updated on the knowledge not only regarding diabetes but also the complications of diabetes. Thank you once again. So yes, coming to my presentation, my work is very, very difficult now because Sunil sir has given me only 7 minutes to talk, and he has given me the topic of skin and nail. I mean, we all know skin is the biggest organ, right? Largest organ. But then what I will be trying to do, thank you. So what I will be trying to do is we will have an agenda just like Sunil sir had. We will try to see what are the different reasons for increased incidence in diabetic patients, what are the types and the treatment in a very, very small way, and how can we prevent. The cool mantra today is prevention. We are not looking at treatment. We are trying to prevent them. Okay? So coming to introduction, very basic skin disorders. Almost in 70 to 80% of your patients, you will see skin disorders, especially in the lower limbs, and nail disorders almost in 20 to 30%. And in fact, more if the patients are coming from a poor socioeconomic status. So the most common changes, what are the reasons? I will not go into the details of these things because you guys know this much more better than us. What are the reasons for the skin changes? What are the reasons for nail changes? Poor hygiene, poor socioeconomic status now cannot be a reason for the same. Please take it that I have seen people coming from slums who have maintained their feet in a better condition because they were ready to change their attitudes. So attitudinal change is the one that we have to start targeting. So again, reasons for nail changes, periangular erythema, capillary alterations, and glycation end products which get collected in skin, the superficial areas of skin as well as the nails which cause all these. Now there are different types of problems, basically divided into 3 types, associated with but not specific for diabetes, due to diabetic complications, and associated with neurovascular complications. So coming to the most common ones that you will be seeing in the lower limbs, the most common that your diabetic patients will show is furunculosis. We all know this. Hair root infection, which can happen very, very common in wet conditions. So most common is the Staph aureus, starts as a tender area growing to 2 to 3 centimeters, and then central separation. Simple antibiotics and wound care will take care. Carbuncle is nothing but a collection of all these furuncles. Many of them think that it's just an incision and drainage. No, you have to explore this cavity to make sure that all the septations have been removed. Intertrigo, again, almost 80% of your patients will have intertrigo if you are able to look at their feet. So this is one of the most commonest things that I tell my physician friends, that the easiest way to not miss a diabetic foot, ask the patient to leave the footwear outside your consultation room, tell him to come in, see his feet when he's walking in, and by the time you have finished everything, put your hands on the dorsalis pedis and feel for the pulsations. Dermatophytosis, again, can affect web spaces, but yes, nails, when it affects the nails, is called onychomycosis. The problem with onychomycosis is the treatment takes a long time, takes almost 3 to 4 months. Dermal and epidermal manifestations, again, believe me, when I see, I am at a tertiary setup where many of these are referred patients, and almost 90% of my patients already have dermal and epidermal manifestations. So diabetic dermopathy, this is one of the most commonest ones again, but most very benign, because these are atrophic hyperpigmented macules on the skin due to minimal trauma, mild pyoderma and or folliculitis. They are irregular, rounded, oval, and they do not cause any problems. There is a high correlation with retinovascular disease. So that is one point that the physicians can pick up. When you see a patient with diabetic dermopathy, these will not be itchy. They will just be there, they will not be itchy, they will not cause any problems to the patient. Diabetic bullae, how many of you have seen diabetic bullae? Yes. So this is how common diabetic bullae are. Please do not put it on the patient that you have walked barefoot, you have put pressure on it, and the patient will vehemently tell you that, no sir, I have not done any of them, because diabetic bullae do not happen because the patient has walked barefoot. They are common in lower limbs, they can be spontaneous. And there are reasons, people have looked at by taking a biopsy, they have found out there's some problems in stratum corneum causing it to become a bullae. But basically goes to say that these bullae are usually not pus-filled. They will have sterile fluid. The only thing that you have to do is puncture them with a sterile syringe, leave the skin there, do not try to deroof it, but in case when you are puncturing it, if you find out there is purulent discharge, please deroof it properly. That's not a diabetic bullae. So again, there are 3 types: spontaneous and non-scarring, hemorrhagic and scarring, and multiple tender non-scarring. How many of you have seen ingrown toenails in your patients? Or many of the patients, yes. This is how common it is again. The predisposing factors are poorly fitting shoes. This is the most common cause for an ingrown toenail. Improper nail trimming, which we will be trying to demonstrate on Sujata today. Excessive sweating, that can be a cause. Nail infections and nail apparatus abnormalities. And how can we avoid? Proper footwear, wide toe boxes or open toes with proper cushioning or proper protection. Proper trimming of nails straight across. What do you mean by that? I will talk to you in the next slides. Addressing the underlying pathogenic factors, like treating hyperhidrosis or onychomycosis. Cleaning with hydrogen peroxide or iodine, this is doubtful, but yes, we will show you. Silver nitrate application for the granulation tissue. Why am I talking about granulation tissue? Because these are the 5 different stages that your patient will come to you with. The first stage, where it looks almost like a normal nail, but the patient will tell you that he is having pain because of local irritation. Stage 2, where you will see a proper paronychia, there will be an abscess. Stage 3, where there will be a nail lysis at that area, you will see some unhealthy granulation. Stage 4, where there is the nail would have come up, the nail lysis would have started, and stage 5 when it is bilateral. So we again have a different, what our idea is to understand that if you see this, you have to tackle this patient, because otherwise this itself can give rise to a great toe amputation, a hallux amputation. So don't try to neglect it by just giving antibiotics or by just cleaning it. If it is not settling down, it is time that this patient goes on and meets one of the specialists. So what is proper nail trimming? Now you see 4 ways in which this nail can be trimmed. How many of you think that A is the proper nail trimming? None. So how many of you think that B is proper nail trimming? How many of you feel that C is proper nail trimming? Still none? So none of these are proper nail trimming? Yes, D. So everywhere we keep hearing straight across, straight across. What do you mean by straight across? I don't know whether you people have done it straight across. You try to do it, it's difficult, because every time we try to go inside and try to remove that extra part of the nail which you are trying to see, which is visible here. We think that this is the extra nail and we try to remove it. In diabetics, don't do it, because whenever you are trying to do that, the chances that you are injuring the underlying substance there is very, very high. So that is the importance of straight across trimming of the nails. Importance of a footwear assessment. How many of the physicians here assess the footwear of the patient? Very less. So this is one case which is going to demonstrate how important it is to look at the footwear. Now this lady, elderly lady, around 55, 58, she came to me, very good control of sugars, and was sent to me by one of my colleagues at my institute saying that the lady is following all the things that you have told her. She's wearing footwear, MCR footwear, which she thought was proper footwear, MCR Hawaii chappals, and she says that this wound has started since 1 month and it's not improving. So when we took her up, this was what it was. This was a callosity. Any callosity in a diabetic foot patient, consider it as a pre-ulcerative lesion. So that was the time when we decided that let's have a look at the footwear. And this was the footwear that she was wearing. Okay? This is not the proper footwear, but okay. Let's go to the next slide and see what is happening to this. You see that? Every time a neuropathic patient is walking on this footwear, which has an embedded stone in that, patient will not feel a thing. And that's the reason why the patient is coming back to you, thankfully with only a callosity. Can you imagine this patient wearing this and walking more than 100 steps a day for the next 1 month? This patient is going to definitely come back to you with a wound, with an ulcer. So one of the first steps of preventing the first ulcer, please look at what the patient is wearing. So we just removed it, told the patient to come back to us, everything healed. The importance of avoiding extremes of temperatures. I know many of you would have, I know there will be the mantras in the things that we have given you, Dr. Sunil has given you. Avoid extremes of temperatures. Forget extremes of cold. We rarely get extremes of cold in our place. Extreme heat, that is one thing. Many of your diabetic patients will have pain-filled peripheral neuropathy. And for that, they will be using electric blankets, hot packs, dipping their feet in hot water with salt. So many of you, if you are telling them, please stop telling them that. Do not tell the patient, a diabetic patient, to dip their feet in hot water. Does not help in any way. It only causes further problems. Now this patient is again an elderly man who came to me. I'm so sorry, I don't have the exact preoperative images wherein there were bullae and all. So the patient was going to a bath, and without checking the temperature, he just took 1 mug of hot water and poured it on his feet. And he came back with this. So it is important that you educate your patients how to prevent these. These are very easily preventable. They can check the temperature, not with their hand, because their hand would also be involved. Tell them to use their elbows. It's very easy. It hardly takes 1 minute, but that is going to prevent these wounds for you. Okay? And sadly, the right foot, this was the regular follow-up, and we could not save the left, second, and the third toes, but thankfully the right became absolutely normal. It just goes to show how simple things, how simple education will improve and prevent the first ulcer that the patient will develop. So with this, I will finish my talk. Yes, there are so many pamphlets which we have been making. We have been trying to do so many programs, educative programs. We recently did something called as a Safe Feet, Safe Ride, wherein we went to the PHCs trying to raise awareness about diabetic foot. Every one of you can do it. By the time the patient leaves your consultation room, you could have told them at least these 9 to 10 points. Give them a flyer, give them a pamphlet, at least let them know what they can do to prevent that first ulcer from happening. Thank you. Yes, we have Shekhar sir with us. So, no problem, sir. So we would like to hear from you.
Right. I'm sorry I was late. I don't know how it happened. 2:40 I was supposed to speak and 3 o'clock I was supposed to be here. It got, all these things happened. Now, Dr. Sunil Curry, who is a very good friend of mine, his name is Curry, but I am skin-wise, whatever you want to call me as, okay? He called me and said, Dr. Shekhar, you should be, actually he said, sir, I'm sorry, he's as good as me and I am as good as him. You must be a part of this diabetic foot workshop. And I said, what do you think I will bring to the table to the august body of what I should speak? He said, talk about prevention. I readily agreed. It's very easy to prevent, etc. like that. When I thought about it, I came to know it was a Pandora's box. You know the story of Pandora, the Greek semi-goddess? The king of gods gives her a box and says, don't ever open this. And inquisitiveness takes better of her and she opens. And she opens up all problems of the world and she is unable to put it back. That's why we are suffering, it seems, Pandora's box. And abdomen, you all know, they say in medical this thing. And now put the brakes on diabetic foot complications. He has given the topic. This is my disclosure. Fact, everything we hear is an opinion. It's just an opinion. What I'm going to speak is an opinion. Pawan, Sunil, it's an opinion, but it's an educated opinion. But it's not a fact because it keeps changing. And truth, everything we see is a perspective and not the truth. Keep this in mind. Fact and truth is the thing, disclosure that you should have. I don't know, I went to thank you very much for your patience. Deliberately I put it because it's such a patient hearing when a stupid man like me speaks to you about diabetic foot, which is not my field at all. Anyway, I remember in my early days of practice, when I was young, physically, not mature enough mentally, many of my patients, we used to tell them, don't do this, don't do that, it will happen and all that. How to prevent? An elderly person said, the biggest way to prevent is not to be born in this world. If you are not born, you can prevent a damn things. But we have already taken birth. How to prevent? The next biggest step is to prevent diabetes. Impossible. So, we are now in the problem of how to prevent diabetic foot problems, diabetic kidney problems, diabetic that problem, this problem, because we have diabetics in front of us. A very, very practical, pragmatic question that we have to answer. This one, I hope, AHA 2010, American Heart Association, came up with this. Simple 7 concepts. Reduce blood glucose. I should have written glucose, it's written sugar. Sorry for that. Control cholesterol, manage blood pressure, stop smoking, get active, lose weight, eat better. 7 concepts. Are you doing it? Say yes. If you are not, stand up on the bench. This, they called it as life's simple 7. Simple preventive measure to prevent your diabetic or yourselves from having a heart attack, having a kidney failure, having diabetic foot, blah, 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 is life's simple 7. Can we do this? If you can do it in your clinical practice for your patients, you can prevent it. I can stop here, but I cannot. I'll go for a few more slides. Barriers. unfortunately, these two are the barriers. The community and the system we live in is the biggest barrier. Whatever you tell them, you have told them, lost in translation, as Pawan said, please wear footwear. But we don't tell them what footwear, how to wear them, when to wear them. This is what he was talking about. That is the system barrier. Community barrier, no, we can't wear chappals into kitchen, we can't wear chappals into that room, this room. All those population admixture, etc. And personal barriers. The biggest is poverty. How do you define poverty? Empty pockets. No, it is poverty in their intelligence also. Please keep in mind the biggest barrier from the patient side and also probably from the doctor side is paucity or poverty of their thinking process. These two barriers, if we can overcome, we can prevent it in a big way. Factoids, we see so many Google scholars, Google University trying to give certification to all this. This is another major thing. Factoids are semi-truths, not full truths. These three barriers, if we can overcome, it's not very easy, it's pretty difficult. Now, why do you think diabetic foot is very important? You don't have a heart, can you live? No. If you don't have one kidney, probably. You don't have brain, definitely. But if you don't have a heart, you cannot live. You don't have a foot, you can probably. You don't have feet, it's very difficult. But from a diabetologist perspective, from a diabetic foot surgeon's perspective, diabetic foot is very, very important. Why? For heart it is macrovascular disease, for nerves it is microvascular disease, for retina it is micro, but diabetic foot is both macro and microvascular. So if you can prevent a diabetic foot, take it from me, you can prevent cardiovascular, retinopathy, neuropathy, and to a certain extent nephropathy. Can you understand that? That is the importance. And thanks to pioneers, that young Turk there and this old Turk here, thanks to them, they have brought to the forefront the importance of diabetic foot. Take care of diabetic foot. Prevent them from primary prevention or whatever it is. Take it from you. You can prevent a stroke, you can prevent a heart attacks, you can prevent heart failures and probably kidney failure. Right? You all agree? How do you say yes in India? You say yes in India like this. How do you say no in India? So we have to change our mindset. Like diabetic foot, you have to change mindset. Say yes like this, say no like this. Similarly, take care of diabetic foot, you will take care of micro and macrovascular complications. Prevent diabetes. I think these are all theory. Okay? You can all read about this. But what's important is, you have taken the step in preventing all these things. How do you prioritize? What is the priorities in prevention? And management I will not touch. I leave it to these two people to do it. What is the first priority to prevent diabetic foot you take in a diabetic? Anybody? Regular inspection of the feet. Glycemic control. Fantastic. I think you are doing a great job with your diabetic patients. How many patients? Wow. Give her a hand of appreciation now. The first step in a diabetic you take is blood glucose control. Inspect the foot, it's all right. Right? First step you have to take is glycemic control. How do you do glycemic control? It's beyond what we talk about it, lifestyle modification, education, euglycemia, etc. like that. But the next step is blood pressure and dyslipidemia. What is dyslipidemia? For a diabetologist, it is LDL below 25, 75, 100. For a diabetologist, LDL below 100, HDL above 45, 40. For men, 50 for women. I don't know why women should have more. The rest it's fine, okay? But for a cardiologist, crazy people, less than 50, LDL. HDL, more the merrier, more than 60, it's impossible. But proper blood pressure control from 160, 90 to 150, 80, is it good? Absolutely. 5 millimeter systolic can bring down 2 to 3 times the macrovascular disease. Simple. one step at a time. So we will not look at the guideline cut-offs. We look at bringing it down in a proper manner. And others, what are the others? Deliberately I put it, you can fill the blank any which way you need. Anything else, but the first step, as our great dietitian said, is blood glucose control. Whoever it is, young, old, middle-aged, whoever type 2 diabetic or whatever, blood glucose control is paramount. Then blood pressure, lipids and lifestyle, etc. like that. I hope I made myself clear. And lastly, look at this. The conundrum. Non-veg fit and active. All those puma, leopards, tiger, they are fit and active. They eat non-vegetarian. How many of you eat non-vegetarian? Lot of people. So you are fit and active. Except this guy who is a just joking. I know him very well. Okay? Look at the other side, the vegetarians. Elephant. They were saying, a doctor was saying, no animal is obese. I think he has not seen elephants. I think he has not seen a gendamruga, rhinoceros. Okay? They are obese. Probably not. You have seen a gendamruga, rhinoceros. The fastest speed it can reach is about 30 kilometers per hour. Beyond that, it can't run. It can run only for 50 meters and then it stops. Sorry, I can't run, Shaker. I'll stop. Look at this. What is the thing that you should get? Because let's not confuse our diabetics about unnecessary diets, non-veg versus veg, etc. The reason is, it's impossible to reduce weight by eating green grass and salads and walking. Both non-vegetarians who are very active, vegetarians who eat salads, it's impossible to lose weight. You have to shift your gear for weight loss, because I was told by Sunil, who is more of a physicist, he's a physics expert more than a surgeon, stupid fellow. He doesn't look at diabetic foot just for the sake of vascular, and he also looks at the kinetics of the bones and muscles, great activity. This is it. Okay? It's not just walking, it's not just eating, it is something else beyond that, which we have to decide. I'm sure Sunil will give you a very good idea. At the end of the day, patient-centered approach. I have deliberately put only these 5 or 6. Impact on weight. Whatever you do, blood glucose control, blood pressure control, dyslipidemia, you must look at the impact on weight, because 1 kg weight gain, 12% incidence of heart failures, 6% incidence of heart attack, all those funny things we have read about. But when Sunil told me quite some time ago, many years ago, 1 kg weight gain puts 1.5 kg on each lower limb. So 1 kg weight gain puts 3 kgs on the feet. So if you think blood glucose is fantastic, blood pressure is very good, dyslipidemia is normal lipidemia, but he has gained 5 kgs. Take it from me, they will come with calluses. That's what he was telling. I fully agree with you. Patient preferences. Chapli akadala sir. What does Pawan do? So you have to have an answer for that. Any answers you have? Anybody? Igella Google nal siguttallappa. Thick socks. They prefer to wear socks. A little bit thick sole. Socks, they can wear it inside. Outside, whatever. Simple answers I'm giving you. I'm not an expert. Cost, efficacy, etc., etc. You should think of. Okay? What happened? I don't know. Something wrong. Okay. Do you understand now? Deliberately I have put all this. Otherwise, patient-centric approach is patient in front, all doctors and nurses and all those people in and around. No. When it comes to diabetic foot care, it is the patient preferences first and then doctor's expert opinion. So this is my last slide, thankfully. What happened? All of us have gone through high school, almost done. We went on for the first 10 years of our existence. Then what happened? We went into PUC. Then we went into medical college and we went to the top. Is that the end? It's only a small peak that you have gone through. So OSHIT is the first thing that should come to you when you see a diabetic foot. Thank you.
Thank you, sir. Thank you so much. Thank you so much for putting putting the radar back on biomechanics of a diabetic foot. I'm sure Dr. Sunil will be touching on that. He was our director some years back, and we used to just love presenting to him so that we get the questions. And these questions usually made us think. And just like what you people are thinking now after going through all the slides that he has just shown you, believe me, this workshop, I hope, will make you think. Over to you, Dr. Sunil.
Well, the next presentation, what I'm going to show you is what is a 360-degree care, what we need to render through physicians to prevent the first ulcer. Degree care. Yes, yes, correct. See, I gone to the a 360-degree care to prevent the first ulcer. Very, very interesting. You know, I could get this beautiful template where, as you all know, that I have been working in this area since quite a long time. And I love regarding foot and ankle biomechanics, which is very, very interesting, very challenging. And I love to design footwear for all high-risk feet. High-risk feet is the one where it's a greater challenge to everyone across globe. And I've been with so many societies. Especially I love to be with International Foot and Ankle Biomechanics community, where it has taught us so many new things. Every patient of diabetic is something unique. From roots to results. So let us go to the basics. In Bangalore, in Karnataka, whether diabetic foot is happy, is it cared, is it safe, is it functional? Or is it lying in one of the corporate hospital months together? Or is it lying in the house months together? Basically, lower limbs are organs. They are organs of ambulation. If they are not functioning, and you say that I have healed a wound, I don't think a podiatric surgeon or any surgeon has done a great job on that. That limb has to walk. It has to ambulate. Then only your job is complete. Now, what was there in last 35 years? The first conference on diabetic foot was done in 1986 in Melbourne, where in UK they could see the longevity of life of 85, 95, and 100 plus because of use of insulin, and they noticed foot problems in their patient in 1986. First conference on diabetic foot was conducted in UK, Melbourne. Since then, in last 35 years, what we have learnt? You just go retrospectively. What we did well in last 35 years? We came to know it is a common, complex, and costly affair. Yes. Highest recurrences, highest relapses, highest failures. In best of the best centers in the world. What are the parameters to say that I have done a good job? Evidences. So we have got two evidences in diabetic foot. One is a clinical healing of an evidence. Second is a radiological evidence, which is not there radiologically in any medical departments anywhere. It is only in diabetic foot. If you want to say that I have done a good job in a foot, then you have to have two evidences. One is a clinical wound has healed, and take an X-ray and prove that there is no bone involvement. Then only you are right. You can't say that only wound has healed, so you have done a good job. What didn't work in last 35 years? We utterly failed to prevent the first ulcer. Utterly failed. We are struggling to heal the ulcer. We are using number of methodologies, number of dressing materials, number of advanced wound care modalities. And we miserably fail in preventing the recurrence. 60, more than 40% they recur within 1 year. So callus, pre-ulcer, ulcer, heel ulcer recurrence have been a challenges. So a short overview, I'm going to talk on cure, myths and facts, where I had created one group diabetic foot workshop group where they kept on asking me, and a lot of suggestions came. What is functional foot? What is non-functional foot? What is footwear science? What is exercise advice a physician should give to a diabetic patient? What are the new challenges? What is the take-home message? I cure diabetic foot. Wrong. You can't cure a diabetic foot. So what it is? There is only arrest. You can arrest a disease process by doing or advising the things. You can't cure the disease. Make it very clear. It is an ongoing process, and as long as he walks, he is going to break. What is success in diabetic foot? Success in diabetic foot is, sir, I have kept my patient ulcer free for 5 years, so as good as cancer. That is your success. Second, surgeon says, I have maintained a plantigrade foot, sir. Success. Shoeable, braceable foot I have given back. Excellent. I have kept foot in remission like cancer. I have not seen that after he went through ulceration, again I have kept the foot remission for 5 years. Excellent. That is your success. But don't expect that I am going to cure diabetic foot. It will never happen. And somebody says, even I have changed my consent forms to all my patients when I do surgery. There is no cure. I am not curing anything here. I am arresting a disease process for time being. This is a module, what we work on. This is a stairway of amputation by Rogers and et al., where it's very clear that your role is very important in primary care and secondary care. Tertiary care is altogether different. So we have different segments: normal, DF care, PNP, PVD care, DFU care, DFI care. Most important, rehab. I get many patients, sir, nan kaalvan tagadarri, illon kaal police kodavak. Look at the approach what patient come to me. I have lost one limb, sir, but I don't want to lose other limb. So rehab is so important. You have to work on that segment. Either you are working in primary care or you are working in tertiary care. Footwear science is very, very important. To prevent a first ulcer, to heal an ulcer, and to keep the ulcer in remission. It is a footwear and footwear science. One has to understand in a right way. So every patient who enters into your clinic is always with a question. Look at my feet and tell the prediction. You just predict, sir, whether I will go through any amputation or something like that. So we have a stratification 0, 1, 2, 3. And all of you know, in 2019, we had a latest inclusion criteria of PAD. That means we missed. In so many years, we missed. And what is stage 3? If somebody is CKD, dialysis, you need not have to assess anything. He is already in stage 3, grade 3. So we missed all these people in last 30 years. The first guideline was in 1996, 2015, 2019, 2023. We are getting one more guideline now. 160 countries meet and they draft the guideline. So this is something new turn we had in 2019. PAD, peripheral arterial disease, has to be assessed. Then only you can say that he is 0. There has to be no LOPS, loss of protective sensation, and no PAD. Then only it is stage 0. Otherwise, no. Earlier, we never used to check. It was all together. So now the things are totally different. Now what I want resource poor clinics, rural practitioners to know is, very high risk, stage 4 is barefoot walk. Worn-out footwear. Sir, you ಬೈತಿದ್ರಿ ಅದಕ್ಕೆ ಹಾಕೊಂಡು ಅಡ್ಡಾಡ್ಲಿಕ್ಕೆ ಚಪ್ಪಲಿದನ್ನು. Worn-out footwear, very, very wrong. Acute Charcot and chronic Charcot you are missing in your clinic. Very, very bad. It's a very high risk field. This is one classification. People are asking me that, sir, tell me a new classification where I can pick up the cases. YFE classification: wound, ischemia, foot infection. These 3 criteria together, you can come out and predict, as you have a TNM classification in cancer, that whether this foot I can save or he is going for amputation. So these are very, very important things. You can go refer, you can go through it. The most important thing is, should we preserve this limb? One has to assess this with your surgeon. It's a multidisciplinary team, but in India, I wish a good physician and a good surgeon, a 2-member team can salvage maximum limbs. Can Can the patient walk in the community? Can he walk at home? Can he transfer his weight from one room to another? No, he is going to be bedridden. So is it worth saving his limb? So criteria to salvage are also very, very important. Foot screening, basic screening is PNP assessment, PVD assessment. Footwear assessment, you need not have any dynamic pressure mapping. You can just go through the footwear. Where 7-8 years back when I was invited there in Mysore, I think last session, all the patients were seen only when I saw, after sir's permission, I used to see first footwear and I used to tell this patient is having lesion here. Am I right, sir? So it is a footwear which will give you 80% of the clinical acumen. If you know footwear, how to examine, what to see, everything is written there in the footwear. Number 1, number 2, number 3, don't miss footwear examination. And if you are interested in diabetic foot care, then keep your CPR score very high. Because if you are carrying your feet, diabetic feet, I just give 1 mark. I am protecting the feet, I give 3 marks. But if you don't know what to do next, you should know how to refer early, because that carries 6 marks. If you are not doing that right reference early, look at the timely references, everything cost, morbidity, mortality is low, but a delay leads to amputation and death. At just 2 weeks delay, we have lost the patients. So everyone has to have a CPR score which should be above 6. These are the foot types, what you'll be seeing in your day-to-day practice. But the commonest what you're going to see in next 10 years is this. Either somebody has got his grade 2 amputated, second 2 amputated, because everyone is going through high risk now. So to prevent this, we thought, why not get our colleagues, physicians into action now? They have to prevent the first ulcer. Then only we can prevent this kind of feats, which are going to be in big number in coming 10 years. What are the myths? Dressings heal the wound. Nee dressing madko thokpa, ad gayam aiti. No, it never happens. If that would have been the case, why so many people are wandering from place to place? So this is a myth. What is a fact? Dressings don't heal the wound. A properly selected dressing enhances your body's ability to heal a wound. A dressing never heals a wound. Number 2, diabetic foot ulcer is a medical problem. It's a myth. It's not a medical problem. It's a mechanical problem. Your body weight hits the ground, breaks the feet. What is a myth? Healing a wound, keeping wound healed throughout is the same science. If that would have been the case, why there is a recurrence in such a number? So healing a wound and keeping it healed throughout are 2 different sciences. You have to understand it well. The moment you look at an ulcer, you always say, Mulu chuchitta, Muli chuchitta, Chapletitu, Yen Badskondi. Wrong. This is not outside in injury. Nothing has come from outside. It is inside out injury. The metatarsal head, the joints, IP joints, they lose the cushions which are there in the diabetic normal people. They are lost, pushed forward or thinned out. And whenever he walks, the repeated moderate forces hit the ground, break the skin. That is how they come to you. But you keep on asking them, Mali chuchittu, Muli chuchittu, Kal chuchittu. No, it never happens. It's 80% of the ulcers are because of repeated moderate forces. What are the clinical types? You know, pre-ulcerative, ulcerative, non-ulcerative. This is very important. I want physicians to pick up these non-ulcerative feet. Active disease, chronic disease, neuropathic, which was earlier thought 70%. Ischemic was just 30%. Now it is neuroischemic, which has taken 45%. Critical ischemic, acute ischemic, which you have seen in COVID. I have brought this new one for all of you. Renal foot, cardiac foot, HIV foot. HIV is no more an acute disease, it's a chronic. Necrotizing fasciitis foot. Psychiatry patient with diabetes and diabetic foot. Critical limb threatening ischemic. Such, I had all these varieties. The most difficult is renal foot. If anybody is on CKD, on dialysis, and you are handling it with a small ulcer there on the heel or somewhere, some part of the foot, it is not going to heal. It is the worst foot. what goes wrong? What is functional foot? What is non-functional foot? It is altered biomechanics in diabetes, which leads to sensory, motor, and autonomic neuropathy. The non-enzymatic glycation end products get deposited in all the capsules, tendons, and fascias. So what happens? You have a sensory insensate feet, you have a rigid feet. I don't know how many of you have seen rigid feet. It's a log. I see in my practice there is no mobility of the great toe, there is no mobility of the ankle joint at all. Everything is fixed. He walks like this. And this is the worst stage. And I always tell all the young surgeons, never touch rigid feet. You can't change that rigid foot. You have to just get that rigid foot in a footwear. You design it in such a way that you heal the ulcer or prevent ulcer. You can't do any surgery. You do the surgery, it is again healing by fibrosis and becoming more and more rigid. So the rigidity, if it is there, try to work on a different line. So any rigid insensate feet, the moment it breaks, we call it as a non-functional. Functional foot never breaks. So what is basic foot concept biomechanics, as all of you know? Because of the insensate, the body weight gets fixed at a local area and maximum pressure is there. There is a callosity, and callosity is inversely proportional to the area and directly to the body weight. And that's how you get the break and ends up with the osteomyelitis. You have to look for the basic mobility of the great toe. If it is not, there is no dorsiflexion, that foot is going to break. If there is no dorsiflexion of the ankle, that foot is going to break. It doesn't require any gadgets. You don't require any n number of gadgets to deal with this, to check. Just take the great toe, try to mobilize it. Foot, try to do this. If it is rigid, that foot is going to break. So this is what we want you to people to assess in day-to-day clinical practice. What diabetologists can do, callus, trim it. You have prevented ulcer there. If you are not trimming it, you are all afraid to hold the blade. Okay, fine. Today I am going to tell you how you can do this with a nail cutter, nail trimmer. I have seen, we did it with the USV DEF program, where we gave hands-on training, but 80% of the physicians were not willing to go ahead with the trimming of that callus. So then I thought that we should give them something new idea by which they can reach there. Preventing first ulcer in a unilateral lymphedema. It's an active Charcot. What we did, we achieved inactive. We could bring it back to normal. How we did this? What are the steps? Weight-bearing X-ray, number 1, we could pick up fractures. Number 2, TCC, total rest, 1 month, 2 months, 3 months till the temperature comes back to normal of the contralateral limb. Then put the feet into the crow. This is a crow shoe. Fine, we could achieve this. What is happening today in day-to-day practice? The moment you see a unilateral lymphedema, tablet Dito, Lasix, 45 minutes walk every day. Review after 2 weeks. This is what is the prescription I see with most of the diabetologists. So what is the end result of this? This is the end result. There is a midfoot ulcer. And you blame diabetes for that. Diabetes is not a culprit here. You should have given 100% rest, TCC, and put the feet back into the crow shoe. Then only the foot will not have midfoot ulcer. But if you write for unilateral lymphedema, Dito and Lasix, that is not a management. What is new thing? What is the new focus in 2019 has come for offloading? Whatever we were practicing to heal a wound. So that was a short-term offloading. Now the new concept is long-term offloading, till he dies. Lifelong offloading, once there is a break in the feet. So these are the new things. One has to go through it, and one has to do short-term for 100 days. I keep on telling 100 days are very important. If there is a break, it heals in 100 days. If it is not healing in 100 days, I am wrong somewhere. I have not done justice in management of the foot in a right way. Now, the next basic is behavior of the foot. Look at it, compromised neuropathy behavior. You see daily such kind of cracks, great toe at the heel level everywhere. When you trim it properly, there is a hidden ulcer there. This is a neuropathy behavior. But same patient comes back after 2 months, gangrene of the great toe. Then you blame diabetes for that. No, you have missed that ulcer there because you have not trimmed it. It is hidden there inside. This is a classical neuropathy behavior of the callous skin where you have got lot of hidden ulcers there. This is compromised vasculopathy behavior. Patient was told that there is an impending gangrene, please go ahead, meet vascular surgeon. She said no. There is microvasculopathy, nothing can be done, and we can't go, nothing can be done. My doctor has said, no, you can open up the vessels. That's the reason vascular department has grown such a level across India. And see, the end result is like this patient enters my chamber. They don't listen because they have been convinced by physicians that nothing much can be done. You can open up all the major vessels, macro vessels, where you establish the perfusion pressure, everything gets to normal. But this is not happening. So you need to understand there is only basement membrane thickening in the foot micro as such. If you open the macro, there is an increase in perfusion pressure and everything opens up. What is compromised limb and neuroischemic limb? This patient came to me with great toe ulcer. You were shocked how he could develop this. He said, I had been for cardiac checkup and the limb lead was kept here for 10 minutes. And simple pressure of that ECG has led to this ulcer. Look at the behaviors, how the foot is behaving. You can't blame diabetes for this. You need to understand the science, how it is going in a different way. A simple 10 minutes pressure on that area, he could develop an ulcer. And similarly, I have seen surgeons doing dressing on a sensory foot, tight, which were this gattenkatri, and that has led to ulcers on the dorsum of the feet. So you should never apply tight bandages on totally sensor feet. This is immunopathy behavior. Patient was admitted in a medical college months together, and he said it is totally now well demarcated. We will not do anything much. Patient came to me. This was extensive disease. We did a bony amputation and he died. This is classical immunopathy. A patient coming to you with 5-year, 10-year, 15-year, 20-year, 25-year-old history of diabetes, they have immunopathy. Anybody above 10, a massive immunopathy, their response is very poor for the healing purpose. This is footwear. Most important thing is to prevent ulcer, to heal and to prevent recurrence. Time to buy in the evening. Life of footwear, only 3 to 4 months. Diabetic footwear has a life of 3 to 4 months. Patients come and tell, sir, you factory True, they have to change it. The most important part is the insole, which is 9 mm. If it reduces to 4.5, you have to change the footwear. If you are not doing it, he is going to come back to you with ulcer and he is going to have lot of problems. When to replace? Every 3 to 4 months he has to replace. What not to prescribe? How to prescribe in limited resource to a poor patient is very important. You can't say everyone that you should buy a footwear from such a company which is costing you 3,000, which is costing you 2,000 or 800 or patient can't buy, poor patient. So we need to find out some solution for that. What is it? What you look for in a footwear? Footwear screening is important. Look for the types of footwear, look for the wear, how he wears it. What is the insole quality? What is the outer sole quality? What is the size? What is the seam? Is it seamless or with seams? Adherence. Is he adherent to that? Is he using it regularly? Whether he has lost a great toe and is he using toe filler for that or no? All these are very important. Footwear science in diabetes. Foot doesn't know what to do in diabetes. Footwear has to do the job of foot. Foot doesn't know what to do in diabetes. Footwear has to do the job of foot. This is due to this kind of footwear. This is due to strap of the footwear. This is due to Jitendra style footwear where there is no enough toe box. How many of you seen in your clinic? 80% of the patient, I see them, they should come and sit in front of me and wear the footwear. They are using right into the left, left into the right. And that is the cause of the ulcer. 80% of the patient do this. We do it in childhood and we love that. And this is what happens when a patient comes to you, ask her to get the footwear inside, open up, See, there is no insole at all at that site. And you want to give her all kinds of antibiotic. It's only 100 rupee good insole will heal that wound. I want you to know outer sole, there is a thorn, the most important size. I was shocked to see a number 9 on the left and 8 on the right side. I asked the patient, why you are with Azonki Bharat like this? He said, sir, ಇಲ್ಲಿ ಬಾವು ಐತ್ರಿ ಜಾರ್ತೈತ್ರಿ ಚಪ್ಪಲಿ ಅದಕ್ಕೆ ಇದನ್ನು ಸಣ್ಣ ತೊಗೊಂಡಿರಿ ಟೈಟ್ ಹಿಡಿತೈತ್ರಿ ಇಲ್ಲಿ ಸ್ವಲ್ಪ ದೊಡ್ಡದೈತ್ರಿ ಕಾಲ ಅದಕ್ಕೆ ಕರೆಕ್ಟಾಗಿ 9. They are so intelligent. They have started managing on their own because we are missing it. This is very, very interesting. So size, and this is what is very important. Customization of footwear is a new science, how we do in our center. See, he went through all this major surgery, he is with the footwear. So this is how we customize it. Not to have a recurrence, he is with this footwear since past 7 years. He doesn't have any recurrence. What not to prescribe? This patient came to me, I have an ulcer since past 3 years. I said, what you are wearing? This is what was given to him. There is a big hole. He said, who told you this? No, sir, hangadu idre gayam aitadu anta helyaru. No, this is not the practice. You should never do such kind of things. Most important thing is canvas shoes. Never look at those canvas shoes. Open up the insole, you see there is a very hard surface which is hitting on the plantar aspect. Check all these kind of soft top shoes which most of the patients are using. This is how I work in my center where 80% of my patients are poor. So I am a cobbler there. As a surgeon, I have to be cobbler, and I want physicians to work in this line. When this patient came to me with this ulcer, and I just asked him to get the footwear, I could see rest all area was normal. It was only the first MTPG area which was thinned out to 3 mm. Then he said, sir, I can't afford anything. I have already spent enough. Then I said, okay, I just bought that insole, which is costing 800 rupees. I just cut 1 by 1 inch and placed it. See the healing. He paid me 10 rupees for that. It has done the job. This is how you need to reach to the poor. You have to reach to the poor. You can't say that he requires 800 rupees a new silicone insole. Why? There is no pressure anywhere else other than in that point. So why are you recommending that? He can't afford it. You can do this. It can definitely solve the issue. Increase the benefit, reduce the cost. That should be the motto of every physician and every doctor. Footwear to heal, as all of you know, forefoot, anterior wedge, midfoot rocker, and hindfoot posterior wedge. It heals well. And this is what exercise, which I have specially brought this slide, recommended exercise as per the guidelines of 2022. There are so many things written in KRSSDI guidelines, but please define low risk, medium risk, high risk, and accordingly think what should be the number of steps per day. Foot, if it is operated, if he has an ulcer, please don't advise any exercise. Keep that infrared thermometer always in your clinic and check the temperature of the foot. If it is increased, tell him not to walk. Take rest. You can prevent the ulceration. All these foots, never ever recommend them any exercise. They require only static cycle or swimming if the wound heals. This is what guidelines has told you. I want you physicians to practice. An ulcer can heal with a proper plaster techniques, and I am going to demonstrate. I have not done any surgery. Everything has been healed, and I am going to demonstrate hands-on training. I am going to give you that you should start putting TCC. Need not be up to knee. You can have above ankle. Enough. I am showing you all those above ankle now. This is a non-plantar ulcer which has healed in 100 days, which was with PTV. Second, forefoot ulcer. We have done this in 100 days with simple above ankle TCC with a removable. We have made 2 casts. And then we have given him a footwear. He is absolutely fine. Midfoot ulcer, healed in 100 days with the same just above ankle TCC and removable it is. He can have a daily wash, bath, everything, and again put it back. Hindfoot ulcers, everything has healed in 100 days. Same TCC. This has to be practiced. There is no surgery done over here. There is just offloading done. And the most important thing, this has been recommended by Pawan and entire team, forefoot offloading and hindfoot offloading. when it should not be given to the patient? Please tell, anybody, when it should not be given. Pavan, when it should not be given. Those patients who don't have proximal neuropathy, they have a proximal neuropathy, never prescribe them this. Distal neuropathy, prescribe them. If they are having proximal neuropathy, never ever prescribe. They have come back with fracture neck femur. All of them have come back with fracture. But the recommendations say you have to go for this. The recommendation have to be followed definitely for the distal neuropathy, not for the proximal neuropathy. Remember these things. These are the challenges where most of the patients. What is the new prescription you are going to write in next 10 years? Number of steps per day, not tablets or injections. You are going to recommend every patient number of steps per day because they are going to be highly sick. What antibiotic? Everyone is interested in antibiotic. If there is no clinical sign of infection around the ulcer, no antibiotic. No infection, no culture, no antibiotic. I have been seeing maximum MDR in last 10 years because you have been shooting antibiotics to every ulcer. Wrong. What antibiotic has to be given? You have to plan for acute. If it is neuropathic, always gram positive. If it is neuroischemic, always gram negative. Ischemic, always gram negative antibiotics. If it is a chronic, let it be anything, it is going to be gram negative always. What is the new challenge? ಎಷ್ಟು ದಿನ ಒಂದೇ ಕಾಲ್ ನೋಡ್ತಿದ್ರಿ. You will be seeing both like. Already it has started in my clinic in last 10 years. I will show you that. This is going to be a greatest challenge. What offloading you are going to do? What you are going to plan with this patient? What quality life he is going to lead? This number is going to increase in next 10 years. Take home message, there is no cure. It's a temporary arrest. Ulcer-free days are your indicators of outcome. This is what is happening in my clinic. These two fellows are sitting with bilateral limb problems and we are working on that. So we need a DF hotline. Please get connected. Please work on saving especially rural foot. Very, very important. The way I have been seeing their sufferings, they have lost their entire family, all earnings, they have sold their fields, but outcome is they have lost both their legs. So we need to reach to the poor and we should see that whatever the mission we have started now, I wanted it should start from Karnataka chapter and I am looking forward. I think my good friend from Tamil Nadu is here. So I have requested him to pass on this message to the Central Governing Council that we should pass on our all care to the rural segment of India. Thank you. Thank you so much.
Thank you, sir. Absolutely brilliant. Yes, I do agree that we have to start educating patients. We have to at least tell them where to go for taking care of their feet. Yes, education is important, but accessibility is equally important. If you don't know, ask. If you don't know, if the patients don't know, tell them where they can go, what can be done. There are quite a few institutes now which are taking care of them, one of them being ours, Karnataka Institute of Endocrinology and Research. We have a very good department of podiatry. There are also private setups which are doing the needful, but as sir said, the importance of giving proper care at a subsidized cost to make sure that the patient is able to take care for those 100 days, which is very important, which is the golden period to heal that wound for that patient. Thank you, sir. Thank you once again. So we will now, yes, sir. So we'll be shifting to the hands-on workshop. I once again would like to introduce Ms. Sujata, who has been kind enough to come from a different city for Dr. Sunil to demonstrate certain things on her. Over to you, sir. Both will work together.
ಎಲ್ಲಿದೆಯಮ್ಮ ನಿಮಗೆ ಇಲ್ಲಲ್ಲ ಓಕೆ ಫೈನ್ ಯಾ ನೋ ನೋ ಐ just see if you are having this with you, this is a nail clipper and I think he is going to focus on this area for the callus. What normally you used to do it with the blade, you are not ready to accept it because you don't want to go with that sharpness. Sometimes you go deep, though you want to make minimum damage in that area. Trimming is the procedure what we do it, but with this we could see that if you imagine this is a foot and there is a callus somewhere, just keep it parallel, abutting to that entire callus, and initially just create a few clicks on that so that it raises up. It's a very simple technique. Keep abutting to the entire plantar skin around the callus and keep on giving approximate the edges so that the callus raises up, and then keep on shaving the callus with this. There will be no blood, nothing will be there. I will show you this. Can I have one chair so that I can be comfortable? Dealing, oh, that will be too high. One sec. Okay, chalo. No, that is okay. Can you focus here? ಇದನ್ನು ನೇಲ್ ನೀವು ಇದು ಕಂಫರ್ಟಬಲ್ ಯಾ ಎಕ್ಸಲೆಂಟ್ Pawan, she is your patient? Yep. Why she is with such a nail?
She had not come for a long time. That's why we called her here.
Can you focus it? Yeah. It's there? Yeah. See, I think we are not happy with the nails also. Yeah. I am just abutting to the callus. Okay? So once you abut to the callus, try to approximate the edges. Don't cut it, just approximate so that the callus gets prominent. Once the callus gets prominent, you can just trim it off. I have done it. There is no bleeding, nothing. This you can do it. Don't go with the blade. This is available. This trimming will prevent first ulcer to 80% of the patients. Let it be on this area. Even she has got callosity on this area, lateral border of the great toe. Similarly, you can place initially parallel abutting to the plantar skin and just approximate, feel for it, how far you can raise it up, and then ನೋಯಿದ್ರೇಳಿ ನೋಯಿದೇನಮ್ಮ ಇಲ್ಲಲ್ಲ ಓಕೆ ನೋಡಿ okay, we have done this. Now the most important, you have got a file. Nail filer is there, you just file it. Whatever once you have done the procedure, that takes out periphery, whatever the callus is there, it will just take it off. So this I think every physician can do it. You can get away with this blade, BP handle and all that. But this can definitely help you, and you have got a lot of confidence. I think the way once you start doing it, initially you are trying to hold it, don't cut it immediately, try to raise it up by approximating the things, and then just shave it off at the top of the head. 80% of the job is done. And now, the most important is nail. I don't know. She hasn't ಹೋಗಿದ್ದಿಲ್ವಾ ನೀವು ಫಾಲೋಅಪ್ಗೆ ಡಾಕ್ಟರ್ ಕಡೆ ಹೋಗ್ತಾ ಇದ್ದೀರಾ I don't accept such nails. Okay. When you want to go for a nail cutting, go in the center. This is what is my practice. You know, I just cut this nail in the center first. The center, one click, it cuts away. The entire thing comes out. Then you just go at the edge, take out the one piece, from this edge another piece. I think that solves then. Where is that? Okay. The file is enough. So in the kit, I have given everyone file. Nail filer is there in the kit. So I want you to see that every patient, she need not go for nail cutting. She can use the file once she go after bath. It is wet and it falls down as a powder. So it's very easy for you to work on this area. If there is an ulcer here or an ulcer here, as I showed you, as a physician, they can always plan for just above ankle TCC. Above ankle TCC, once you lay it, you can cut it off and make it 2 holes. Every day you dressing, again you close it. So I think we are already late. I think I'll demonstrate TCC some other time. Anytime we'll have one more session only for TCC. I want every physician to practice this TCC. This TCC was earlier planned up to knee high, which is not required now as per the guidelines. Even if you plan just above the ankle, that heals the wound, and we can work on that. So I have shown you the evidences: forefoot, midfoot, and hindfoot. Everything heals within 100 days. And put that whatever the cast, removable cast you have designed into the footwear, accommodative footwear. So he moves with that. Patient is ambulatory, and that is how it should go. Any questions?
Any questions? Any questions? We are sorry if we have overshot. The idea was to talk about basics and to show you some basic techniques. Sorry that we have not been able to show you a TCC application. That's one of the major things. But we would love to show you sometime around. We can work on that. But as we are running short of time now, we will give the stage over to Dr. Manohar.
Truly an absorbing session. A good round of applause for all the participants. And I must apologize for giving them only 1 hour.
Thank you.
I'm sorry for that, sir. Next time definitely we'll accommodate more time for our benefit. Thank you so much. I think we'll move on to the next presentation. Dr. Shanmugavelu is there. Yeah. So we had to make some modifications in the like how we make modifications in the treatment, patient-centric, like faculty-centric sometimes. When we have so many faculties, it is to be done. So instead of my talk, Dr. Shanmugavelu will speak on achieving glycemic symmetry with newer basal insulin. I request Dr. Amal Selvam, my friend, to chair. He's a physician from Bangalore, and Dr. Vijay, you can chair the session. Over to Dr. Shanmugavelu. It doesn't need any introduction. Considered a very, very busy man, but academically very active. We have been working together during the COVID times also with some studies. And he's a central RSSDI member. Over to you, sir, for the topic.
Respected chairpersons, senior doctors, my doctor friends, I feel extremely happy, honored, and most privileged to have been invited to make a presentation on achieving glycemic symmetry with the newer basal insulin analogs, with a particular focus on evidence-based findings. And of course, I thank Dr. Manohar, Dr. Vijay Kumar, and Dr. Suman for their kind invitation. Also thank Novo Nordisk for sponsoring this particular program. This is an industry-supported symposium. My disclosures, of course, I have no conflict of interest. In relation to my presentation, what I'm going to do for another 17 minutes, achieving glycemic symmetry with newer basal insulin analog. So type 2 diabetes is a multi-causal, heterogeneous, progressive cardiorenal metabolic condition. The progressive nature is one of the major challenges. So getting the patients to goal become challenging as the disease advances. Multiple intervention will need to be used. The relentless progressive nature of type 2 diabetes results in an almost inevitable need for insulin supplementation as well as insulin intensification. Several trials have clearly shown the benefit of early intensive glycemic control with reference to diabetes-related complications. Intensive glycemic control has been associated with increased risk of hyperglycemia. Therefore, achieving proper glycemic control, at the same time preventing the risk of hyperglycemia, are regarded as a major measure for managing patient with the type 2 diabetes. So achieving glycemic symmetry, financial disclosures. Let us take a case study. So 45-year-old male, engineer by occupation. He presented to the OPD with a family history of diabetes and a medical history of taking or receiving treatment for diabetes, hypertension, dyslipidemia. He presented with very high fasting, postprandial plasma glucose, lipid levels, as well as A1C level. So if you look into this particular treatment history, that is, patient has been on antihypertensive therapy, statins, as well as cardiac drugs were also prescribed in combination with oral antidiabetic drugs. However, his blood sugar remains uncontrolled. He has been currently on metformin 2 gram, glimepiride 2 milligram BID, MPOC 25 milligram once daily. The primary challenges identified: uncontrolled hyperglycemia, number 1. Subject has a hectic work life and fears insulin initiation will affect work life due to hyperglycemic risk. So the risk of hyperglycemia. Uncontrolled hyperglycemia, number 2. So travels often and unsure about taking insulin on fixed time daily. So we need to have a formulation which can allow for flexibility with reference to timing of insulin administration. It is very difficult to take insulin at a particular time every day, same time every day. So what next in this patient? ADA 2022 recommends basal insulin at initiation. If already on GLP-1 receptor analog or GLP-1 receptor analog not appropriate or insulin preferred, and if A1C is not on target, add basal insulin. That is the recommendation of ADA. So factors to be considered before prescribing a basal insulin. So basal insulin, there are certain requirements for an ideal basal insulin. It should be efficacious, number 1, and should be associated with low glycemic variability. So the risk of hypoglycemia will also come down. And next thing is it should be available in a simpler delivery device, which is to be user-friendly, so it is acceptable by the patient. It will improve the adherence, compliance, as well as quality of life. Significant A1C reduction across clinical trials. So if you look into basal insulin analog, IDAG, insulin degludec, it is an ultra-fast, long-acting basal insulin analog. And if you look into the RCTs, as well as real-world evidence, therapy has been associated with significant reduction with reference to A1C level. So it is found to be effective with reference to A1C reduction. So initiating insulin therapy with IDAG in Asian patient with the type 2 diabetes inadequately controlled on OAD provides similar improvements in long-term glycemic control compared to other basal insulins like IGLAD, that is insulin glargine 100 IU as well as 300 IU, but at a significantly lower rate of overall confirmed hypoglycemic. So therapy has been associated with similar A1C reduction, but with reduced risk of hypoglycemia. That is very important, which in turn will improve the quality of life as well as patient adherence. And very important thing is it also minimizes the cost, resource utilization, and so on. Once stable glycemic control in insulin dosings are achieved. So factors to be considered: number 1, efficacy, right? So consistently proven hypoglycemic benefit. Next is with reference to hypoglycemia. Hypoglycemia has been considered as a major barrier for initiating insulin therapy, major barrier for implementing intensive therapy, and one episode of hypoglycemia is associated with fear, anxiety. This may have a negative impact on quality of life, as well as this will definitely lead to discontinuation of the therapy. And very important thing is likely to increase the risk of diabetes-related complications. So if you look into the RCTs begin, switch 1 and 2, patients with type 1 as well as type 2, and devote. That is, this particular study was conducted in patients with the type 2 diabetes with multiple risk factors for atherosclerotic cardiovascular disease, as well as patients with the type 2 diabetes and atherosclerotic cardiovascular disease. Compared to IGLAD, IDAG established similar glycemic improvement, number 1, and non-inferior with reference to the reduction in the risk for cardiovascular endpoints. Next is you treat type 2 diabetic patient. That is the real world evidence. All these trials clearly shown that therapy has been associated with low rate of hypoglycemia. So degludec achieving target study. So this particular slide clearly shows patient with the type 2 diabetes on insulin glargine 100 IU as well as IDAG. The same study was also conducted in patient with the type 1 also. This particular slide clearly shows the association between glycemic control, So kindly focus your attention on x-axis, which shows A1C. Next is y-axis shows with reference to hypo events per 100 patient per patient year of exposure. So if you look into the association between glycemic control and the risk of hypoglycemia, patients treated with IGLAR, the curve shows more or less a concave. On the other hand, the curve in patients treated with IDEG, it assumes a convex. So there is a difference with reference to the risk of hypoglycemia as well as the achieving optimal levels of glycemic control. So one can achieve lower glycemic targets with the degludec versus glorgine U100 before incurring an equivalent risk of hypoglycemia. Right. Next is DEVOTE, major adverse cardiovascular events in patients with a very high risk for severe hypoglycemia. So this particular trial conducted in patients with the type 2 diabetes with established cardiovascular disease or patient with the type 2 diabetes with multiple risk factors, both IGLAR as well as IDEG achieve similar glycemic control, but with reduced risk of hypoglycemia, and both the drugs demonstrated non-inferiority with reference to MACE. Next is conclude study, RCT in insulin experienced participants, and kindly look into the hypoglycemic risk. So insulin degludec has shown a lower risk of hypoglycemia compared to glorgine U300. So glorgine 300IU and insulin degludec both belong to second generation of long-acting insulin analog, and to achieve steady state, it takes minimum of 2 to 3 days. Once a steady state is reached, the plasma insulin concentration of insulin remains relatively stable, flat, so the risk of hypoglycemia is very less, and which gets translated into pharmacodynamic property, namely it minimizes the excessive glycemic excretion. That is the main reason behind reduced risk of hypoglycemia when you use both the second generation insulin analog. Next is confirmed study, data from real world. That is insulin degludec has shown a significantly low risk of hypoglycemia versus glorgine U300 in evidence from real world practice. So patients with the type 2 diabetes, insulin naive, inadequately controlled on OAD, when given insulin degludec as well as glorgine 300IU, you can see the change in the rate of hypoglycemia demonstrated 30% lower rate of hypo with degludec, number one. Change in the proportion of patients experiencing more than one episode of hypo was significantly lower with degludec compared to glorgine 300IU. So these results may suggest that there are potential economic benefits by reducing the risk of hypoglycemia. We can reduce the resource utilization, emergency hospital visits, and next important thing is it will have a negative impact on the socio-economic burden, socio-economic status also. So economic benefits with the use of degludec versus glorgine U300IU. Next is glycemic variability. Degludec, it offers lower within day variability versus glorgine U100IU. And if you look into the panel on the right side and panel on the left side, panel on the right side shows a consistent glucose lowering effect over a period of 24 hours. In contrast, patients treated with glorgine, you can see the inconsistency with reference to glucose lowering effect. Thereby, it suggests lower within day variability with reference to degludec. This gets translated into low risk of hypoglycemia. That is very important. And this improves the predictability. So treating physician will feel confidence of putting the patient on particular dose because the fluctuations with reference to glucose levels are very minimal. Next is degludec, lower within day variability versus glorgine 300IU. So even within the second generation basal insulin analog, IDEG offers lower within day variability. So again, this particular panel on the right side clearly shows consistent glucose lowering effect. In contrast, patients treated with glorgine 300IU, you can see a U-shaped curve, that is maximum effects are seen in the early 6 hours and the late 6 hours with a dip in the middle. Next is degludec offers 4 times lower glycemic variability compared to insulin glorgine U100 and U300IU. So patients treated with IDEG showed in the blue color, and patients treated with iGlar 100 and 300 in other color. You can see the consistent glucose lowering effect that is maintained in patients treated with IDEG compared to patients treated with Glargine 300 as well as Glargine 100 IU. And this particular study, time in range with IDEG and iGlar 100 IU, IDEG showed superiority in terms of improving the time in range by 20.6 minutes in contrast to patient treated with iGlar. Not only that, it also reduced the time below range by nearly 12.7 minutes in contrast to patient treated with iGlar. So it reduces the time below range, thereby the risk of hypoglycemia. It improves the time in range, thereby it helps to achieve the targeted A1C level. In range, it is yet another study. You can see the inclusion criteria. A large-scale prospective multi-center continuous glucose monitoring based RCT. You can see the treatment period, starting from the screening period, run-in period, and patients were randomized to receive Glargine 300 IU as well as IDEG. Right? You can see the continuous glucose monitoring, that is parameters. Different parameters have been assessed. So patients treated with iGlar, patients treated with insulin degludec, with reference to time in range, with reference to A1C, time above range, greater than 180 milligram, less than 250 milligram, that is level 1, time above range. It appears there is a difference numerically, but not statistically significant. So overall, degludec compared to Glargine 100 IU, 300 IU, it improves time in range by 48.24 minutes and time above range by reduction in the time above range by 44.94 minutes and A1C improvement. Next is simplicity. So simple initiation and titration of degludec in patient with the type 2. Start in insulin naive patients administered alone or in combination with OAD, GLP-1 analog or bolus insulin. Recommended daily starting insulin doses 10 units. You can uptitrate depending upon the fasting plasma glucose and measure 3 days fasting plasma glucose. Average of the 3 or the lowest of the 3 can be taken for uptitration, and titration adjusts dose once weekly based on the mean of 2 SMBG results. So switch from other basal insulin. When you have plans to switch from other basal insulins or other premix insulins, can we replace it with IDEG? Yes, of course. So unit to unit switch or 20% dose reduction to be considered when switching from a BID insulin. If a patient is already receiving once daily, either a premix insulin or once daily basal insulin, you can change the same unit dose. If the patient is receiving twice daily, you can reduce the total reduction dose by 20%. So flexible dose. So it is very difficult to stick on to the same time every day for taking insulin administration. There are occasions wherein this particular time of taking insulin may not be possible. So IDEG offers flexibility with reference to timing of insulin administration. So this particular study clearly shown that without compromising efficacy and safety, it has established improvement in glycemic control as well as the risk of hypoglycemia. And minimum of 8 hours between dosing is mandatory while giving the dosing of insulin degludec. So better adherence with degludec, this particular confirmed study, you see the Kaplan-Meier curve. The curve starts separating much earlier. So 27% lower risk of treatment discontinuation were demonstrated with degludec versus Glargine. So Glargine 300 IU and degludec achieved similar A1C reduction. And the risk of hypoglycemia, no difference at all statistically, but numerically different. But the rate of discontinuation was very high in patients treated with 300 IU Glargine compared to patients treated with IDEG. So likelihood of discontinuation of basal insulin in patient with initiated treatment with the degludec or Glargine 300. So lower dose and lesser SMBG monitoring. So lower dose, that is 10% lower dose with the degludec compared to Glargine 100 IU and 23% lower dose with the degludec versus Glargine 300 IU. And 2 strips less per week with the degludec with reference to monitoring. So this will definitely improve cost saving. So ultra long acting insulin analog, which can reduce the risk of hypoglycemia and other sources may improve the economic status of the individual, and it is cost effective. So progression to good glycemic control in this patient, insulin dose, and you can see the baseline 1 month and 3 months, and the A1C, and with reference to body weight. So patient uncontrolled on multiple OADs, initiating and optimizing insulin deglect. So we have the oral medications and initiation, IDEC 10 units with the dinner, titrated over 12 weeks, and results, end of 12 weeks, fasting came down, post-breakfast improved, A1C decreased from 8.8 to 7.4, and no episode of hypoglycemia. Thank you very much for your kind listening.
Thank you for a timely finishing the session. So it was a wonderful presentation on the basal insulin. One question I had, one patient, if there is any special situation where or something, where the patient is on degludec and there is severe hypoglycemia, will there be a prolonged hypoglycemia that is going to be there, or that may lead to a higher, prolonged hospitalization, more cost involved?
That is, you want to say whether the hypoglycemia
patient is having some illness where there is total intake, food intake is less, and the patient is on degludec. Patient undergoes hypoglycemia.
It is a long-acting insulin.
Yes, sir.
The hypoglycemia will be also long-acting. That's what you want.
And no, the thing is, we normally put the patient on IV glucose, and we continuously monitor the patient, and we try to keep the glucose level between 90 to 140 maximum, and we stop it giving intravenous, and we monitor the patient every hourly or every half an hourly depending upon the risk involved.
Yeah, my question was compared to other basal insulin.
No, we have not come across.
Will
We have
this
not come across.
stay for a longer duration in the body?
We have not come across. I think Prasanna Kumar sir, he can highlight on this.
Thank you. Any more questions from the audience?
Your question is very valid. When you give glibenclamide versus glipizide, what would be the long-acting hypoglycemic effect? It is true there, because it's an insulin secretor. But with IDEC, there is what is called as, after 4 days, what goes in, what comes out. Steady state metabolism occurs with IDEC. And TIR, TBR, time below range, improves very significantly. That means chances of hypoglycemia come down even though you are given insulin. Why? The dose will be much lower, 40% less than other long-acting insulin. So you need not worry that much.
Yes, thank you, sir. Thank you for the answer. Any more questions from the audience? Yeah. I think no more questions. We'll move on to the next session.
Thank you,
Dr.
Sharma.
Sharma, for your wonderful.
So we'll move on to the next session now. A new chapter for improved cardiorenal outcomes in diabetes with CKD. I would like to invite the chairperson, Dr. Sudhindra. Dr. Amal can stay back as the chairperson. And the speaker is Dr. Rajanna Sridhar. Next up. Let's introduce the speaker.
So I welcome Dr. Rajanna Sridhar. So his education qualification is MBBS from Mysore Medical College, Internal Medicine from USA and Nephrology from USA. I welcome Doctor to give his talk.
Good afternoon. Thank you to the organizing committee of RSSDI and my dear friends. I just wanted to give a brief overview of about this new molecule, which is likely to, or which has been shown to be significantly effective in preventing cardio-renal episodes in patients with diabetes type 2 and CKD. So we know that CKD is progression of CKD is driven by hemodynamic factors, metabolic factors, and inflammation and fibrosis. And this leads to tubulointerstitial damage and fibrosis, glomerulosclerosis, mesangial expansion, so on and so forth. All these processes lead to the progression of chronic kidney disease. Now, until now, we have been focusing on controlling the hemodynamic factors with ACE inhibitors and ARBs, and more recently with SGLT2 inhibitors, and metabolic factors such as the glycemic control. You are experts in that. I don't have to say anything about that. However, still now, there have been no treatments available targeting inflammation and fibrosis. So, the triad of hemodynamic factors, metabolic factors, and inflammation and fibrosis, we have been focusing on two factors, two drivers of CKD progression, not the third driver. And that is where mineralocorticoid receptor antagonism comes into play. That is, MRAs for heart and kidney protection. That is the title or the focus of my presentation today. Now, mineralocorticoid receptors belong to the superfamily of nuclear hormone receptors and are expressed in hearts, kidneys, vasculature, brain, gut, and myeloid cells. They are activated by ligands such as aldosterone and cortisol, and non-ligands such as RAC1, oxidative stress, etc. Now, we all know that the MR expression controls fluid and electrolyte and hemodynamic homeostasis. However, more recently, the role of mineralocorticoid receptor in inflammation and fibrosis has been better understood since the cloning of the gene in 1987. So now, kidney and heart diseases, that is CKD and coronary artery disease or ischemic heart disease, and diabetes are associated with MR overactivation through multiple mechanisms, including activation by ligands such as aldosterone and cortisol, and non-ligands like RAC1, oxidative stress, etc. that I just mentioned. And in addition, there is also increased MR expression. So by various mechanisms, there has been increased activity of the mineralocorticoid receptor, and since we understood that it is involved in inflammation and fibrosis, so this potentially plays a huge role in the progression of kidney disease and heart disease. So this is the history of the mineralocorticoids in health and disease. 1938, the cholinergic and sodium retaining effect of DOCA was established. In 1960, FDA approved spironolactone. So it took 4 decades, that is 1999, Rawls study to establish spironolactone as a life-saving drug in patients with heart failure. And subsequently, the emphasis trial in 2011 established eplerenone also as a life-saving drug in heart failure patients with reduced ejection fraction. Now, in kidney also, MRAs have been shown to decrease proteinuria in patients with CKD. However, the problem with MRAs has been the risk of hyperkalemia when used in patients with CKD. So, although spironolactone and eplerenone decrease cardiovascular morbidity and mortality in patients with CHF and reduced ejection fraction, and subsequently in the TopCat study even with preserved ejection fraction, and spironolactone has been shown to improve endothelial dysfunction and increase nitric oxide bioavailability, the problem has been that in patients with CKD and type 2 diabetes, MRAs have not been used in a significant proportion because of the risk of hyperkalemia and anti-androgenic adverse effects such as gynecomastia and increase in cortisol and HbA1c levels. So therefore, although we know it is effective, or rather it is involved in the progression of kidney disease and heart disease, we have not been able to use the molecule because of its adverse events. So there enters finerenone. Finerenone is a novel, non-steroidal, highly selective mineralocorticoid receptor antagonist. Novel, I say, because this molecule was taken out by going through more than a lakh chemicals and subsequently refined to make it available or used in the human, in man. And it is non-steroidal, therefore the side effects, anti-androgenic side effects are going to be absent. And it is highly selective because of its unique structure, and it is an antagonist which is a bulky molecule with a short half-life. Therefore the hyperkalemia effect is minimized because of its short duration of action. It has a unique structure that results in selective and potent interaction with the mineralocorticoid receptor and the regulation of its gene expression. And more importantly, its anti-fibrotic and anti-inflammatory effects have been well established in animal models of heart disease and kidney disease. So it meets all the criteria to be a very useful drug in disease. So in phase 2 studies of this molecule finerenone, in patients with chronic heart failure and mild to moderate kidney disease, finerenone, or it was called as BAY948862 at that time, was at least as effective as spironolactone in decreasing biomarkers of hemodynamic stress in patients with heart failure and CKD. But more importantly, there was a lower incidence of adverse events of hyperkalemia and worsening renal function that was seen with spironolactone. In another phase 2 study, remember these are phase 2 studies with 823 patients. It's a very, very large phase 2 study. Patients with CKD, albuminuria, type 2 diabetes, there was a dose-dependent reduction in proteinuria, and these patients were already on ACE inhibitors. So on top of ACE inhibitors in this phase 2 study, finerenone caused a significant dose-dependent reduction in proteinuria. Now, because of this impressive phase 2 trial data, large phase 3 programs were undertaken. And there were 2 studies mainly, Fidelio DKD and Figaro DKD. These were complementary studies in that they had similar design with minor changes in the inclusion criteria. And because of similar design, they actually were able to do a patient-specific pooled analysis of these 2 trials. Now, the Fidelio DKD, the primary endpoint was a kidney composite endpoint of less than or greater than 40% decline in GFR, kidney failure, or renal death. And in the Figaro DKD, the primary composite endpoint was a cardiac endpoint. And the secondary endpoints for these studies were converse. In Fidelio DKD, cardiac endpoint was secondary, and in Figaro DKD, kidney endpoint was secondary. And there were other secondary endpoints such as all-cause mortality, hospitalization, change in urine albumin-creatinine ratio, and onset of kidney failure or 57% decline in GFR. This is a very kind of a minor point, minute point I would say. 57% decline in GFR equals doubling of creatinine. Most earlier studies took doubling of creatinine, dialysis, or transplantation as composite kidney endpoints. Therefore, this actually is a better endpoint, but 40% reduction was actually mandated by FDA, and therefore they took 40% as the primary endpoint. So there were other exploratory endpoints as well. So the design I told you was similar in both studies. It was a randomized, double-blind, event-driven. That means how many events occurred, then the study would be stopped. placebo-controlled phase 3 trials. 13,000, nearly 14,000 patients were run into the study. The most important thing is optimal ACE or ARB therapy was established. That means 99.8% of these patients were already on ACE inhibitor and ARBs, and that was optimized in the run-in period. Then subsequently, after a 2-week screening period, 5,734 patients were randomized in Fidelio DKD, either to finerenone 10 milligrams if the GFR was less than 60, or 20 milligrams if the GFR was more than 60, or placebo. And they were monitored every 4 months and until the number of events accumulated in the study. Now, this is the primary kidney specific endpoint of the Fidelio DKD study. On top of maximum tolerated RAS therapy, finerenone significantly decreased primary kidney outcome by 18% on top of RAS therapy. And I did not mention, for the lack of time, these patients had an HbA1c of 7.6% at inclusion and blood pressure of 136/82. That means extremely well controlled type 2 diabetic patients with CKD. On top of RAS therapy, there was additional decline in the kidney endpoint by an absolute risk reduction of 3.4%. That means the number needed to treat. I always tell the students, if there is one number you should take from a clinical trial, it is number needed to treat. It is nothing but 100 divided by absolute risk reduction. That means if you treated 29 patients for 3 years, you prevent one event, that is one kidney failure or a composite endpoint. So, by the way, 29 is a very good number. Okay. So, if you treated 29 patients for 3 years with finerenone, you prevented one patient having this endpoint. So, and also I would like to point out that for the first 12 months, there was really no change in this outcome. Only after 12 months, the lines started to separate. And also, you might say, at the end, they kind of came close together, but that is really irrelevant because the numbers followed at 48 months was really very small. So, it's not an important finding at all. Now, the secondary endpoint of cardiovascular outcome in Fidelio DKD study also was significantly decreased by 14%, and here the number needed to treat was 42. Now, the secondary endpoint of urine albumin creatinine ratio decreased by 31% at 4 months compared to placebo. So, in patients with maximally tolerated RAS therapy, there was a further decline in proteinuria when finerenone was given. I told you that MRAs are not used in patients with CKD because of the risk of hyperkalemia. If you look at AMBER CKD study, which included patients between GFR of 25 and 45, and they were given ACE-ARB plus spironolactone, 23% of patients had hyperkalemia. In the Fidelio DKD study, 2.3% had hyperkalemia. I must say that Fidelio DKD included patients between GFR of 25 to 75. So it is not apples to apple comparison, but still there was a significantly less number of patients with hyperkalemia when finerenone was used. Now, Figaro DKD, I told you here the cardiac endpoint was the primary endpoint and kidney was the secondary endpoint. So what did we find here? Again, there was a significant reduction of 13% cardiac outcome on top of maximal RAS blockade, and number needed to treat is 47. You might say, oh, this is not so good as Fidelio DKD, but please remember, Figaro DKD inclusion criteria included patients between GFR of 25 to 90. That means these were less sicker patients in the kidney, from the kidney perspective. So therefore, 47 is also a very good number. So in Figaro DKD, the primary endpoint was decreased by 13%. Secondary endpoint was decreased by about 13% when the GFR was 40% decline, and 23% when the GFR decline was 57%. That is, doubling of creatinine again decreased by 23% in this study. So I just want to put this in perspective. Renal study, losartan was good, 1,500 patients, phase 3 study. IDNT 1700, Credence 4400, EMPA 6600. But Fidelio and Figaro together had 13,000 patients, largest CKD trial to date with any drug. So when this 13,000 patients were analyzed in the patient level pooled analysis, there was 14% reduction in the cardiovascular morbidity and mortality, 23% reduction in kidney mortality or kidney disease progression. So therefore, without doubt, one can say that finerenone is an effective treatment option for cardiovascular and kidney protection in patients with CKD and type 2 diabetes. So based on these phenomenal data, all organizations, professional organizations in the world have now recommended finerenone. This is the latest guideline from KDIGO. SGLT2 inhibitor obviously is a first-line therapy in patients with diabetes, GLP-1 RAs for additional glycemic control, and finerenone if the patient still had residual proteinuria. It is not just KDIGO, American Heart Association, American Diabetic Association, AACE, so on and so forth. Everybody has given a level A recommendation for the use of finerenone in patients with type 2 diabetes and CKD. And there are additional studies that are ongoing when in patients with heart failure or non-diabetic CKD, whether it is going to be useful, or in combination with empagliflozin in confidence trial, or in patients with kidney disease, children with kidney disease. Therefore, a lot of indications are going to be whether it is useful or not will be known in the very near future. But to date, type 2 diabetes with CKD, finerenone is definitely a drug that is going to decrease cardiac outcomes and kidney outcomes. So it was approved by DCGI in 2022 April, and it has been available in India since August of this year. So the take-home message from my brief presentation is that finerenone, a non-steroidal MRA, further improves cardiovascular morbidity and kidney outcomes in patients on top of standard therapy in patients with type 2 diabetes and CKD. You must consider finerenone if there is residual albuminuria and normal serum potassium on patients who are already receiving first-line therapies, and renoprotective effects. I did not provide the data, but I think I would like to emphasize that the renoprotective effects of SGLT2 inhibitors and finerenone are complementary, independent, additive, and makes the treatment combination more tolerable. So with this, I'm going to end my presentation. If there are any questions, I would like to answer.
So that was a wonderful talk, sir. So my first question is, do you experience any hypotension with finerenone?
No. The decrease in blood pressure with finerenone is very minimal, 2 millimeters on average in these studies. So you do not get hypotension.
Okay. And we physicians, normally we see our diabetic patients with stage 1, stage 2 of CKD. Which stage we are supposed to use this?
Like I said, in the studies, the inclusion criteria included, microalbuminuria, or rather, moderately increased albuminuria or severely, that is 30 or greater, GFR of 25 to 90. That means basically everybody. If the patient has microalbuminuria, you can use finerenone, provided you're already using ACE or ARB and their potassium is normal. And on top of that, of course, SGLT2 inhibitor is also indicated. On top of that, if there is residual albuminuria, you should add finerenone. I would say the way the CKD is driven by fibrosis, in most CKD there is fibrosis. So I would guess that earlier the better. Yeah.
Any questions?
These patients are already on ACE.
Yes.
On top of that, you are adding this.
Yes.
Can it not worsen hypertension?
No, not at all, sir. That is why this large 13,000 patient studies did not reveal significant hyperkalemia at all. In fact, there were 0 deaths among 13,000 patients due to hyperkalemia. So hyperkalemia is a significantly less problem with this molecule compared to spironolactone or eplerenone. It is believed to be due to the short-acting nature of the drug. The hyperkalemia is a cumulative effect. Remember, potassium is excreted continuously, and spironolactone or eplerenone, by by the longer half-life, the reaccumulation of potassium or reabsorption of potassium is going to be high, and with this molecule we don't see that.
Is it not necessary to monitor potassium in these people then?
Yes, like I said, initial potassium should be normal, that is less than 5. 1 month later, you should monitor potassium. If the potassium is less than 5, you can increase the dose from 10 to 20 milligram if you have started at 10. If the potassium is increased, let us say if the potassium went up to 5.6, then you can actually, normally we see potassium 5.6, we don't even get concerned. But if the potassium is high, you can decrease the dose. More importantly, in these studies, the patients were not advised potassium restriction at all. And most of our patients, we advise potassium restriction. So you can take other measures to keep the potassium low, such as low potassium diet, and restart the finerenone molecule at a lower dose, maybe alternate days. And if the potassium is well maintained, you can continue the treatment. So 1 month after starting the drug, you should monitor the potassium.
Low dose means 10 milligrams.
10 milligrams and 20 milligrams are the only 2 formulations currently available. So if the potassium, let's say if the potassium is 5.8, obviously you should withhold the drug, put the patient on a low potassium diet, maybe repeat the potassium after a couple of, again, see, this is not because the involvement is fibrosis, it is not an emergency thing. If you withhold for 1 month, nothing probably is likely to happen. Yeah. Any other questions? Thank you.
Thank you, sir, for a good presentation there. And now it's my privilege to move on to the next topic. My teacher, Dr. Prasanna Kumar KM, is the speaker, and the topic is on emerging therapies in the management of diabetes. To chair this session, my good friend and colleague, Dr. Pankaj Singhai, senior consultant from Manipal Hospital, and Dr. Neelkant Kote, to take the chair. Over to the chairpersons.
Hello, check. Good evening, one and all present here. It's my privilege to introduce the speaker for the day, Dr. K.M. Prasanna Kumar. He's an endocrinologist from the Center of Diabetes and Endocrine Care, Bengalore. He was a former senior professor and head of the department in the endocrinology at MS Ramaiah Medical College, Bangalore. He was also the past president of RSSDI. Between 2007 to 2009. He was a past president of Endocrine Society of India between 2008 to 2009. Past president Indian Thyroid Society between 2018 to 2020. During his tenure, he has handled various posts, including being the director of Primer, chairman of Changing Diabetes in Children, India, and he has got various publications, both national and international publications in the scientific journals, measuring up to 150, and he's up to so far he's presented about 20 orations at various conferences and seminars. Thank you. We welcome you, sir.
Thank you, chairpersons. Good evening, everybody, for the introduction. And at the end of the day, to have so many people is something rare. After this COVID situation, that speaks volumes of the organizing capacity. And I would like to thank Manohar and Dr. Shekhar, who is the patron of this KRSSDI. And I think now the revival has come, and more people have come, and it shows the good scientific progress. I'll restrict my talk to 17 minutes so that you have questions. Emerging therapies in management of diabetes. There are so many emerging therapies. I don't want to go into details of what is available 2022, what is likely to come 2023. I'm not talking of 2035. Some of us may not be here also. So let us talk about next 2 years. So these are the ones: imiglamine, which is a mitochondrial re-energizer, and lobeglitazone, PPAR alpha and gamma agonist available. And of course, semaglutide is already available oral. you are likely to see next year Wegovy, that is injectable semaglutide, so much so, people say don't take it without doctor's prescription. They are not able to supply that. Celebrities, everybody says, I lost so much of weight. Of course, tirzepatide, which is another molecule with a GLP-1 and GIP receptor analog, a great thing, you will see the data. And of course, Icodec, we heard about the Degludec, and Icodec is once a week injection. Everybody asks, should I take daily, why not week? This is 2022 ADA guidelines. Last week, Diabetes Care had 2023 guidelines. December end it has come, January issue. All these things show that when you choose a drug, whatever it is, that just like Dr. Reasarch said, that look at atherosclerotic as well as high risk for cardiac disease and renal disease, choose the drug. Then you choose drug which causes minimal hypoglycemia and also drugs which are cost. Today everything has become generic. The what is available except semaglutide has become affordable at all. Prioritize the use of organ protective medication. It's not that a drug reduces blood sugar. Does it protect kidney, heart? Now we are talking of liver also. So these are the mechanism, as all of you have seen, the octet, whether it is the pancreas, whether intestine, whether it is fat, kidney, muscle, brain and liver. And you have drugs because by the time you diagnose 70% or 50% of beta cells are already gone. And various mechanisms, I said not one, there are more than that, even 10 or 11 as such. As you can see, the pancreatic beta cells, whether beta cell function reduced, beta cell mass also reduced, then incretin effect, then alpha cell defect, then you see the adipose tissue, muscle, liver, brain, and also you have got on the colon, then you have got immune dysregulation. Just now you heard about CKD, how the inflammation, then decreasing amylin, as well as small intestinal absorption, and of course kidney SGLT2 inhibitor. I think in the next future we may have many more mechanisms. For every mechanism there will be a new drug that is available. What is imiglamine? What is so great about it? It's a first-in-class molecule of glimins recognized by WHO for type 2 diabetes. Research was started in 2007, got approval 2021, 14 years. It's not a chance one. Its method of action, which is mainly on impaired glucose uptake by muscle tissue, acts on the muscle, reduces the resistance, excessive hepatic glucose genesis reduced just like metformin, and also increase beta cell apoptosis. This is how. So it stops the apoptosis of the beta cell. This is how it works on these mechanisms, and it has been done in various trials, all put together 1,555 studies, and it's called as times 1, 2, and 3 phase 3 randomized clinical trials. This is what the imigline molecule, it just looks like a metformin. So molecule-wise metformin, certain actions are like metformin, but the mechanism of action is mainly on the mitochondria. That's why it is called mitochondria flexibility, mainly RAS production, apoptosis is reduced, ATP generation is increased, because of which the energy gradient across the membrane of the respiratory transport mechanism to mediate insulin secretion. It does not cause hypoglycemia like sulfonylurea because it is only dependent on the glucose. If the blood sugar is high, it works, otherwise it does not work. I don't want to go into all the details, for it is sufficient. What is the dose? It is available in 500 mg and 1000 mg. The dose is twice a day. You start with 500 mg twice a day, then you can go up to 1000 milligram twice a day, and it can be used as standalone or it can be addition to metformin. Of course, all over the world, every guideline says metformin is the first drug, ADA guidelines, WHO, everything, except the European Society of Cardiology said SGLT2 can be used ahead of the metformin. We don't agree because there are no diabetologists, they are all cardiologists. It's okay, it's all right. Whatever they can say, it is good enough. I and you have to treat that. It's the first-in-class unique action, improves C2 redox factor, modulates the blood glucose excursion, beta cell function, hepatic glucogenesis and uptake. And there are many, I don't want to go into detail. There are studies to show monotherapy. It reduces about 0.6 to 0.7 A1C reduction when added to metformin. So you can add to metformin, you can add to other drug, you can even add to insulin also. So all these cases are there. So if the patient does not tolerate metformin, you can start it, or after metformin you can use. And you can use with metformin, gliptin, then imiglamin, or metformin, gliptin, SGLT2, and then this, or metformin, insulin, all. Every data shows more than 3 drugs is useful, but everybody in this hall is using 5 drugs also, I know that. What you learn in dark, you don't practice in the light tomorrow morning, 10 o'clock in the morning. So talking is different thing, practice is different, because there are patients who say, doctor, one more drug, let me say, all right, take. To his good luck or your bad luck, he comes back, look, 6.8. You said after 3 drugs, no, now I am on 4 drugs. And has anybody started insulin without adding sulfonylurea? Because sulfonylurea is the most potent drug. So that's why, just like what is resistant hypertension, more than 3 drugs, one of them should be diuretic. Same thing applies to sulfonylurea. We have lobeglitazone. What is it? It's another glitazone, like Rosi and Pio. Then what is great about it? It's a novel glitazide where approved in Korea. The previous imiglamin also is not approved by FDA. That is approved in Japan, Korea, and India as such. And this is the structure. Only thing is, unlike the Pio and Rossi, lebeglitazone is a dual agonist against PPAR alpha as well as gamma. Everything else is just like that, except probably that lobeglitazone is less than 1% excreted in the kidney, and majority of them is through the liver. And the dose is smaller. It is 0.5 milligrams once a day. Whereas you see pioglitazone is 15 once a day, 30 once a day, not in India. Some countries they use 45. Of course, rosiglitazone is already gone. So it was not inferior to pioglitazone. So lebeglitazone, just like pioglitazone, 0.5 milligram, and it is safe, effective both alpha and gamma. Now the problem is obesity. As all of us know, 65% of the patients are obese. I want to have a study, India, Pakistan, Thailand, and other countries, and they said the BMI should be less than 25. Out of my 100 patients, I don't have 20 patients whose BMI is less than 25. I'm sure that is true in this hall also. So how do you expect our patients to be that? So that is why we want drugs which can reduce obesity, and this is what is etiropatide, which is a dual GLP-1 and GIP receptor agonist as such. And there are so many, surpass 1, 2, 3, 4, 5, 6 studies. 13,000 patients have been done, and the participant even starting at about 8% experience 2.5% reduction, which is great. But what is so great about it? Weight loss, 52 weeks, 10 kg. If we can lose 10 kg, everybody here, we will live another 5 to 8 years longer. Even with SGLT2 inhibitors, studies have shown 2 to 3 kg. But today somebody came and said, my wife, everybody is telling, you have lost too much of weight. How much? 8 kg. Why are you worried? Sir, if I lose weight, nobody is afraid. Why should anybody be afraid? What are you? Sir, I am Panchayati member. If I stand for election, nobody will be afraid. The problem today is your patients say, no, my wife is telling your face is all dried up. You should be fat, okay, then you are good. This is the problem in our country. Anybody loses weight, maybe he is having cancer, heart attack, and he is not telling. So patients are worried if they lose 5 kg. So though we are happy, everybody is happy, patient is not happy, that is the problem. And I think if it comes not only that, the cholesterol, if you see, at 52 weeks, 6% reduction of cholesterol, triglyceride 22%, LDL 7.9, VLDL1, and HDL increased by 10.8. No drug will increase HDL. Look at this, this is fantastic. So if you lose 5 to 10 kg or 5 to 10% of your weight, I think your cardiovascular risk comes down greatly. Of course, I don't want to targeted therapy for adjunct, that is microbes we are using, all probiotics and all, this is something which will come. This is what I was telling you, results of it. Look at the SURPASS studies, what you will see here. Step 2 key results. If you look at placebo, semaglutide and all, the reduction is great here. This is what you will see at 68 weeks. And these are all the studies with semaglutide. Oral semaglutide is available now, and you can see a great weight loss in these patients 68 weeks. And on treatment, you can see there's a great improvement. So this is what not only HbA1c, which reduced from 8 to 6.5. This is fantastic weight loss you will see. 1.5, 1.6 from 1 to 2.4 milligram. This is once a week injection. Thus, achieving A1C weight loss endpoint, if you look at it, this is something which is great. And look at placebo, semaglutide injection 1 milligram, 2.4 milligram. That's why Wegovy is right now we see it's a great one. The oral semaglutide, all of you have experienced. They thought probably it will make about 50 crores, 80 crores. They made 120 crores in India. Who thought anybody will buy 360 rupees tablet? I think you are mad. Anything 50 rupees, nobody will buy. And you have seen in 8 months that it is something like a blockbuster which nobody expected. And that's why you start with 3 milligram, go to 7 milligram, 14 milligram. We have now more than 6 months of experience. At least 40% of my patients have reached 14 milligram. Everybody will not reach 14 milligram. 40% is very good number what you see oral. And this is what you see how 6 to 8 core defects, whether brain, adipose tissue, liver, are all targeted when you use the GLP-1. This is what you will see semaglutide structure. And now we have got oral. And the most important thing is you should take it in empty stomach with 120 ml of water. Not very small, not well, half a cup of it. 24 clinical pharmacology trials, 9,543 patients, and these are all the trials going on in them. And this is what known as Pioneer 1, 2, 3, 4, 5, 6, 7, 8. I don't want to go into details compared to the monotherapy, Yampa, Sita, Lira, and renal and others one. You will see great reduction in the HbA1c as high as 1.4, 1.6 you will see. And also, you will see A1C from baseline, it can go up to 2.3 also compared to the other sitagliptin and other drugs. So this is what the more than 5% weight loss in semaglutide compared to 10% in the tirzepatide molecule as such. This is the oral one, you will see superior reduction in A1C, cardiovascular safety, and this is what is established. So this is how you must take as soon as you get up in 120 ml of water. Don't have anything 30 minutes, don't take other minutes after the medicines. And first month start with 3 mg. Patient tolerates well, go to 7 mg, tolerates well, go to 14. Patients have already taken injectable, start straight away with 7 milligrams. And most of my patients are quite happy with the drug as you see. This is what I told you, weight measurement, step 1, 2, 3, 4 trials. Some of them have achieved 15% of weight loss from the baseline, which is fantastic. And just like liraglutide, start with 0.25, go to 0.51, 1.7, maximum dose is 2.4 milligram over a period of 20 weeks, or you can say about 2.5 months, 3 months, you can achieve it. Beyond that, you get CV risk factors also comes down, and A1C comes down. This is the summary of semaglutide. 2.4 milligram injectable, not available in India, already approved by DCGA. You will get it next year, and this is the dose. Your safety profile is similar to other GLP-1 receptor agonist. And the last thing is once a week injection, icodec, and you can take it once a week, and by 3-4 days injections you will get a steady state. Hypoglycemia is much less, and as you can see, once you inject subcutaneous, goes to blood vessel, target tissue. It is slowly there, and you don't have to do daily blood sugar. Once a week, once to 8 days, like somebody in the previous talk telling, you can reduce the number of blood sugar tests. Each strip costs 20 rupees. So 3 times a day, testing is more expensive than the insulin you get. To summarize this, we have a lot of drugs in the pipeline next 10 years, but these are 4 or 5 which I think very, very important. Imiglimine, and you have got obetazole, and you have got tirzepatide, and icodec long-acting insulin, and semaglutide oral and injectable Wegovy. And patients and physicians prefer fewer insulin, so once a week will be useful. You can use it only in type 2, not approved by type 1, where it is very, very flexible. Patients have already reached a steady state. So last 3 months, I'm taking 20 units, 40 units, take like that. And it offers better convenience, better compliance, and available data shows they are quite safe. Thank you for your attention. If there are a few questions, I'll be happy to answer.
Yeah, thank you, Dr. Prasanna Kumar, for a wonderful presentation and enlightening us about the newer generation, or probably I would say the emerging therapies in management of type 2 diabetes. And since the time of introduction of the newer generation anti-diabetics, we are not able to address the diabetes and its complication in a proper manner. So, what is the role of iminim in combination with the metformin in our population? Since we know the Japanese, they don't respond to the metformin well. I think probably they're not using at all. So that could be the reason most of the studies is done in the Japanese population. So what is your take? Probably we can consider the first line therapy in combination with metformin?
Actually, I didn't show it because of paucity of time. There is already Indian data of imiglamine with combination of metformin. And it showed over and above metformin, 0.6 to 0.7% reduction of HbA1c good. And also it showed that the safety profile is very good and there is no problem in most of them didn't have. In fact, the gastrointestinal side effects are the only ones you see. It is slightly less than, because 15 to 20% of metformin they cannot tolerate, whereas imiglamine they tolerated better. The only indication, if they cannot tolerate metformin, then you can use imiglamine. Otherwise, start metformin, add 500 mg BD, and after 2 months, make it 1000 BD. The tolerability is good. This is about 700 patients, Indian studies.
So you rightly mentioned about the people, they don't want to see like they're reducing the weight. So like people are coming with a like significant loss of weight with the semaglutide. You know, you have seen like 5 to 10 kg weight reduction. Probably in obesity, we have to treat in toto, you know, in terms of dealing the obstructive sleep apnea and obesity, diet control, and then newer generation oral GLP-1 receptor agonist. So some of the patient, despite of reaching the 14 milligram tolerating nicely, they're not reducing 1 kg weight also. So what could be the probably reason?
Very correct. There are 4 types of response. When you use GLP-1 analog, best response, they reduce weight also, reduce HbA1c. Second, weight comes down, HbA1c doesn't come down. Third, HbA1c comes down, weight doesn't come down. The worst is neither weight nor HbA1c. If somebody says, I have seen everybody has that, you are telling a lie. You are 100% correct. Let us say you give 3 months, doc, I don't find any improvement at all. I am spending 10,000 rupees per month. My HbA1c has not come down 0.5%. I have not lost 1 kg. So every drug in this world has responder, non-responders. We don't know who is a responder, who is not. And I have some patients who are on injectable, very happy, changed over to oral. Worse than that, we go back to injectable. There are patients. I still feel a lot of patients are doing very well with weekly dulaglutide. They don't want to go to oral tablet because it is more expensive. So you have to individualize patient. You are not happy more than you. Your patient is not happy and spending so much of money. I think better to stop and say probably you are the one who is not. But we don't have a marker to say at the beginning who will respond, who will not respond.
Absolutely. Yeah.
Thank you.
So any questions or any comments from the audience? Yeah.
Sir, I should tell the diabetes population, doctor population here, one of the major reasons why I became a diabetologist is you.
Thank you.
Talia bajaye. Now, the question is, how do you stay so reliable, so dependable, and so inspiring?
I think...
I need an answer.
Yeah, exactly. Wisdom comes from experience, right? And experience comes from mistakes. So nobody is a born speaker or anything when you start your career. And somebody comes and says your talk is not good, honest and all. Over a period of time, it becomes easy. Next thing is, when you talk from your heart, you don't need any PPT to kill. If you have an experience, knowledge, it's easy. If somebody gives us, these are the slides, then turn layer 20 minutes and then say anything like that. So turn to see that what's your experience and have you understood the concept. If you yourself has not understood, you will not be able to convince others. Sometimes they come, I think today your talk, you yourself are not convinced that it's not good. Somebody honestly gives that, you know your heart and mind is not in that topic, you just come and give some topic. So all of us can come to some extent, but everybody cannot be a born speaker. There are some people I have seen in my lifetime, nobody can beat them. One of them is Bajaj. How many people in this have heard Bajaj? Outstanding speaker in my lifetime. And whether he speaks to a nurse, undergraduate, postgraduate, or Indian Institute of Science professors, he comes so prepared. I will target Shekhar. He will rip you apart in that meeting. So that, I mean, it's other way of doing it is no more. So I think all of us have to learn from others. If you are a good listener, others, how good he is speaking, and you can learn. Otherwise, come here, okay, my talk is over, I'm rushing away, then we are not a great learner from that. Yes, Dr. Sidney.
such a humorous talk from a serious looking person. And that says all about Dr. Prasanna Kumar. And those thought-provoking talk, I'm just wondering, do we really practice the right diabetes practice as on today? Because the hemoglobin you put it looks like a panacea for all our problems. Such a wonderful drug. After that you came with other drugs as well. Now my question is, among these drugs, which one do you prefer? Number two, secondly, insulin is thrown away into the gutters. Number three, were we practicing all wrong medicine till today? These are my questions.
Thank you. 40 years back it was easy. You had only two drugs, metformin, sulfonylurea. You didn't have anything. Today you are spoiled by choice. You have got after metformin 10 drugs. So the question comes, which is second? And EASD, all guidelines says patient choice. First you say, this is the drug, it's a tablet, it's an injection, this is the doc. Don't tell me that I can't afford. So a patient choice is always the best. And tell them this is the cost, these are the side effects and all that, then he will choose. I don't say any drug is panacea, including today metformin is still the best drug. After that what? You have got 20 choices including bariatric surgery and all. I think in every patient, when the patient is sitting in front of you, in that 30 seconds, your 40 years of knowledge, studies, whatever it is, in 30 seconds you have to decide, is this the best drug for him? And tell the patient this is what it is, and patient accepts it, fine. He comes back after 3. Every day I get 2 calls, you gave me this drug, I had nausea, vomiting, tablet is coming in this stool as it is. What do you say first thing? Yes, it could be side effect, please stop. If you try to insist, no, it's very good drug, continue, he'll never come back to you. So I think patient acceptance is the best what you see, and there is nothing like one prescription for all. Let us say you take 10 consecutive patients, it will be 10 different things. Why in this patient in 30 seconds you have to say he is overweight after metformin SGLT2. He is not overweight, I will use gliptin. I think this patient has so much of weight, I think he can afford, I will say GLP-1. I think I use all the drugs, but ultimately when I look at the patient, I know him 5 years, 10 years, I offer him, tell him these are the side effect, cost of it, let him decide. Most of the patients say, Doc, don't worry about it, I don't bother the cost, give me the best. Then you have got a choice, whatever you think best. Whether HbA1c reduction, cardiovascular safety, renal safety, taking all this today, I got few drugs. Certain drugs might not have gone CVOT trial. You don't know they are cardiovascular safe, renal safe. Probably in such patient, you don't use those drugs. Very good. One thing is, guidelines are only guidelines. Guidelines are not a law. Guidelines are for MBBS, not for you. Dr. Govindappa with 50 years of experience does not need any guidelines. So guidelines is only, and even in guidelines, if you look at it, what is it? Hardly 30% have level A evidence. Do you have level A evidence? No. 60% do not have level A evidence. Guidelines is you have to walk like this. What happens if you go, you can go in this way. I think it is better you walk that way. That's all what it guide. Don't think that, and who is it that is making guidelines? He is not any Brahaspati or anything. It's not Bible, Bhagavad Gita or Quran or anything. And many times people don't believe the guidelines. Guidelines are only a guidelines, not a law. Your wisdom, I think with 40 years of experience, better. You don't have to go a guideline, follow page 1, 2, 3, 4. I don't think it is necessary. It's a first MBBS students, sir, I don't have experience, so much knowledge. Then a book is taken, follow the guidelines. That's all. Beyond that, don't give so much of importance to guidelines. Yes, sir.
What is your experience with these drugs?
If you ask me, I have just started them. I don't think I can say today after 1 month. Some of them have been introduced 1 month. You can't say my experience of 5 patients, 1 month, what happened. Whereas semaglutide, I have more than 50 patients. It is good, as you said. It works in some, doesn't work in others. Other 2 drugs, icodec and trizepamide, I don't have any experience. Only semaglutide I have. And lopeglitazole, I don't have the experience. I have just started. So also imedium. See, best thing is to use 5 patients. Wait 3 months. He comes back, you are happy, patient happy. Unless you have own experience, whatever you read, I don't think you can make any conclusion out of it. And why today metformin and others you have used gliptin, SGLT2, your own experience. I think Dr. Mano is getting restless. Okay, thank you.
Sir, sitting here on the podium, being a part of the session as a chairperson, we thoroughly enjoyed your session, and of course, we completely agree with you that orator skill is a very important skill for a doctor, for patient communication, as well as for having wisdom. It is important to communicate to the juniors and fellow colleagues. We highly appreciate your session. Thank you very much.
And just before we conclude, just congratulate Dr. Manohar, Dr. Shekhar and Dr. Vijay, Dr. Sanjay Rao for having the fantastic KRSSDI feast over here. Thank you.
We'll take a clap.
Sorry for the delay, but sometimes it's out of hands. We'll move on to the next session, co-formulation insulin in Indian realities, from published evidence to practical experience. To speak on this, my good friend Dr. Faraz Farishta, endocrinologist from Hyderabad, and to chair, I would call upon Dr. Vishwanath K. and Vishnupriya Reddy onto the dais, and over to Faraz, and I'm always the villain, and I will request you to be crisper than usual.
Thank you so much, Dr. Manohar and the entire KRSSDI team for inviting me for this. And I see a lot of journal, and I would say very enlightened and energized faces. Thank you to Dr. Prasanna Kumar, sir. I think I just missed him. But he has done the right dose of caffeine in all of us. We all needed that. So I think I will continue with that and boost my presentation. So these studies, we've always seen that, we all know that higher the intake of carbohydrate, the more risk you have of developing diabetes. And these are the two studies which have already shown. The PURE study, again, which said more the intake of carbohydrate, the more increased risk you have. And the START study, which was done across pan-India. Most important thing which I would like to highlight here is, unlike our Western population, where we always feel that once we get down the A1C, there the role of PPG becomes more important, and there it becomes very prima facie that we control the PPG. But in Indian populations, I would say, हम लोग हैं अलग अलग, हम लोग हैं जुदा जुदा. That is how it is. We are different. In every ways we are different. We carry a central obesity. So it is very important for all of us to control the fasting. It is very important to control the postprandial as well. So there are key issues when we practice in India. Primarily, first, across all the zones, if you will see, first is the high intake of carbohydrates, the central obesity, delayed insulin therapy. I think this is where it is hitting us very, very hard, that the inertia to start insulin therapy. My senior colleague was saying two drugs, 3 drugs, 4 drugs, but again, it's very easier said than done. Probably, I think it's time that we all are learning from it. And need for simple and convenience. I think whenever we talk insulinization for our patient, the first thing we see is the startle on their face or their attenders. I mean, we've seen that a number of times. Even if the patient is not astonished, the attenders start getting that fear. So we need something very simple. At the same time, we need something which will help us to control both the fasting and the postprandial. So which insulin regimen can address this? So before going to that, how many of us have watched the T20 World Cup this year? Oh, lovely. So we have a lot of hands in the air. This tells us 2 important things here, that with a great batting lineup, you can win a match, but you will not be able to win the final, or you will not be able to win the tournament. Again, same thing. With a great bowling lineup, you could reach to the finals, but you will not be able to win the tournament. So what does it tell? It tells that the better team, which had more all-rounders, had batsman and bowler and an all-rounder, won the tournament. So in our journey, in our war of getting control of diabetes, we will need a player. We will need somebody who would not only help us to control fasting, but postprandial as well. So when we talk about insulinization, I think a decade before where we all started this, fix the fasting first, where the concept came of basal insulin. Does your basal insulin answer these questions? Is it suitable for your high carb diet? Does it has any effect on PPG? Is it suitable when you are delaying insulin therapy, and whether it gives you once daily control? Your answer is no. So do we need something else? Yes, to answer this, we have the co-formulation. I think I do not need to speak much on that. It is a co-formulation, it is not a mixture. Remember that two drugs maintain their individual PK/PKD profile. That is very, very important, and that is the beauty of the drug. There is 70% of ultra long acting and 30% of the short acting. So what does the short acting does? The short acting helps you to control the postprandial rise, and the long acting helps you to control the fasting and moreover. So this is what is saying that once you give it once daily before a major meal, you control your postprandial spike and fasting. So this is a head-on study which was done once daily of insulin degludec aspart compared with the basal insulin glargine 100. You will see there was a better and superior A1C, 1.4% more reduction in A1C and similar fasting plasma glucose control, which is very, very important. And we all know that PPG rise itself has its own problems. It can cause endothelial damage. It can lead to all the increased risk of developing micro and macrovascular complications. So IDEC ASP is one drug which will help you to reduce your postprandial and fasting blood glucose. This is the SMART study. Again, this is a study which was done in India by my senior colleagues. Adults with diabetes, where the participant received the IDEC ASP, the data was collected at 0, 3, 6, and 12 months. It was a multi-center, so it was spread well across the country, and the key inclusion criteria were the sugar control, fasting, postprandial, and A1C. Here you will see the A1C reduction was around 1.8% in patients who were on insulin treated, and on oral anti-diabetic drugs, it gave you an A1C reduction of around 1.7%. So if you see the fasting plasma glucose reduction, it is around 50 milligrams. The postprandial, again, is the very important component, especially in a country like India. Here you will see it is 74 milligrams per deciliter. When you're starting a drug like this, one thing which will come to your mind, whether I am putting my patient at increased risk of hypoglycemia, the answer is no. So this study, you will see clearly said there was reduction in the number of hypoglycemic events before the start of the study and after 1 and 3 months. The main reason again being the less amount of dosage of insulin required to control the sugar levels. So insulin IDEC ASP is a very simple and convenient solution for all our diabetic patients. It can be given once daily. You can give it with the major meal. So you can give it for lunch, you can give it for dinner. It gives you a lot of flexibility, especially I would think a state like Bangalore, where more of the IT hub is there, where you do not have your patients maintaining that timing. I think we're doing that same in Hyderabad as well, nevertheless, but it gives you a lot of flexibility, 6 hours plus or 6 hours minus. That's a huge amount of flexibility you get with insulin. You can give it once daily. How do you monitor it? So if your fasting target sugar is above your target, you keep on adding 2 units every week. If it has reached the target, you continue the dose. If it is less than that or less than 100, you reduce the dose by 2 units. So where do you use the IDES-CASP in a diabetic patient? Use in patients where you are failing to achieve the A1C, where you want a good postprandial control, where there is increased risk of hypoglycemia, where there is a severe glycemic variability, and where you really want the flexibility in the timing. So to summarize, high carb and high PPG levels are the major problem of type 2 diabetes in our country. IDEC-ASP once daily is a very simple solution for that. And we have a lot of analysis, we have real world evidences, datas. I've been a part of 3 trials, even one trial which was done during the period of Ramzan as well, where once daily compared to the other premix insulin, it did show that the incidence of hypoglycemia was very less. So to end it, at the end of the year, I would still say we'll just continue with the World Diabetes Day theme of the IDF, diabetes, education to protect tomorrow. If we not do it today, then when? Thank you so much. And I'm sure, I don't see Manohar here, but I'm sure he's going to be very happy with this.
Thank you for the wonderful talk. In fact, even I was about to say that, right? It was crisp and you finished it very quickly. But, you know, in spite of so much of advancement, in spite of, you know, we having such good devices, still you will agree that there's so much of resistance to, you know, insulin. And, you know, with this flexibility, I think people are more accepting and able to take compared to earlier that half an hour. So,
one of the slide you said indication after adequate use of other insulin non-optimization, then you start, or can you start it as the first line? Because,
now when we are talking,
that was the first indication you had put, that after other.
Yeah, see, that is why I said a decade before, when we used to talk about insulin, I think all of us loved basal insulin. Yes. If I had to keep my hand here, and in my last more than a decade of journey of practice, if I have to talk, if I have to sleep well, my patient has to sleep well, it has to be basal insulin. You are not worried about hypoglycemia. But now we have learned that in that journey, we are missing that good glycemic memory.
Yes.
More and more inertia is there. So you start with basal, you intensify, it takes real time. So there you are putting your patient at lot of risk of developing micro and macrovascular complications. We do not want that. I think now the guidelines are saying that intensify the therapy, start it early. So maybe after metformin therapy, if your patient is having a higher A1C as the guideline says, 9% and above with osmotic symptoms, then definitely, because again that slide, if you will see the Moiner et al., where in Western population, the PPG control was important when A1C was reaching the target. But unlike in India, where you want PPG and fasting to be under control. So if you want a once daily therapy, you're trying to look at the PPG, especially if you come to Hyderabad, we can't live without biryani. So what do you do about that postprandial rise? Similar in, I would say, Karnataka or anywhere in India. So when you're looking at both, you can start it initially with 10 units and then escalate the therapy.
So yesterday, I think in paper it came, Indians had ordered 2 biryanis every second. So that was the, I don't know, in Times of India it had come.
Most
so I think all the more IDAG is needed.
I'm sure Hyderabad was topping the list.
Yeah, definitely. Thank you. Any comments? So Dr. Shekhar sir is here. We would love to listen to your comments.
About biryani and the postprandial rise.
He said IDAG-SP is one indication, you know, when you eat a lot of biryani.
Please.
Anyway, we are a close-knit family now, not many around. My opinion about IDEG is it's probably the best. Just for the sake, not just pharmacokinetics and pharmacodynamics of the drug, put together my personal experience. I've been using Novo and I've been screaming at them for all the stupid information they come with, pre-mixed fast-acting insulin and all that. But the paradigm shift happened when I had difficult to treat type 2 diabetics. I put them on IDEG, and now IDEG-ASP let me tell you, the so-called blood sugar control was pretty good, but much more important than were two things. The first one was hypoglycemic episodes. My patients on insulin were a little bit worried about hypoglycemia because you should go through hypoglycemia to know, isn't it? That's what we tell. The second one was weight gain. With insulin therapy, you have no other choice but to tell your patient you'll put on weight. But with IDEG and probably IDEG ASP, I have not had that. So I could probably talk about pharmacokinetics and dynamics, that it's steady state. You give 10 units, after 4 days, 10 units come out. So there is hardly any reliability component of, glargine or whatever it is. The second one is weight gain, which everybody says is a done deal with insulin, has not occurred with IDEG. 5,000 rupees, please.
Absolutely, sir.
That is on the guy on the table, sir.
Sir, in fact, personally, when in my practice, what I saw, from basal bolus also, I was able to switch it to IDEG ASP with 2 doses. Instead of 4 shots, the person was taking only 2 shots. Then weight gain also was definitely much lesser, and she was very happy. Smooth control.
And then compliance improved significantly.
Compliance, she was so happy. 4 shots came to 2 shots, and that was possible with this.
Thank you, Dr. Farishda. It was excellent. As she said, very crisply summarized the thing. Thank you once again.
Thank you.
Thanks. We'll just have a snap. So, penultimate talk. I don't know if I am growing old, finding difficult to focus. Anyway, pioneering the upstream approach in diabetes management with oral semaglutide. I think we had some interesting pointers from Dr. Prasanna Kumar on this to speak. I would invite the chairpersons, Dr. Sanjay S. and Dr. Sridhar. For chairing this session, speaker is Dr. Jay Prakash, consultant endocrinologist from Kochi. Chairpersons to take the stage. Over to the speaker.
Yeah, I welcome Dr. Jay Prakash. So please continue.
Thank you. Thank you, respected chairpersons. Let me begin by thanking the Karnataka KRSSDI for giving me the opportunity to talk, especially Dr. Vijay Kumar and Dr. Manohar. It was a well-attended conference, and it's glad to be back in the physical form. So I'll be talking on the diabesity and the role that semaglutide has played in terms of managing this. Actually, Dr. Prasanna Kumar's talk has made my talk much easier. He has covered most of the salient aspects. I'll just add some icing to the cake that he has already served. The burden of diabesity is something which I think we are still underestimating. Again, the data which paved way for the diagnosis of obesity, bringing down the BMI to 23. Even with that, now again, Dr. Prasanna was telling about making it to less than 20. That's what the obesity starts with. But then even with this data, there is an increased all-cause mortality. When a patient has diabetes and a BMI of more than 23, there is a 7 times increased mortality rate. So this kind of twin epidemic that we are facing is, there are various terms by which you describe this. Adiposity is one of those, where adipose tissue is at fault. Adipose tissue is actually now considered as the largest endocrine organ. There are so many chemicals coming out of it, which some of them are harmful, some of them are protective like adiponectin, but most of them are harmful, and most of this actually kind of drives the pathway of insulin resistance and cardiovascular risk and ultimately lead to diabetes. So the complications due to increased body weight, we know the cardiovascular complications, the micro and macrovascular complications, but the non-cardiovascular complications again go with that. Depression is commonly underestimated, obstructive sleep apnea, then the osteoarthritis, which is again debilitating. All these things are associated with obesity. So what you mean by this upstream approach is that when you reach the downstream, where already the complications of diabetes, the vascular complications are set in, there is a limited scope for our intervention. But when you travel upstream, when you try to catch the adiposity or adiposopathy and obesity, we will try to prevent these downstream complications. That's what we are trying to do. So this weight-centric management right from the beginning would help to not only to prevent the diabetes and the vascular complications, but it kind of disrupts the underlying mechanism so that people won't develop the complications. Weight loss as part of diabetes prevention program. Diabetes prevention program or DPP trial is now 2 decades old, and it's shown that weight loss is one of the most effective measures by which you can prevent diabetes in somebody who is obese. So even a 5 kilogram of weight loss actually would help to prevent diabetes onset in people who are at risk for diabetes. What about weight loss and diabetes control? Somebody who has already had diabetes, again, we have seen people losing weight, 5-10% of their existing body weight. We know diabetes reversal programs, and one of the trials which have shown in terms of reversal of diabetes or diabetes remission is the direct trial. So as you see, the greater the weight loss, less than 5, 5 to 10, more than 15, the higher the remission of diabetes. So we are talking about cure of type 2 diabetes once you have the weight loss. But weight loss in terms of achieving this is always a problem. There are various methods. Again, orlistat is one of the drugs which is approved, but we know in our setting it may not be that helpful. Liraglutide, semaglutide, and naltrexone, phentermine, topiramate combination, all these are approved drugs. But we'll see the evidence with these drugs, how it translates in terms of our management aspect. So there are certain unmet needs in weight loss therapies. One is the sustainability of weight loss. We have seen patients losing weight and then regaining this weight in the long term. So a drug has to have a long-term sustainable result. In quality of weight loss, we need to have adipose tissue or visceral adipose tissue to lose, not the muscle mass and the other bone mass. Effect of concomitant anti-diabetic medications should also be taken into account. So when you're trying to address this unmet need, a molecule which can address this gap is again GLP-1 receptor agonist. How it addresses the ominous octet in multiple pathways we have seen, how it improves glycemic control and with the risk of minimal hypoglycemia, the cardiovascular benefits. Among the drugs, it's the GLP-1 receptor agonist which stands apart. And when you talk about oral semaglutide, there is a significant weight loss. Dr. Prasanna was talking about that. The mechanism by which is with the hypothalamic areas. The satiety centers are where the communication between the hypothalamic satiety and the appetite centers in terms of the molecular level has been now elucidated. So the trials have shown that semaglutide predominantly affects the fat mass. So if you see among the out of this 2.7 kilogram on either side, it's the fat mass which is lost. Out of that, the 2.6 kilogram is the fat which is lost, and that's what we want. The pioneer trials in terms of achieving the A1C goal, you have 3, 4, 7, and 14 milligram of semaglutide. The higher dose of semaglutide, 7 milligram, achieves the maximum glycemic control with maximum amount of weight loss. And this is sustained. You see the results up to 36 weeks and 26 weeks and 52 weeks. So more than a year, you have sustained weight loss, which is again significant. I think Dr. Prasanna touched upon this slide where the change in body weight is compared to other drugs, it is remaining. And over time, even these are trials which have got more than a year, 1.5 years, 52 weeks of trial results, we have had significant weight loss. Even on top of the existing drugs, even on patients on any of the other anti-diabetic medications, be it empagliflozin compared to sitagliptin, compared to liraglutide 1.8 milligram, the blue bar actually falls down the maximum. You got maximum weight loss with oral semaglutide 14 milligram. even on top of the background medications. So regardless of whatever oral drugs they're on, regardless of whether they are on insulin or not, semaglutide achieved significant weight loss. So the change in HbA1c, again we are talking about anti-diabetic medication, the change in HbA1c is also preserved compared to placebo, compared to liraglutide, oral semaglutide, again the 14 milligram dose achieves significant reduction. So this has made the standard of care. We know the cardiovascular risk reduction, and the weight part is also mentioned in this. So the aim is to promote weight loss and have minimal weight gain. It's the GLP-1 receptor agonist, which is the preferred agent. So let's end with the patient profile. A patient named Pavan, who is an average youngster, a relatively young patient coming to our OPD. 46-year-old software engineer, so obviously we are talking about sedentary job and snacking and other things. He is already obese. The BMI is 30, and he kind of doesn't follow the lifestyle as advised. He's got a strong family history of cardiovascular disease also. So he was initiated as per the standard of care on metformin, diet and exercise. But what has happened is that he has progressed. We'll see that we allow him to progress, and 3 years later he has come back with this. Again, if you see his lifestyle modification is rather poor. 2 to 3 times a week for 20 minutes. This is hardly the exercise that we advise. And look at the treatment regime. He has gone up with the glimepiride 4 milligram once daily. So metformin plus glimepiride. So this was what was practiced probably 3 or 4 years before. And over the past 3 years, he has had weight gain and hypoglycemic episodes on the background of his cardiovascular disease. So this is what happened after 3 years. So from 88 kilos, he has made 91 kilos. His HbA1c is remaining uncontrolled. So we have made a treatment decision at this time where his A1C has grown over years of, and then he was added a GLP-1 receptor agonist and statin was added. So yes, it has yielded result. His HbA1c is coming down. It has reached the target of less than 7 over years. But what has happened is that he has already had the risk factors which have driven him downstream, as the pathway shows. So this is after 3 years of adding a GLP-1 receptor agonist. He has achieved weight loss, 91, he has got 78 kilos. His targets have improved, he doesn't have albuminuria. But see, what has happened is that he has already developed cardiovascular complications. At that time you are intervening, and probably we are doing good. At least at that time we are intervening, and we know GLP-1 receptor agonists and SGLT2 inhibitors actually prevent further complications. But already he has had cardiovascular complication. But what would have happened if appropriate measures, like what we are talking about, the upstream pathway, if we had added effective drugs which would had help him to lose weight, like oral semaglutide, we know how effective it is. So apart from metformin, diet and exercise, if oral semaglutide and statins was added at that time, it would have had prevented his cardiovascular disease onset and had better result in terms of preventing further complications. So this is the upstream approach that I think we should start doing now, where we are not allowing the patient to develop complications or increase in the risk factors, as the guidelines have suggested, high risk for ASCVD and high risk or already had an event. We shouldn't wait for that. We shouldn't wait for an obese patient to develop that, and we should allow him or give him the benefit of GLP-1 receptor agonist. Now that oral semaglutide is there, it works well in these kind of settings. So I would end here by summarizing that the complication, the twin epidemic of diabetes we are facing, and managing high body weight right from the onset, right from the pre-diabetes state itself is important. And it's an upstream approach that we should try to follow. We should try to follow this and try to prevent these patients from going into, in terms of the higher cardiovascular risk and cardiovascular event probability. And oral semaglutide has made a path-breaking change in terms of that, where we help the patient to achieve this weight loss with an improved cardiovascular risk profile and safety profile. Thank you.
Thank you, Dr. Jayaprakash. Anyway, it was a wonderful talk. Anyway, semaglutide is a very promising drug. I think in future it will be definitely a good hormone for the diabetic treatment.
Thank you, Doctor, for this excellent presentation. So, running short of time. Delegates, any questions? You can please ask the speaker. If there are no much questions, we'll end this session now. Thanks for this.
Thank you, speakers and chairpersons. So, next talk will be by our dynamic speaker, Dr. K.N. Manohar, who is going to speak on decoding and preventing CV events in dyslipidemia management. So for this, I would like to invite chairperson as Dr. Subrata Das.
Well, I'm the last man standing. Dr. Subrata Das, you want to make a comment before I start?
Dr. Manohar, first of all, congratulations to you for wonderful organizing a scientific program for us today. We are eager to hear you. Over to you.
Thank you. Well, cardiovascular disease, as we all know, is the major cause of mortality worldwide. Some points I would like to make. We traditionally do a fasting lipid profile, but even a non-fasting lipid profile has equal or even more importance. Even the Lipid Association of India guidelines says, if you do once the fasting, on the follow-up, you should do the non-fasting. Because most of the time we are in the fed state. Especially we start having a late dinners, we are almost always in the fed state. So non-fasting has a role. And a lot of data is coming in that non-fasting could be better reflector of mortality. I wanted to keep it short, but not this short anyway. Non-HDL cholesterol is emerging as an important entity. So I always put this points to ponder, whether we really look at fasting and non-fasting. And most of the time, dyslipidemia management is based on ASCVD risk reduction. We moved away from just looking at the lipid. Rather, we are looking at ASCVD risk reduction. But if you look at the guidelines, it all is based on calculators. So do we really use the calculator? But actually, there is only one indication where you need to use calculator when is a younger patient and a non-diabetic. If he is a diabetic, almost always we give the statins. And if someone has a secondary prevention, no question, statin are the #1 drugs to be used. So there is always a minor difference only too in the triglycerides, where you can see 26 milligram per deciliter difference versus fasting to non-fasting. It also depends on what food we ate and how long after the food it was measured. And interestingly, the fluid intake also determines the HDL triglyceride level. Otherwise, if you look at the total LDL and non-HDL cholesterol, it will be showing slightly lesser than in the non-fasting state. Dyslipidemia, we all know, is a major concern, and very important point I would like to highlight is very high risk group has been formed now, and they are looking at targeting LDL of 50. Or someone had a coronary event, secondary prevention, and is a high risk or a second event, then you need to look at LDL of 50. So iceberg is always shown in all diseases. We are always treating the tip of the iceberg, and we are not looking at the base. And definitely, even though we have seen good LDL levels, means less than 100, sometimes still people have ASCVD. So what is the residual risk? Even after statin treatment, if you look at the left of the screen, 77% unaddressed residual risk is always there. So coming to the molecule per se, bempedoic acid, adding bempedoic acid to statin therapy, or using the bempedoic acid in statin intolerant patients. The first group is what we need to firstly look at is people, if you look at the bottom half of the screen,
Clear Serenity and Clear Tranquility are the two trials which used bempedoic acid in people who are intolerant to statin or who didn't tolerate maximal doses of statin. The top half, Clear Harmony and Clear Wisdom, are the two trials which were used independent of the statin therapy. So what is the difference between this Clear Harmony and Clear Wisdom? Clear Harmony was safety-oriented trial to look at the side effects. Clear Wisdom was efficacy-oriented trial. And in both, you can see around 15 to 16% LDL reductions were seen. So percentage change from baseline to week 12 in LDL, because we are looking at the efficacy, is about 15 to 25% in different group of people, is the efficacy of bempedoic acid with respect to LDL therapy, LDL reduction. So in all, what they showed is clinical trials have shown that bempedoic acid monotherapy or in addition to background lipid-lowering therapy lowers the LDL cholesterol, non-HDL cholesterol, and it has some effect on the ApoB and HSCRP to an extent slightly better than what statin does. So where does it act? It acts, simple way to remember is we all know statins are HMG-CoA reductase inhibitor. 2 steps above that is what bempedoic acid acts. One important highlight, what we need to look at it, I don't know if the pointer is working, it won't not, is onto the left of the screen here, AMPK activation. We all know statin-associated diabetes or NOD, new onset diabetes in statin therapy, is a problem. Where bempedoic acid scores over statin definitely is, it possibly has a better effect on the glucose by AMPK activation, where metformin also possibly acts, and it has a favorable effect on reduction of the glucose, as it's shown on the top of the left extreme of the screen, reduction of glucose. That is one point which we need to remember. So again, Clear Serenity and Clear Tranquility are the two trials. They are both efficacy trials. Serenity trial was against placebo. Tranquility trial had an arm with bempedoic acid plus ezetimibe. The other arm was placebo plus ezetimibe. So we are trying to look at the efficacy individually of bempedoic acid and with ezetimibe how it does. If you look at the number of patients in this trial, study group was much less, but it is heartening that it reduced the LDL cholesterol by 23 units in both studies. So Clear Serenity was versus placebo, Tranquility versus plus ezetimibe plus minus the drug. So if you want to look at the overview of bempedoic acid, Harmony and Wisdom and Serenity and Tranquility are the 4 trials which are there, and heartening to know it has been approved by most of the regulatory bodies, US FDA, European Association, and it comes in 180 milligram of tablet, and it can be taken once daily irrespective of the meal. The much awaited Clear Cardiovascular Outcome Trial, it is the CV risk reduction trial. We know CV outcome trials. Statin is one of the important drugs to reduce the CV outcomes. Bempedoic acid, very, very recently, few weeks back or few days back, this trial results were out, and it reduced the 4-point MACE. So that is one big highlight about this molecule, that in the future it could be very, very useful in people who are intolerant to statin or who are having a load, not tolerating the full dose, then you can add on. Or I feel another area is IGT, people who are on IGT, and if this has shown some benefit with respect to mortality reduction, instead of using statin, can you use bempedoic acid? That is the reckoning question what comes. But of course, there is a huge amount of data with respect to, I'll skip this slide, amount of data with statins. But there is some controversy. Statins were always controversial molecules, even though we have used it for decades. That is because of the 28% increase in the risk of developing diabetes with statin therapy. That was shown in the Jupiter trial. So that is where bempedoic acid scores over the statin, that it is glycemic friendly, helps reduction in LDL, and most importantly, the Clear trial has shown that it reduces the CV outcomes also. The 4-point MACE reduction is significant. Thank you.
Thank you, Dr. Manohar, for a wonderful talk. So I think this will be very useful to us in patients who have diabetes, particularly with statins causing some amount of hyperglycemia. And many people don't tolerate, say, rosuvastatin more than 20 mg in among Indian population. LDL more than 100, that forms an important.
Yeah,
Rightly so, that residual risk reduction still, if it is looking at, this could be a good add-on therapy. And then, of course, if you are looking at IGT, people treating for dyslipidemia, with the CV outcome trial in a positive trend, I think we can think of using it.
Another thing will be to look at how it is helpful in our non-alcoholic fatty liver diseases.
I don't think we have any data as of now on NASH. We'll think
Who
about
knows?
that.
You can always do some study to find out.
Sure. Sir, can you get the mic, please? Or you can come forward, sir.
Sir, some of our patients are showing a lot of high triglyceride levels. Although LDL is normal, HDL is normal, triglyceride will be high. What about this drug on triglyceride level?
A very good question. Triglycerides in itself, treatment, actually we over-treat it. LDL cholesterol is the first thing to look at it. If it is coming into the high risk range, more than 100 now is the guidelines, or if there is no other major risk factor, more than 160, definitely treat it. Triglycerides alone, if you look at the indications for treatment, if it is more than 500, we need to treat, more to reduce pancreatitis. Between 250 to 500, if the HDL level is very low, there is some benefit. Again, it could have been a debate topic on how triglycerides are useful. If it is 250 to 500 and HDL is very low, then there is an indication for triglyceride treatment. Otherwise, triglyceride treatment has not shown to improve mortality. Yeah, that's what the new trials have shown. If the rosuvastatin is stronger. Yeah, that's why we need to monitor it and titrate it accordingly. If that is the case, previously we used to stop it. Now we can think of adding or substituting bempedoic acid in such cases.
Actually, even in patients with fatty liver disease who are on rosuvastatin, you would give them vitamin E and acetylcysteine, they actually do better. And sometimes if you're worried about triglycerides, low HDL, saroglitazar has shown some useful.
And what about this established atherosclerotic cardiovascular disease, or probably patient coming with a acute coronary syndrome or post-MI for stabilization of the plaque, despite the LDL may be normal or maybe only...
No two things, statin are the number one drugs. So please don't go away.
No, somebody is not tolerating the high dose
not
of statin.
Not tolerating, yes, definitely
so
we can.
There's a role of the plaque stabilization and those
Actually,
conditions.
the Clear Harmony trial was used with a lower doses. Some people couldn't tolerate, the lower dose was rosuvastatin 5 milligram, only they could tolerate. On top of that, adding bempedoic acid showed a significant reduction in the LDL level.
So probably low dose of statin and then this,
and then bempedoic acid. Or if someone is not tolerant at all, I don't think so many cases we see. I have used only one prescription till now. And Prasanna sir said wait for at least 5-6 prescriptions to know what it
So
does.
probably cardiologists are going to give the input for that, acute coronary syndrome cases. Yeah.
All right.
Perfect.
Yeah, this is a small trial which has shown the CV outcome results. Statins have been there for decades together, and one of the number one drugs to stabilize plaque and reduce the secondary prevention after aspirin is statin. So with the wealth of evidence, we should not just deviate from it. Let it prove its worth. Again, we have said it started all with people who are intolerant to statin or not tolerating the maximum dose which you recommend. So that is where it is. It is not the number one drug to be used, definitely no.
Okay, there are one or two odd things. If I don't know how many of you use the ACVD estimator, but if you see that, it's always from 40 to 75. So if somebody is less than that, you don't know what to do. If you have a risk factor like a diabetes and all, there is no question about it.
True.
So, but otherwise there's a hitch there, number one. Number two, just to explain, the potency of each statin doubles. Lovastatin is considered as 1, then simvastatin is 2, then atorvastatin is 4, then rovastatin is 8. So it's almost doubling. Second thing is that the metabolism of rosuvastatin is different from atorvastatin. So if you find that the enzymes go up after using atorvastatin, you can switch to rosuvastatin. Am I clear?
The lower potent statins have lesser side effect on the liver, in short, if you want to get what sir is saying.
That is the important thing you must know. And there is the question of having myopathy is a myth. It is not true. If you read any Harrison, Cecil, any book, you will find that there is something called a nocebo, where they say you tell them there's nothing going to happen, you will have, patients will have no problem. But if you tell the patients, look for hepatitis, look for myopathy, look for enzymes, check the CPK, they will come back with you. This is the experience I have had. So you don't tell them anything, look for cataract and say you may develop diabetes. But be careful, when you say you may develop, that's a deterrent. Okay? See what I...
If you are in the target, you don't have to switch over the statin therapy at all. It is same as for atorvastatin. I don't think there is a different indication.
See, the book again says that you can use up to 40 milligrams of simvastatin, that you should not use. You can use up to 40 milligrams or 80 milligrams of atorvastatin. But when you start going to higher doses, it's better to switch over to rosuvastatin because the metabolic pathway is different. Then switch to see, this myopathy is a class effect. It is not a single drug. Okay, so 95% of the time it's a nocebo. You tell them nothing will happen, nothing will happen. This is, I'm not quoting my, you read Harrison, you read Cecil, it's written there. Then you switch to rosuvastatin and see. You can use ezetimibe. You can use ezetimibe, which is not so potent. This is too new. It's a new. It's very new. So we don't. There's a saying which I have always quoted: when a new drug comes, wait. Don't. I will use it for everybody. Then after 5 years, effects will come. I will not touch it. It could be now Japan, Korea, US, Europe. Please remember, US FDA is the strictest of all. After the thalidomide tragedy, the US FDA is the most strict thing. Now the European Medicine Agency, EMA, is equally strict now, but still the FDA is the strictest.
Over to him.
So I'm not going to leave Dr. Manohar so easily. So he keeps troubling all the speakers with questions. So
I don't think so.
So some comments, that's all.
Sure.
Uric acid, you didn't touch the uric acid. Bempedoic acid, only known problem is with uric acid. Tip of the iceberg, we keep talking about the tip of the iceberg. Any tip in India is bigger than Madagascar. So we should remember. So there is no tip in India. So how much non-fasting is you are going to check the lipids? Say 1 hour after the meal. What is the quality of the meal? Because for diabetes, we say 2 hours after whatever is a balanced meal, we check it. So if you are going to check non-fasting state, so
it is irrespective. There is no time limitation for that. What Lipid Association of India says is, once you do fasting, next time you do random.
It's a random.
Yes. I think the general advice is, don't modify or do something to your diet because you're going to do the test. Okay, do what you have been doing regularly.
After regular meal.
Regular meal.
And ASCVD is not relevant. We cannot say it's not relevant because we have, particularly being in Bangalore, every second patient comes with a big health checkup brochure. So they don't have any other problems. They come with only a abnormal lipid profile. So those patients, it helps us make a decision. So ASCVD risk scoring is very important for those patients. And good session to end. Wisdom, harmony, serenity, and tranquility. So I think
I think it sums up the day one of KRSSDI. I'm very, very thankful to everyone. Late in the day, and we started quite early, and then most of the sessions were jam-packed. It can't happen without the delegates being present. I can see a few of my students, but I can promise that I have not threatened them that they have to be there, but they are there. Thank you so much. Thanks for the chairpersons and everyone for making it grand success. I would invite everyone for a unique mind and body workshop. I've been telling it throughout. People must be bored by listening to me. 7:30, 7:45, be here and experience the difference. And tomorrow also will be interesting, and I invite everyone to come back and join us tomorrow. And we will have AGM in 15 minutes downstairs.
Thank you. Thank you, Doctor.